So I'll be discussing the role of systemic therapy in the management of locally advanced carcinoma and nasopharynx. No, this is not the one. Okay. I have loaded there, okay. So anyway, carcinoma nasopharynx is a very unique malignancy because of its clinical presentation, staging, the treatment, response to treatment, and pattern of relapse. Yeah. Sorry. The stage 3 and stage 4 constitute the locally advanced carcinoma nasopharynx. Stage 1 is T1N0. It is treated by radical radiotherapy. And stage 2 is a heterogeneous disease. It includes T2N0, T1N1, and T2N1. And it is treated by concurrent chemoradiation. And there is a huge role for chemotherapy in advanced disease. When we discuss about this stage 3 and stage 4 disease, the standard treatment is radical radiotherapy plus chemo. And we will discuss the sequencing of chemotherapy. High quality, uninterrupted radiotherapy forms the backbone of in the treatment of nasopharyngeal carcinoma. First, I will discuss what constitute this stage 3 and stage 4 disease. Is any patient with a T3 disease, that's T3 in nasopharynx is mainly due to bone involvement. If the patient is having a base of skull involvement, clivus destruction, sphenoid sinus involvement, maxillary sinus involvement, or C1 vertebra, pterygoid plate destruction, these are T3 disease. And this patient has base of skull involvement. You have a clivus destruction there. T4 is constituted a patient present with cranial nerve palsy. 20% of the patient can present with cranial nerve palsy. Then patient have intracranial extension. And patient who has a tumor which spread beyond the lateral border of the lateral pterygoid muscle, parotid gland involvement, orbit, or lesion involving hypopharynx. These are all T4. When the patient has bilateral lymph nodes, it becomes N2, and patient any node more than 6 centimeters, it becomes N3, or any node below the caudal edge of the cricoid cartilage, that becomes an N3 node, irrespective of the size. And this is very important. This is a trachea, so it's a level 4 lymph node. It is at the level of the trachea. Irrespective of the size of the node, this becomes an N3 disease. Now, when we look into the business of chemoradiation in carcinoma nasopharynx, whole business started with the intergroup trial 0099, which was published in JCV way back in 1998, Al-Sarraf regime. It was a randomized phase 3 clinical trial comparing radiotherapy versus concurrent chemo followed by adjuvant chemotherapy. And the study was prematurely closed because the patient who received chemotherapy had a better 3-year progression-free survival and overall survival. And there was 2 trials conducted in Asia, one in Hong Kong, other in Singapore, and both trials were contradictory. And to prove the benefit of chemotherapy, this first meta-analysis was published in JCV in 2004 by Ben Slotman. And later, there was an update of this. There is a publication from the McKen-PC group in 2006. It's included around 8 clinical trials and included 1,700 patients. The conclusion from the meta-analysis published by the McKen-PC group in 2006 in the journal showed that those patients who received chemotherapy, the absolute benefit was 6% at 5 years, and the magnitude of benefit was mainly for concurrent, and there was no benefit for neoadjuvant or adjuvant. You can clearly see that. So to prove this, what is the role of adjuvant chemotherapy in addition to standard chemoradiation? Because the main problem with the adjuvant chemotherapy was the poor compliance in the 0099 clinical trial. Only 55% of the patients could complete the adjuvant 3 cycles of cisplatin plus 5-fluorouracil. To address further this clinical trial, there was a randomized clinical trial comparing concurrent chemoradiation versus concurrent chemo followed by adjuvant chemotherapy, 3 cycles of cisplatin plus 5-fluorouracil. This is a paper by Chen et al. Paper published initially in Lancet Oncology in 2012 and updated in European Journal of Cancer in 2017. The update shows that the 2 curves are hugging each other. You can see that concurrent chemo followed by adjuvant chemotherapy versus concurrent chemo, no benefit by adding adjuvant chemotherapy. For a substantial number of period, the concurrent chemoradiation remained as the standard of treatment. In 2012, at RCC Trivandrum, we stopped giving adjuvant chemotherapy. Now, how to proceed further? Main problem with the treatment of carcinoma nasopharynx locally advanced is to have a systemic relapse. How to tackle reduce the distant metastasis? This is approach one, systemic, this risk-adopted adjuvant chemotherapy. In patients who have high EBV value after chemoradiation, why don't you give adjuvant chemotherapy rather than giving adjuvant chemotherapy for all patients? Second is to reduce distant metastasis. Can we incorporate induction chemotherapy in various forms? And third attempt is to give adjuvant chemotherapy, which can be tolerated. That main concern is that the compliance. So why don't you give a metronomic capecitabine? So this first attempt was risk-adopted adjuvant chemotherapy. This is a paper by Anthony D. Chan, presented in ASCO 2017 annual meeting, published next year in JCO 2018. This is patients with locally advanced carcinoma nasopharynx, patients after 6 to 8 weeks. Those who have a high EBV DNA, were randomized either to give observation or to give chemotherapy, that is cisplatin plus gemcitabine 6 cycles. Why they choose gemcitabine? Because there was a randomized trial in the recurrent bar metastatic setting. Cisplatin 5FU basis cisgem showed that cisgem is superior in terms of progression-free survival and better tolerance. So that's if they choose to adjuvant chemo cisplatin gemcitabine. This trial failed to show any efficacy compared to the chemoradiation. So even in patients who have high EBV DNA value, after chemoradiation, there was no benefit. So there is a NRG HN001 clinical trial. This is a phase 2 bar, phase 3 clinical trial is underway to evaluate the role of adjuvant chemotherapy in patients who have EBV value. This is one of the review articles from my side published in 2018, but this was not discussing the recent updates. This is up to the high risk, adapted chemotherapy. Second attempt is to have induction chemotherapy before the standard chemoradiation. So the main advantage of giving induction chemo before standard chemoradiation is that early eradication of micrometastatic disease. It facilitates better radiotherapy planning. Patient is better tolerated compared to the adjuvant chemotherapy. Disadvantage is that there is a delay in starting the definitive treatment. There is a real concern of axial repopulation, and the patient may not tolerate the definitive chemoradiation after the induction chemotherapy, and also the concerns regarding toxicity. So there are 6 randomized clinical trials evaluating this problem. Then you give chemoradiation, and that's the control arm. The experiment asks you use 2 to 3 cycles of induction chemo before the standard chemoradiation. This is a systematic review from my side. So I have incorporated all the 6 clinical trials which are addressing this problem. So this is the only one trial was negative. The trial from the TAN, that's the Singapore trial, was negative. All the 5 trials showed that there is an improvement in failure-free survival if you add induction chemotherapy before the standard chemoradiation. I will discuss 2 phase 3 clinical trials because I will not dwell into the 6 trials because lack of time. This is the first trial incorporating modified TPF 3 cycles before the standard chemoradiation. Initially published in Lancet Oncology in 2016, updated in International Journal of Cancer by the UICC, and this is in 2019, the update came. And this is a phase 3 clinical trial comparing stage 3 and stage 4 patients were randomized to 3 cycles of cisplatin, 5-fluorouracil, and docetaxel, modified TPF 60, 660, versus followed by standard chemoradiation. It showed that there is, at a median follow-up of 71.5 months, this update came in 2019, showed that all parameters were in favor of patients who received 3 cycles of chemotherapy compared to the chemoradiation alone. And there is an increase in grade 4 toxicity at the expense. And this is one of the most practiced regime, that's the cisplatin plus gemcitabine. Very convenient OP procedure. There's no need for any admission. This has become a norm now in patients with stage 3 and stage 4 carcinoma nasopharynx. And this is the 3 cycles of cisplatin gemcitabine before standard chemoradiation versus standard chemoradiation. Initially, the publication came in 2019, and the primary endpoint of the trial was recurrence-free survival, and the primary endpoint was met. And you can see that the p-value is significant, the hazard ratio of death is 0.5, hazard ratio of recurrence is 0.51, and there was an improvement in survival also. There was a 4.3% improvement in survival, and there was no difference in local regional control. So it was at an expense of grade 3 and grade 4 toxicity, 20% increase in grade 3 and grade 4 toxicity. And there was an update which came published in 2012. It was presented in ASCO 2022 annual meeting and published in the next year, same year in JCO 2022. It showed that with a median follow-up of 69.8 months, there is 5-year overall survival was better in patients who received cisplatin gemcitabine compared to the standard chemoradiation alone. And this also showed that the magnitude of benefit was mainly seen in patients with high EBV DNA value at presentation. And this has been incorporated as a standard induction chemotherapy regime into the latest NCCN guidelines. This was updated in December 28th of last month. So it is in 2023. And it is cisplatin gemcitabine became a standard induction chemotherapy regime. And to know which is the best induction chemotherapy regime, two clinical trials. One is cisplatin 5-fluorouracil versus cisplatin plus 5-fluorouracil plus docetaxel. This was published in April issue of Translational Oncology in 2019. Showed there is no difference in between cisplatin 5-fluorouracil versus cisplatin plus 5-fluorouracil plus docetaxel. Similar trial was published in JAMA in 2022, and it showed cisplatin, paclitaxel, and capecitabine, TPC versus cisplatin plus 5-fluorouracil. Again, there was no difference improvement in survival. So the conclusion is that there is no difference. Cisplatin 5-fluorouracil versus cisplatin gemcitabine, there is no data. Cisplatin gemcitabine versus modified TPF, there is no data. This is again this is a chapter contribution from our side. Now, what is the role of the adjuvant chemotherapy after the chemoradiation? That is question was asked in 2 phase 3 clinical trials presented in ASCO annual meeting in 2021. One was published in 2021 itself, and next published in JAMA in 2022. This is metronomic capecitabine in the adjuvant chemotherapy after the definitive chemoradiation. One of my colleagues has recently done preparing an article for this, comparing these 2 articles. So the one is the trial with metronomic chemotherapy. They used 650 milligram per meter square BID for 1 year versus observation after the chemoradiation. The other trial used a high dose of the capecitabine. That was for 8 cycles. So there is slight difference in inclusion criteria of the both trials, but it showed that both trials showed improvement in overall survival, 3-year overall survival, and 3-year failure for survival in those patients who was adjuvant capecitabine versus standard chemoradiation. And there was a meta-analysis published in last ASCO meeting. This is only an abstract form. There is no published paper. It also shows that those patients who received capecitabine compared to the chemoradiation, there is an improvement in overall survival. There is a slight difference in the inclusion criteria between these 2 trials. There is difference in the follow-up, the dose schedule, the duration of capecitabine, but both trials showed there is an improvement. And if you look into the NCCN guidelines, you can see that it has become a category 2B recommendation using a capecitabine as adjuvant chemotherapy. And the last thing is the meta-analysis. Can I take another 2 more minutes? Yes, thank you so much. This is the update of the BEC-NPC meta-analysis. Initially, I discussed that it came in 2006. There was an update in 2015 by Blanchard and Lancet Oncology, and this is the last update which came in Clinical and Translational Radiation Oncology in 2022. And this, by the same group, showed that addition of chemotherapy in addition to radiation, there is magnitude of benefit. Those patients who received chemoradiation followed by chemo versus radiation, there is benefit. And there is a recent update is that those patients who receive neoadjuvant versus chemoradiation alone, there is a 5-year overall survival benefit of 6% and 10 years benefit at 9.6%. And I conclude with our own results. This is a rule of the results of our stage 3 and stage 4 patients. If you look, you can see that 41.9% received neoadjuvant plus concurrent, and the 34.5% used only concurrent. Because the concurrent data, the neoadjuvant chemo became more mature in 2016. In 2005, there was a negative trial by the TAN, but in 2006, the induction chemo came into the forefront. Okay, thank you very much for your patient listening. So to conclude, the stage 3 and stage 4A standard treatment is to give induction chemo followed by chemoradiation. Which is the best induction chemotherapy? That's a matter of concern. There is no randomized data comparing cisplatin gemcitabine versus cisplatin 5-fluorouracil or cisplatin gemcitabine versus the modified TPF. Adjuvant capecitabine is promising, although with little excess toxicity. And in those patients who have high EBV DNA value after chemoradiation, and there is no benefit by adjuvant chemotherapy. So this is a workshop which is going to be held next week in Kidwai. Those who are interested to learn head and neck radiology. So this is a 2-day program discussing the head and neck radiology workshop for oncologists. Thank you very much for your patient listening.
Any question from the audience?
Yes. Yeah, that's a matter of concern, madam. Because if you look into all the inclusion criteria, because if you look into the number of cycles of chemotherapy used before chemoradiation, only the Cowers paper uses cisplatin 5-fluorouracil for 2 cycles. All other use 3 cycles of chemotherapy. So this was a discussion in the faculty head and neck meeting, whether to discuss 2 cycles or to go for 3 cycles. So if you go by CISGEM paper or by the modified TPF data, then we have to give 3 cycles, because the overall survival benefit by giving induction chemotherapy is not by improving the locoregional control. It is mainly by reducing the distant metastasis. So it may be wise to consider 3 cycles. So initially we used to do 2 cycles, then go for their simulation. What we do now is give 3 cycles, then after you schedule radiation along with the 4th cycle, the day 1 of C4, and do a CT simulation 2 weeks after the 3 cycles of cisplatin gemcitabine.
And so should the standard of care today be NACT, CCRT? What about capecitabine?
Okay, that's a matter of concern. I agree that. If you look into one of the papers, one paper addressed only when we discuss about the capecitabine, one paper had only definitive chemoradiation. I didn't discuss about in detail, but the paper with a large number of patients, 74% of the patients received either 2 to 3 cycles of induction chemotherapy. And they give chemoradiation, they were given capecitabine, and this is showing benefit. So it is going to be a very toxic affair, but that is going to be, so everyone is waiting for the long-term results of the capecitabine data. We slowly started giving capecitabine for only patients who have N2 or N3 at presentation. T4, N2 or N3. Because if you look into the inclusion criteria, that is very stringent. Okay, so you cannot give all the stage 3 and stage 4 for adjuvant capecitabine. So patients who have N2 or N3, because these are the group of patients who are likely to have more distant failure. Yes. Yes.
Personally, in my clinical practice, this gemcitabine, cisplatin, I don't give it in a daycare basis. What I do is, there's a lot of toxicity with 80 milligram per meter square of cisplatin. So what I personally do is I divide 80 mg into 40 mg day 1 and 40 mg day 2. This is how I modify it and give it in my personal practice.
Yeah, very nice presentation, doctor. This is regarding head and neck cancers, basically oral cancers. T4, A and B, this is the concern. T4B lesions, by giving induction chemotherapy, how much percentage can we reduce to T4A operable cancers? What is your experience?
In nasopharynx or?
Head and neck.
I think there are a lot of discussion coming up regarding the locally advanced oral cancer, so I won't take up that.
What's your experience?
Yeah, okay, because many patients, the selection should be very good. Okay, selection should be very good. If you have a high ETF patient very close to the base of skull, patient is abating or infiltrating lateral pterygoid muscle in oral cancer, whether we should give TPF and whether we should consider them for surgery, that's a matter of concern. Because whether the patient becomes resectable, so that has to be discussed. If a patient's lesion is extending into the origin of the temporalis, okay, whether you should take up that, okay, that needs a lot of discussion. Yeah.
Thank you, Dr. Cecil, for a wonderful session.
Okay, thank you very much.
Discussions we'll leave for we'll discuss it in the panel discussion, which is upcoming. And now I invite, the next topic would be re-radiation in recurrent head and neck squamous cell carcinomas. I invite Dr. Sapna Nangia from Chennai to please take over.
I'd like to thank Dr. Neeti Raizada and all the other organizers of the Fortis Cancer Summit for giving me this opportunity to share the earliest experience of proton therapy of recurrent head and neck cancers in the country. There is a lot of interest in proton therapy all over the world simply because of the rapid rise in proton therapy establishments. As you can see, in the last decade, they have more than trebled. Another interesting thing to note is that in Europe, there is one proton therapy machine for every 21 million people. In India, we have one for every 700 million people. So there's, of course, going to be a growth of a lot of proton therapy machines as time goes by. And we need to be aware of what they can do. Just as an example, I would like to tell you that Spain has been gifted 10 proton therapy units by the owner of the fashion brand Zara. And Spain has the same population as any Indian state. Spain has a population of 38 million, which is like Gujarat or like Andhra Pradesh. So there is a lot of potential for the use of proton therapy, which we still haven't, which we are to explore. So for the non-radiation oncologists in the audience, the white bar is a tumor. The blue represents X-rays. As X-rays travel through the body, they attenuate, and they keep delivering their energy. Of course, this is super simplified. They keep delivering their energy as they go along. Protons stop at a particular point. They do not give any energy, deposit any energy distal to the location that you have identified as the end of the range of the proton. You haven't covered the entire tumor. As you can see, the white bar is peeping out. So another smaller energy, another energy, and now you have made the spread out Bragg peak. Bragg with a double G is named for the scientist who identified, who described this phenomenon. So what does this let you do? This allows you to spare critical structures. When we are re-irradiating, we want to spare the spinal cord, which has been re-irradiated earlier. If we are re-irradiating the skull base, we want to spare the optic chiasm, the brainstem, the temporal lobes, and proton therapy allows us to do that better. And because we are sparing the normal critical structures better, we are not going to compromise on dose, or we are less likely to compromise on dose. The damage caused by proton therapy is to both strands of the DNA. That is more difficult to repair as compared to single-strand DNA breaks, which is why proton therapy is more effective in radio-resistant malignancies like sarcomas, chordomas, and adenoid cystic carcinomas. The older generation of machines was complicated, and they allowed distal sparing but not proximal sparing. As you can see, the tumor is being spared distally, the last blue that you're seeing on your right hand, but proximally there is a lot of energy being deposited. But with the newer proton therapy machines, we are using a 3 millimeter beam of protons. It's called a pencil beam. With that, we are layering the tumor. We are painting the tumor layer by layer, and we are therefore conforming the dose of the radiation to match the shape of the tumor, proximal as well as distal. And this is how the tumor is getting treated by the proton therapy beam. The ASTRO, the American Society of Radiation Oncology, has come up with guidelines for insurance companies in the United States, stating that for certain things, there is enough evidence and the treatment has to be borne, the cost has to be borne by the insurance company. One of them is re-irradiation cases, when critical structure tolerance would exceed the tolerance dose. The other head and neck sites that are recommended are nasopharynx, nasal cavity, paranasal sinus and accessory sinuses, advanced stage unresectable head and neck cancers. It's not that the other head and neck cancers don't have to be treated, just that they require to be on a registry protocol, while these can be treated without even being on a registry protocol. At the Proton Center, we have treated about 1,200 odd patients, and 20% of these are head and neck cancers. The basis of the use in head and neck cancer is the better tolerance, besides skull base, where the outcomes are better. But general head and neck cancers, what happens is there is lower peg placement, less hospitalization, reduction of end of treatment narcotic use, etc., are much less. There is data from Mayo Clinic, there is data from MD Anderson Hospital and University of Pennsylvania suggesting that the tolerance is better. We ourselves have published our results in radiation oncology, which the radiation oncologists would be familiar with, and it's an open access international journal, where we have been able to confirm that therapy reduces the dose being received by mucosal structures, and because of that, the mucositis is much less. And you can see this 80-year-old lady who has completed treatment for CA tongue and is not showing any mucositis on the palate and the cheek. And this is the benefit of protons. Maybe I'm just going to go to the next one for paucity of time and take you directly and show you that difference on a re-irradiation patient. Now, we all recognize that re-irradiating patients is challenging. Retreating, or rather treatment of recurrent head and neck cancers, is challenging, both for the patient as well as for the treating team. These patients have had previous surgeries, they've had radiation, because of that they have endarteritis, their tissues are damaged, and the damage may extend to mucosal pain, swallowing difficulties, laryngeal edema, xerostomia, etc., etc. The most important critical step is the two things that make it better for patients is a long disease-free interval. So this is the MIRI collaborative study, which has looked at what makes it better, or what makes the outcomes better. One is a disease-free interval of more than 2 years, and second is surgery. If a patient has had surgery, especially if they have a flap in place, they have new tissue, they have new blood supply, and it's easier for them to go through re-irradiation. The worst patients are those who have failed within 2 years and who also have some functional damage. For example, they have a tracheostomy tube or they have a Ryle's tube. In them, the overall survival at the end of 2 years is less than 20%. Is this the group of patients for whom you want to use up resources of proton therapy? And I mean the patient's resources. Not necessarily, because this is a patient who has a bad prognosis disease. However, a patient who's had a disease-free interval of more than 2 years, or who has at least a function intact, is definitely somebody who warrants consideration of proton therapy. So as an example, I would like to show you this 45-year-old gentleman, a doctor, treated for CA buccal mucosa in 2017, underwent radiation after surgery. Following that, he had a disease-free interval of 4 years, had a recurrence in the tongue, and then subsequently, that was only dealt with by surgery. And now in 2023, this patient has come to us with a lesion in the tongue, and he's undergone surgery. There's a flap in place, and there are 2 nodes which were positive, multiple negative features, LVSI, PNI. Now, he really does warrant re-irradiation. And this is a comparison of his proton plan with his IMRT plan. So for the non-radiation oncologists in the audience, the red outline that you see is our target. And the blue is the buccal mucosa on the contralateral side. All these colors are representing dose. Yellow is what we want to deliver. Green is 50%. Purple is 25%. And as you can see, proton is sparing the palate and the buccal mucosa significantly better, and that's the volumetric representation of the same. And then when we see a coronal view, I think it's even more striking when we see how well the palate and the pharynx have been spared in the proton picture that you see. You don't even see some of the 25% dose on the posterior pharyngeal wall. However, with an IMRT plan, this patient would receive at least 50% of the previously irradiated pharyngeal mucosa and palatal mucosa. What is the quantum of difference? So even if the spinal cord critical structure is the same, you can see the xerostomia chances of this patient who's already previously irradiated are remarkably less, with a 60% plus reduction in the parotid dose. And all these structures that we should be paying attention to if we want to reduce the pain and dysphagia, such as larynx, uvula, epiglottis, strictors, etc., are receiving a much smaller dose. What does the literature have to say? So we have published data. This is the photon data, and this photon data tells us a 1-year survival of 50% for head and neck cancers at the end of re-irradiation. But we look at the proton data. This is from the MSKCC group, 65% at 1 year. And then this is from the MD Anderson group, 84% at 1 year. Of course, a very select group with some slow-growing malignancies like chordomas and adenoid cystic carcinomas. However, an excellent 1-year control of 84%. And a very recent data, which has been published from Memorial Sloan Kettering, which talks about a 1-year loco-regional control of about 62%. So, of course, they are difficult cancers to treat. You're not going to be able to cure everyone, about 60% of patients, with some potential toxicity. So you see a significant number of grade 3, grade 4, and even grade 5 toxic effects. So this is a conversation that you need to have with your patient. Yes, there is a possibility of cure. Yes, there is a possibility of loco-regional control. It may come at a price. At APCC, proton re-irradiation constitutes about a quarter of our head and neck work. And as expected, this is India. Most of our work is oral cavity cancers. And this is our data. We have so far re-irradiated 43 patients, 28 squamous cell carcinomas, and 15 others. At a median time from registration of about 26 months, 13 are alive disease-free. 9 are alive with disease at various stages of their immunotherapy. And about 12 patients are symptom-free, grade 3 symptom-free. Our 1-year survival rate is 67.7%. There is a big difference between squamous cell carcinomas and non-squamous carcinomas. So the adenoid cystic carcinomas do remarkably well. The squamous cell carcinomas don't do that well, and the 1-year survival is in the range of about 60%, as you can see. In the non-squamous cell carcinomas, it's as much as 86%. Some places where proton therapy makes a huge amount of sense is, for example, this esthesioneuroblastoma. Lady previously irradiated, now requires to be re-irradiated in between the 2 optic nerves, which have already received tolerance dose. And this is for the same optic nerve doses. IMRT is going to underdose the tumor. So you can see the tumor, which is outlined in green and yellow. It's going to not receive the prescribed dose, which is the red, while proton is going to allow you to give the full dose without damaging the optic nerves. And this is a patient who was treated, remained well for about 2 years, subsequently failed with dural metastases, and is no more. This is a doctor whom we had treated, previously treated for carcinoma glottis, and now failed in the neck, underwent a neck dissection. The lesion had to be shaved off the carotid. His concern was, am I going to be able to practice? I need to speak. Of course, I need to eat. And the critical organ here was actually the larynx, to be able to treat the larynx without causing laryngeal edema. And you can see the FOL pictures. He continues to be well with no swallowing dysfunction. So we're not only talking about the spinal cord, we're talking about a patient going back to functional living. He has to swallow, he has to speak, he has to look presentable, and so on. However, looking at the success is one story, but there are competing risks that we need to be aware of. So this is a very interesting paper that has come on re-irradiation of nasopharyngeal cancers. Nasopharyngeal cancers are actually, they're supposed to be the better ones to re-irradiate. However, as time goes by, the red bar, which is the dead patients, the peach bar, which is patients who are alive with disease, and then there are patients who are alive with grade 3 toxicity, and then there are patients who are alive and well. So there's a very small section of patients who are alive and well, under 20% at the end of 10 years. What are these competing risks? Radiation necrosis, dysphagia, trismus, carotid blowout, temporal lobe necrosis, osteoradionecrosis, and this is something that we have to be aware of. In our own profile of 43 patients, we've had a carotid bleed, and I'll show you something about that later. Loss of vision has always been with prior consent, never in both eyes. Soft tissue necrosis, we've had 1 attempted suicide and we've had 4 tracheostomies. There are issues in re-irradiation. There can be bad biology. That's the before and after picture of a patient who was re-irradiated with a very small disease-free interval. You hardly see any difference. That's bad biology. And then there can be unpredictable spread. These patients have had surgery where they're going to fail. That's a patient irradiated the 3rd time, and the picture that you see at the bottom is a failure just outside the target. We don't re-irradiate patients the 3rd time anymore. We have learnt our lesson, and we do not re-irradiate 3 times. Or rather, re-irradiated 2 times. That means no 3rd radiation. So there can be poor vascularity, there can be necrosis, there can be carotid blowouts, there can be optic neuritis. And we have adopted strategies such as hyperfractionating pentoxifylline and the aggressive prevention of optic neuritis by even giving HBOT as preventive if a patient has a transient loss of vision recovery, as we have done in 1 patient. So this is the coiling of a patient who presented with a warning bleed. Please give me 2 more minutes. And this is a patient who had temporal lobe necrosis after having re-irradiation for adenoid cystic. He remains well. He remains well and functioning. This I've already discussed. There are planning techniques we may use, such as creating a relative cold spot on the mandible and then on the carotid to reduce the possibility of ORN and carotid blowout, respectively. So my final slide is this 32-year-old man, and Dr. De Cruz is in the audience and might remember this young man who was, treated 10 years ago with a high-grade sinonasal neuroendocrine carcinoma in 2010 and had undergone 60 gray, developed a recurrence in 2019, treated with NACT and endoscopic surgery. There were many challenges. We needed to give 60 gray to this region, and yet the permissible doses were very limited to the brainstem, the optic eyes, and the optic nerve on the right and the left. That is the tomotherapy plan, and this is the proton therapy plan. I think it's so sort of self-explanatory that proton therapy allowed us to treat the target without damaging the optic nerves. This gentleman remains well functional 3 years later with intact vision in both eyes. So in conclusion, there is a dosimetric advantage with better odds for survival and safety. I omitted to mention that the MSKCC study that has recently been published by Ann Lee has looked at the population and said that there is a 25%, so 50% patients surviving at the end of 2 years versus 40% in the usual published literature. That represents approximately a 25% gain. So there is a dosimetric advantage and better odds for survival. However, judicious selection incorporating disease-free interval, previous dose, overall prognosis, and the cognizance of impact on normal structures is very, very important. The story of squamous cell carcinoma histology is not as exciting as re-irradiating non-squamous histologies such as adenoid cystic carcinoma and chordomas. However, it is something that we must consider. At the end, I would like to thank all of you for your attention, and I would also like to thank the team at APCC and also the head neck surgical oncology and the head neck cancer management team. Thank you very much for your attention.
Thank you, madam, for the enlightening session. Do we have time for the questions?
So, ma'am, I have one. What is the minimum interval you consider for re-irradiation in head and neck area?
See, there are occasions when we have to consider early, but I would say at least 1 year gap is something that we would be looking at. And if we would be looking at re-irradiating in exactly the same area, we would like it to be as long as possible. If you were irradiating, for example, somebody has a neck nodal failure slightly lower down, we could be looking at 1 year or so, 9 months, 1 year. I think another critical decision that impacts, another important thing that impacts our decision is how close the carotid is. You know, an ORN can be managed, but a carotid is very, very difficult to deal with. So if it's far away from the carotid, maybe. But if it's close, we would be very careful. So it costs around 30 to 33 lakhs if we are using a fractionated course. We don't do SBRT with protons for head and neck. If we were to do SBRT for protons, with protons for head and neck, it would cost 7 lakhs. However, let's just say I'm not convinced about whether we should be using SBRT. It's available in Chennai, where we have approximately now 5 years of experience. It has recently become available in Tata Memorial Hospital. 2 places in India, one at Chennai, where we have been doing this for the last 5 years, and in Tata Memorial, where it has become available a few months ago. Apollo Proton Cancer Center in Chennai. It's a standalone cancer hospital built around the proton therapy center. It's not only a proton therapy facility, we also do normal radiation, surgery, chemo, etc. I wouldn't be able to tell you, sir.
40% cannot be salvageable after re-irradiation.
Not 40%, more like 60.
Okay. Those patients can be salvaged with adjuvant chemo?
Most of our patients who have failed are now on adjuvant, we wouldn't call it adjuvant, are on palliative immunotherapy, and they have a reasonable survival after that. I mean, some of them have been on immunotherapy for about a year or so. Is that all? Yeah. Thank you very much.
So let's start our next session. We have an upcoming panel discussion. I invite Dr. Anil D. Cruz, sir. Since Dr. Devendra Chokar is not here, so Dr. Anil D. Cruz will take care of the head and neck recurrent head and neck cancers, as well as the locally advanced head and neck cancers. Over to you.
Morning, everybody. Cecil, Sapna, great talks. You'll set the stage for good discussions. And some of the points that came up in your discussion, I think we can continue in the panel. Can I have... So we've got 2 sessions. I thought we'll just have 5, the first 5 on the first session, and we are discussing recurrent head and neck cancer. So can I call Dr. Vishal Rao? He's a surgeon. Niranjan is here? Here's Niranjan. He is a surgeon as well from Kuldeep. Kuldeep is Radong, correct? Vivek, Rajat, and Thorstein. Rajat is here. Vivek's not here? Okay, so we've got 2 medoncs, we've got 2 surgeons, and we've got 1 radonc. I'd love participation from the crowd as well, but we've got 20 minutes. If each of you all speak 3 minutes, 5 and 3, 18, it's over. I don't get time to speak. So let's be very brief and try to get as much of points that we can. So the first is recurrent tumors. After we treat our patients, what should be our protocol to pick up this recurrent disease? When do we look for it? What's the best imaging and your frequency of follow-up? Anybody? Go any order. Vishal, you go first. He's the biggest guy on the panel, so I thought I'll start with him.
Hello. Yeah. Sir, first of all, thank you to Fortis team for this. Sir, I would like to start with saying I think in the first 2 years in head and neck cancers, this plays a very crucial role because more than 80% of them tend to recur in the first 2 years.
So intensive follow-up first 2 years, great.
Yeah, and we generally try to keep it as compliant as possible. That is, I follow a general formula to say that come for 2 monthly for the first 2 years. easier to kind of keep them, and I give them a calendar. So we have a follow-up calendar.
So intensive follow-up, 2 monthly, first 2 years. And what imaging do you do at each visit? You do a clinical examination.
We do a clinical
You
examination.
do a Hopkins to look for second primaries at the back of the throat. What imaging do you order and when?
Generally, I prefer it if it's post-radiation, 6 months after that.
6
3 to 6
months.
months after the thing. If it's a standard low-risk category, clinically normal, Hopkins normal, I wouldn't simply do an imaging.
And what do you do 6 months later?
6 months prefer I do a PET scan and then one more PET scan at 2 years. This is one thing that I follow
So 2.
in my
Okay.
practice.
Anybody else? A different viewpoint? Go in any particular order.
Yeah, in head and neck, I'm not very pushy for doing the PET scan. Unless and until baseline PET is available and patient had advanced disease to begin with. More than that, I think MRI or the best is clinical, but the next will be an MRI or good contrast CT only.
And when do you do it? 6 months later?
First is at 3 months.
3
and
months.
Then after, so at 9 months maybe.
So at 9 months maybe. Now how do we decide that? We have to give them some messages to take home. So it would be 3 and then 6 months later.
6 months later.
Anybody else has a different viewpoint? Maybe from, yeah, go ahead.
Similar viewpoint as the other panelists. If there is a bulky disease, then I'd probably look for a PET scan. But then if it was not a bulky disease, then a clinical examination for sure. Of course, the surgeons will deal with it more than the medical oncologist does. But a 6 monthly examination of the scanning of the head and neck is important, and also of the chest. So an X-ray of the chest also is what we do.
An X-ray of the chest.
So
Let's
I agree with the 3 months follow-up, in particular after chemoradiation. And given that you are asking for residual disease, I would ask the surgeon if there is any salvage option.
If there's a salvage,
Yeah,
we come to the salvage.
Yeah, but you're pointing out residual disease, so that's what I would ask you. Can you salvage the patient?
No, say that again. I didn't follow what you asked.
If there is a residual disease after 3 months after chemoradiation, I think my first question would be ask the surgeon, is there a salvage option
to operate?
Yeah.
Yeah, sure. If it's larynx, I mean, I can answer on behalf of the panelists. If there's a larynx, we'd go in and operate for residual. But the probability of residual treated chemorads is very, very low. And if we've operated before and it's 3 months recurrence, I don't think any of us would venture in again. So quickly, if we can...
Yeah,
go ahead, sorry.
Yeah, sorry.
Sorry, Niranjan.
In our center, after completion of treatment, we call the patient, first follow-up is after 2 months, then every follow-up is every 3 months. And after 2 months, we do one imaging for this
After 2 months?
After 2 months of completion of treatment, yeah. Then after that...
Would that be a PET, an MR?
No, preferably MR or CT scan. In head and neck, we also don't prefer PET CT so much unless initial patient has had a PET scan, then we can compare with PET scan, yeah. Otherwise, MRI or CT scan, then chest X-ray.
So go ahead, Sapna. So you can see we've got 5, I mean, more or less everybody is same, but there's 5 variations in what we do. Let's take one message home. Sapna is going to do that for us. Can she have a mic? Huh.
Almost all patients would have a PET scan before treatment. Or at least I feel that I think that message should be there. There is information that we get from the PET scan that is useful, and there should be a PET scan 3 months after treatment to assess for, as we discussed, residual disease and the possibility of a salvage treatment.
Point well taken. So let me kind of summarize. So I'll first go with the, go ahead. Yes, sir.
I want to add that for throat, for example, larynx, hypopharynx, I will essentially do an FOL because that tells
On follow-up.
First follow-up at 3 months. FOL is mandatory because mucosal disease we can detect best on FOL compared to MRI or PET scan. So I think FOL along
Clinical examination. Yeah, clinical or a good Hopkins. Go ahead.
So for nodal disease, can ultrasound pick up, sir? Because, I mean...
So I'll quickly summarize it. Do you want to make a last comment? Please, behind you. Just give the mic behind you and then we'll just conclude this and move on.
Dr. Anil Dikris, good morning. I'm Dr. Naveen Machado, 1 year your junior. In 2016 August, Dr. Vishal Rao was my surgeon who operated on me. Complete thyroidectomy for follicular carcinoma of the thyroid. Diagnosed myself about 3 weeks back. Before that, felt the node myself. We operated, I had radiotherapy, and I've been following up with his HCG, doing well. Can I just adequate something which is probably too dumb for you guys? And it's just simply like self-examination of the breast, self-examination of the neck.
You can, it's not bad. You must report to your doctor when you have a problem, but it may not be as accurate. In medical term, the sensitivity, the specificity, the diagnostic accuracy of doing imaging is better than self, but for a patient to be aware is good. So we're going to conclude this and I'm going to tell you my philosophy. If you don't agree, please get up and tell me. So pre-surgery, our patients need not always have a PET scan. It's good, but we'll do something that has the best imaging information for me as a surgeon. So I might do an MR, I might do a CT. We know that all these diseases fail in the chest. So we'll do a CT of the chest. So I'll do local imaging what I want and I will do an imaging of the chest. If I feel distant metastasis is high, as in hypo or naso, then I always do a PET. So that's my pre-op workup. I don't know if all of you all would agree to this. Post-op. First follow-up 4 to 6 weeks later. Not because I want to make money on consultations, I'm now in private, but I'll tell you the logic. Patients have complications of treatment. I need them to get the right toothpaste. I need them to move their shoulders. I need to see the side effects. So I call 4 to 6 weeks. My rehab gets more intensive. Jaw stretching. 70% of patients have trismus finally. You have to initiate that first. So I call my patients 4 to 6 weeks first time, and then I do the Vishal algorithm for 2 years intensive follow-up every 2 to 3 months. First scan 12 weeks later, unless it's an early cancer that I've operated. A tongue with neck, no adjuvant, clinical examination, Hopkins, send him home. Don't waste his money. CTRT, complex flaps in place. First scan is always done 12 weeks later. And the scan is a PET. The reason is the PET has the highest negative predictive value. If your patient comes out clean with no orange and pink dots on that scan, 95 to 97% he or she is clean. And then depending on the first scan, we'll decide on the second scan. If the first scan says query inflammatory or correlate clinically, there's nothing found on my scan, then I do the repeat scan 6 months later. Unless the patient has symptoms, then I might do something in between. Otherwise, I do it a year later, depending on the initial volume of disease. So I think that by and large is what everybody does, NIRAD's recommendations and others. So if we can formulate an even policy and follow-up, it will be better for us. Comments, agreement, disagreement, and then we'll quickly go to the next.
So I just want to add one point. Today, of late, with more educated people, when they come and ask us for PET, one more advantage that I tell them is if he's a chronic smoker or a tobacco consumer, the chances of a second primary could be about 5%.
Yeah.
And this is one thing just to document, because a lot of them who come back with that second primary, to combat them and in our argument becomes very difficult, because they ask you, why didn't you tell me about this earlier? And the cost difference between a CT and a chest CT versus a PET CT would be almost similar if it's available in the hospital.
Anyway, I don't agree to you on the cost difference. I also believe a PET CT, if they're radiologists, they will radiate you more. You have to give contrast. And most of the data screening for lung as a second primary comes from the West, where guys smoke. Here we have all chewed. How many of us, hands on heart and hands in the air, see a lung second primary in head and neck? Usually our oral cancers fail orally. It's rare to see a lung cancer. We do see, Point well taken, but many of our people are chewers in tobacco. Let's move quickly. I've jumped one case because we've got a lot of... So we get a recurrence. We all agree that if it's surgically operable, we'll operate. And we are not going to go over the basics of what DFI and all that kind of stuff. So classically, we get oral cancer cases that recur. And this was the only photograph I had on my computer. We can't operate. We can't give protons. How are we going to palliate these patients with recurrent disease? This is just an illustrative photo. You don't have to really talk on this. So I want you all to tell us, is the choice of chemo varying according to local, loco-regional, metastatic? And how do you decide between conventional TP, TP extreme, using IO, using metronomic that we use in our country? Take it from here.
So various variables have to be looked at. One is the performance status of the patient.
So good performance status.
Finances also is not an issue.
Let's discuss ideal and tell us if they don't have good finance.
Okay, so I would like to do a CPS scoring, PDL1 CPS scoring on the block that we already must have had post-surgery. So this is not required to be a rebiopsy where we need to look at the PDL1. If the PDL1 CPS score is in the various connotations like less than 1%, 1% or more, and more than equal to 20%, then the treatment varies. Before that, the chemotherapy backbone can either be a cisplatin 5-FU or a taxane platinum. Generally, my preferred regimen is a taxane platinum because of higher response rates, easy tolerability. Patient does not have to come too much to the daycare for the visits, as is with extreme study. If the patient is having a high CPS score, 1% or more, I would tilt more in favor of Pembro plus chemotherapy. If it is less than 1, it will be cetuximab plus chemo for me.
So you are driven by the keynote paper. If your patient can afford IO and above 1, you will do the Barbara Buttress protocol.
Yes. So first of all, I think it also depends when does the recurrence occur. Is it within 6 months after because this makes a difference after platinum exposure, or after 6 months? If it is within 6 months, there is still the keynote 40 or checkmate 141, or even taxane, cetuximab as a monotherapy. If it's after 6 months, we have the two options. I wouldn't go for pembrolizumab mono, even if there's a high CPS score, but there's pembro plus chemo, but definitely TPX as an option as well to receive higher response rates. So that's what we usually do in Austria and Europe. But CPS score is great to have. And we also opt or ask the surgeons to do a rebiopsy as well, because we think that CPS score can change. We know that from some data, archival tissue might be sufficient if we don't have it, but we observed in our daily clinical practice that the CPS scoring does change. After a particular radiotherapy, for example, it has an effect on the immune system. So if feasible, and if there is a recurrence after a year or so, I would really like to have a rebiopsy.
So I think I agree with your point that I would do the same. If the recurrence comes very quickly, maybe, I wouldn't say year, but quickly. I mean, very subjective, I probably would go with Rajat's way of doing it on the original blocks. But if it comes some time later, extensively treated in between, then I would ask for a new CPS score. The only reason is there is data, but there's also, because it's a costly drug, I want to make sure that my patient who's going to benefit gets it or no. So we've got two views. We've got Rajat who wants to do the IO, and we've got you who says that you don't mind TP extreme. Surgeons, rad-oncs, you all have to send the patient to these guys. They'll come back to you.
Both is an option.
Yeah. Say that again?
No, I just want to say, both IO, chemo, of course, this is
both.
It remains an option. Definitely.
You were given a choice. The patient says, I want the best, sequence me correctly. Should they go targeted first, or should they go IO first? I can tell you, in the US, they would go IO first. In Europe, many people would go targeted first.
Oh, in Europe, it's quite a mixed. It's quite a,
but you all have a higher percentage of people going targeted first. What do you all do? Vishal, patient will ask you, where should I spend? Should I go to Rajat?
I think what I understood is that our thoughts were nearly the same, except for less than 6 months, where of course we would not do a keynote 048 and would resort only to a single agent IO.
So, okay, so we agree that we'll go IO because of compelling data that it's better than giving it with targeted, and that should be the first line if patient has good performance and can afford.
Only if CPS score is not
Granted,
less than 1.
granted, well taken. 3 of. Would you agree?
So just one more point to add at this condition. I think the most important thing to achieve would be first put in a PEG tube, achieve good nutrition.
That all is okay. That all is okay. So we'll do the symptomatic business.
And I think what we follow is, if there is good general condition, chemo with immuno would be a very good combo if the bulk of the disease is higher. If the latest Tata paper on low dose immunotherapy is also something where
if the patient can't operate, you'll do that.
Yes.
So I'm going to throw the cat among the pigeons and ask you all. The patient comes and I pick up a recurrence in follow-up 1.5, 2 years later. Whether it's on scan, whether it's clinical, the patient is asymptomatic. What will I do? Patient is asymptomatic. I give your IO with chemo, I'm going to make an asymptomatic patient symptomatic and I'll drain him financially. What should I do?
I think first patient has to go for, anyway, to prove the recurrence, we do biopsy.
Done.
So based on biopsy, then
proven, sir.
Yeah, then based on these reports, then I think
patient asymptomatic. Oral cavity lesion, I can see one small cauliflower sitting in his mouth. And
but if it's that small, then I ask you again, is it salvageable? If it's really small and he's asymptomatic, that obviously means it is small recurrence.
Surgery not possible.
Not possible.
Going into the high ITF, it's sitting on the superior aspect of my flap. If surgery was there, I wouldn't bring it here. I would just operate and be busy today. So what do we do?
But the radiation is also not possible?
Re-radiotherapy. Interesting point. Oral cavity, recurrence, radiated. Would you radiate for palliation? Would you radiate for cure?
If it is at 2 years and if we can check our previous plan and if the overlapping is not much, if it is less than 40% or so, and surgery is not possible, then I think such patients should be given a good trial of re-radiation before.
So I'm again going to very, very pointedly put this question. In my book, I would never send a patient to radiation if it's not operable in oral cavity for re-radiotherapy. Because y'all guys are not curing primary disease. Re-radiotherapy you're unlikely to cure. And you're going to palliate. And we don't have data that y'all do better palliation.
But I think that should come from a radiation oncologist. That
so I'm asking them, I'm looking, he's jumping up. Bolo Jay.
See, the kind of patient you mentioned that recurring at the superior end of the flap, he is an ideal case for SBRT. 5 fractures treatment, OPD visit, no major side effects, and local control is in the range of 70 to 80%. And we have our own patients who are surviving long, 2 years, 3 years, etc. So if there is a good disease-free interval, more than a year, and patient has a localized recurrence, they are the ideal candidates for SBRT, and we have published our data also.
Point very well taken, and I wanted to bring this point and then we'll close this panel because though I've got 5 cases. I want a discussion revolving now so that people can take home message on alternative radiotherapy regimes for a recurrent disease. One is SBRT, and the second, which I like, and I know Sapna doesn't subscribe to my thinking, is the quad shot regime. I just believe biologically it's very good. So giving the quad shot gives good palliation. Comments from radiation oncologists, surgeons, and some of the seniors in the audience, and then we can close.
Sir, if this patient is asymptomatic and if he has a small disease, then we should not jump for palliative as an objective. Our objective can be radical at this point of time. So first notion is that once it has recurrence, then it is always palliative. It is not like that.
Point taken.
Radiation can give good radical cure in few selected cases, up up to 40-50%.
Point well taken, but I'll just drive this corollary home that if it is small and you're going for cure with radiotherapy in oral, a surgeon worth his salt will operate that disease. This is the point I'm making. So don't give re-radiotherapy in the belief that you'll cure because a surgeon can't. If it's up in the pterygomaxillary, I'll go his way. SBRT, just focus my radiotherapy there and not give radical fields. There was a trial, it's an old trial, 9803, looking at radiotherapy versus chemotherapy. They had a fancy regime of hydroxyurea and all, and really it didn't improve, and it was for palliation. A grade 3 toxicity was significantly higher when you gave radiotherapy and did not improve overall survival. So if you can cure, but the point I'm just making for discussion, of course, sometimes there will be cases that you would treat, but generally what you would treat, I would operate. Otherwise, I would go for that kind of regime.
Surgery is the first option in that.
Point taken.
Touch the patient.
Last point.
I really must agree with Kuldeep here that in the high ITF, you may not necessarily go, sir, but the radiation oncologist can.
Done. Done.
Our intent in some of the cases is potentially curative. In those situations, we should aim for therapy which has curative value, like SBRT is a radical dose. It is not a palliative dose.
Granted.
Second is that wide field re-radiation has all the side effects which everybody is scared of. SBRT in very good selected patient has very little side effects. So cure is possible with good quality of life.
So great. So here what we are concluding, that if you could operate, operation is the best. Generally, if it's small volume disease and you have to radiate, a surgeon would remove it first and then we would send to you for re-radiotherapy. And Sapna told us the MIRI A, B, C, we'll follow those guidelines. If we can't operate and it's small volume disease in a location because I can't operate, pterygomaxillary, we'll go radical. And SBRT is a good option for that. Otherwise, we'll do CPS, we'll know the score, go IO, and subsequently other regimes following that. If the patient cannot afford, we'll go metronomic with that. Is that okay, Vishal? Lovely. I think we'll finish because it's time up. We've got another panel. Quickly, while the next panelists are coming. I'm sorry, guys, it was too rushed. There's just no time. But maybe we can do the rest over coffee.
If brachytherapy is feasible, I think brachytherapy also will do the...
Brachy is good, but brachy the surgeon will operate. Brachy surgeon, Vishal will remove that disease. Don't do brachy. Theoretically, you're correct.
Before they put the tube.
Yeah. Before he puts the tubes, he'll get negative margins. Lovely. So thank you very much. I'm sorry in the paucity of time. Can I have the next panelist over? Welcome. Neeraj. Come, Neeraj. Sairam, come. Satakshi, Subramanya Rao, and Sunil Vasudev. So we've got, how many surgeons now? One Satakshi surgeon, Maxo. So 3 surgeons and 1 radonc, 1 radonc, and 1 medonc? Yeah, but 2 rebes. We don't have a medical oncologist? Okay, no bothers at all. Let's quickly go. So here we have to decide in oral cavity, when do we draw the line on resection? When do we say no to resection? So we know this staging. T4A, we'll always operate. T4B is very advanced. They don't say inoperable, but generally we don't operate these cases. Now, in T4A, we have what I call T6. You can have extensive skin involvement. You can have extensive bone involvement going from one condyle to the opposite angle. Plenty of cases, deep muscle involvement of the extrinsic tongue. So I put up 3 cases of buccal mucosa. Which one will we not operate? Or will we operate all these 3? Anybody? Satakshi. Would you operate all these 3? How do you decide which buccal cancer you would operate and which ones you wouldn't?
So the first one, possibly we will like to operate, even though there is some excuse my voice please, some inflammatory component. So after treating that inflammation, for the second and the third one, upfront surgery, no, because it looks like the second one might have disease extending up to hyoid and the third one might have disease extending up to zygoma. So these come under the criteria of borderline operability, and upfront surgery we may not consider.
Okay. Anybody else? The other two surgeons, please.
Second one might have metastatic disease also, sir.
No, metastasis and all are not there. And it's not going to the hyoid. Maybe the picture is not very descriptive.
The first one has a lot of subdermal...
Put the mic closer.
The first one has a lot of subdermal component. So the exact extension of that would be doubtful even on a scan, because which is inflammatory, which is the subdermal extension is very difficult. Whereas the second and the third, the subdermal extension doesn't seem to be quite a bit. We'd like to have a look at the scan, and if the subdermal component is not much, the second and third looks more operable than the first.
So Satakshi wanted surgery for that, you don't, and let's see your view.
Yeah, basically I agree with him. The second two, if it can be,
excised,
reconstructed, we can do some kind of good reconstruction. Then we could look at that, or if we can give some chemo radiation, reduce it from T4B to T4A, then we can probably look.
Great. So now I think they've made very important points, but all in their own different styles. The point is, if you can excise an oral cavity with adequate margins and give good reconstruction, we will operate all cases. Would everybody agree with this? We would.
Yes.
So now when we look at 1 and 3, I didn't operate. 1, because the margins of excision are diffuse, exactly what you say, subdermal. I don't know where to place my knife. I may do something else for the patient. And exactly the patient for 3. If you look at 3, below that fungating area, there's all redness. And it may not show well, but there are 2-3 skin nodules that are seen there. So the dermal lymphatics are already seeded. So whenever you have dermal lymphatic involvement, we don't operate our patients. But if you can get margins negative and good reconstruction, we would always operate our patients. Is that correct? Perfect. What about T4B? Going into the infratemporal fossa. AJCC says don't operate. In our country, all of us operate because retromolar go into the infratemporal very easily. Are we doing right? Wrong.
Infratemporal notch below the infra notch, infratemporal fossa. If this one are favorable, then I think upfront surgery can be done.
Would that be your philosophy, Satakshi? Your philosophy as well?
Agree to that. T4B infra notch will be for upfront surgery. That's no discussion. T4B supra notch, some thoughts are there for upfront surgery. We have data to support that by Liao's group. Some Indian groups are also there. But by and large, having a margin there is very difficult. So for majority of the cases, it will be chemotherapy to downstage, attempt and downstage, and then consider surgery.
So I think great points. Again, even in T4B, if you can get negative margins, we will operate the patients. And the arbitrary plane described came from this paper, which all of you all would be familiar with, from Taiwan, that they draw an arbitrary line from the sigmoid notch to the pterygoid plates. If you have disease below that, you may be able to get negative margins. But even these patients don't do as well as other patients unless you get negative margins. So you must ensure you're getting negative margins. And clinically, if you are not sure about the notch, just look at the lateral pterygoid muscle. That's above the notch. If the lateral pterygoid is involved, you have edema going up there, probably the patient needs to have some other regime, neoadjuvant, and operate these patients. This paper I just put up for the youngsters. It's a latest oral oncology, not too late, a year and a half too, looking at the Taiwan group, looking at a nationwide on T4A versus T4B, suffice to say T4B do very, very well. And then they've collated a lot of studies that have operated on T4B, and many of them are Indian studies, which again is a matter of pride that people in our country have started publishing and showing their work, and most of them show benefit. So again, those of you all who work in multidisciplinary clinics and are not very sure about infratemporal, don't make all negative. As the panelists have said, if you have disease infra-notch, you can get negative margins, you may want to operate these patients. Another advanced oral cavity cancer. What do we do? My juniors who examined this patient told me, you can do a total glossa. And they also moved that nodule and they said, sir, it's moving like a laddu. Pardon my English or my Hindi or my French. They said, sir, it's moving like a laddu. Is this inoperable? Should I call it a day? Should I operate this patient? What should I do? What is the philosophy? And then after that, we're going to have opinions of the rad-oncs as to what you all would do in this case.
So for tongue primaries of what we are seeing in the photograph, we'll see two things. One is posterior extent if it's around the vallicula. Also, if the inferior extent is up till the hyoid. Those will make it borderline operable / inoperable because of the outcomes.
So we'll just rephrase this, though it wasn't in this patient. If you have disease going to the vallicula and you'll have to take the epiglottis as a margin, we are not operating those patients. That's Satakshi's philosophy. I also do exactly the same. And if you have root of tongue involvement, basically for youngsters, if you cannot feel a plane between the posterior edge of the tumor with your hand inside the mouth and one hand outside the mouth above the hyoid, if you can bring your fingers together and you can get that soft tissue, we'd operate. If we can't, we'll not operate those tongue cases. This case was absolutely operable. I could do a total glossectomy. Patient has ankyloglossia, but I can get a margin. The hyoid and the vallicula are not there. Would you still operate? So I put up some cues at the side. So for the primary, you said the base of tongue vallicula, you said hyoid. What about the number of nodes? Whether the carotid is involved, whether the skin of the neck is involved. If you look at staging, they say skin on node is not a good prognostic sign. If you have bilateral big nodes, if you have nodes at level 4, level 5, would you operate these cases?
No upfront surgery.
So let us give them some message. If you can just put it in a sentence rather than say no surgery.
If there are level 4 and 5 nodes, the likelihood of it metastasizing is very high, lower down, and upfront surgery wouldn't be an option if there is level 4 and 5 nodes. The skin on the tumor, I mean, I can't see much of it, but the skin on the tumor looks inflamed, looks to have nodules. So again, skin involvement, wouldn't go for upfront surgery. Carotid involvement, less than one, not in this case, generally speaking, less than 180 degrees and no constriction of the carotid, we can still operate, but I don't know about the carotid in this, but looking at all the factors, I wouldn't go for upfront surgery in this.
Go ahead,
I'll agree to that, but I'll add, sorry.
Adding to what he said, if the carotid sheet is involved, it is primarily inoperable, it's difficult. If that is not so, you can also do the contralateral neck dissection, because some studies have shown that it is beneficial to do the contralateral.
No, in this case, 100% if I operated, I would do contralateral. Yeah. It's crossing the midline, it's a T3, T4, you must do contralateral. 25 to 40% will have opposite neck involvement. So Satakshi, you wanted to make a point?
Just in addition to the rationale, I think we all agree on the surgeons to that upfront surgery might not be considered in this patient. Just to add on to the rationale of what we may like to do, that neoadjuvant chemotherapy subsite-wise has shown benefit in tongue, number one. Number two, we'll also look into the reconstruction and the swallowing possibility of the patient. Rehabilitation is not going to be good for this patient upfront surgery. Number three, if the life expectancy of the patient as such is not going to be high, we'll not push for a morbid surgery. These three factors.
So I think again important points, whenever we say we want to draw the line, we look at anatomical constraints that we have. If we can remove structures, we will remove them. But we can't remove the carotid, we cannot remove the base skull, we cannot remove the prevertebral fascia, we won't operate the patients. This patient is operable, but here we will look at the biology. The patient with an N3, I can excise that big skin and I can remove this node, I can put a deltopectoral flap and reconstruct the tongue and radiate. But this biologically is a cancer that's going to fail. So the point that Satakshi is making, that if you feel the life expectancy is not there, then don't rush your patient to morbid surgery. So whenever we have to draw the line, it has to be a balance between anatomical structures and biology. And I say this because as I get senior, the juniors always want to operate every case. Every case they want to. They say, this guy's over the hill, he cannot remove it, I'll remove it. But you have to look at biology. Don't do heroic surgery and have your patient coming with skin nodules in 3-4 months. And I'm happy my surgical panelist agreed with me, though they are 1 or 2, 3 decades younger than me. Radoncs. I want to go back to this case. Can you make some point about radiation into the infratemporal fossa? All of us operate oral cancers and we believe you all guys will mop up the disease. So many of my colleagues operate infratemporal, it bleeds like hell. So they don't go wide. And they say, I've got great radiation oncologists who will look after. So tell them something about radiation to the skull base into the infratemporal in an oral.
So borderline operable cases, it is better to give concurrent chemo to know the biology of the disease. Because what happens is, if you do massive heroic surgeries, by the time the flap is taken up and by the time the patient is taken up for post-op adjuvant treatment, there would have been already recurrences. So to know in a borderline operable cases, it is always advisable to go for concurrent CTRTs.
CTRT. Point taken partially, but I can tell you as a surgeon, it's bloody mess to operate after RT. The chances that I'll salvage with surgery is very, very low. So, Satakshi, before you, your opinion, sir. As
I agree with Dr. Sairam, chemoradiation in borderline operable cases.
Upfront. What about the approach of giving neoadjuvant, giving your surgeon a chance to operate? All three surgeons, would you like to operate post-CTRT or post-neoadjuvant?
Post-neoadjuvant.
Neoadjuvant. So you can see the reluctance of the surgeons. If I cannot operate, I would give CTRT. Someone wants to make a point on the floor? No. Oh yeah, go ahead.
I'll just add on to what the other surgeon colleagues here mentioned. Of course, for our ease of operation in a post-NSCT field versus a post-radiation field, but also the survival of the patient, the data that we have supports that T4Bs are anyhow bad cancers. A very small percentage. The Indian Tata data suggests around only 50% of them can convert to surgery. T4B supranotch, I'm talking about the same case that we were discussing. So anyhow, they are bad prognosis, but who become operable have better survival. So we will like to still give the chance.
Of course, we live, man lives with hope.
NSCT plus CTRT.
Yeah.
They have poorer survival by half.
Yeah, but in the Tata paper, the 721, where I'm a co-author, all didn't go for definitive CTRT.
No.
The triaging of the 721 was that those that had neoadjuvant and came into the realm of surgery with appropriate adjuvant, the survival was double that compared to the rest of the group who didn't respond.
So I'll be just quick on that, sir, that if a case upfront, T4B supranotch, disease very extensive involving lateral pterygoid going up to pterygomaxillary fissure, we will go by what they are suggesting, CTRT, because they are very less likely to become operable anyhow. But few fibers of temporalis involved, few fibers of supranotch medial pterygoid involved, where we are still considering surgery, will go in SCT route.
So I agree with you. Probably we would give CTRT if surgery is totally ruled out. But a lot of my patients have trismus, poor oral hygiene, poor nutrition, whether they'll tolerate CTRT. They are symptomatic. I want very rapid response rate to alleviate their symptoms. So I still prefer the neoadjuvant route. Then subsequently I would send to y'all rather than give CTRT upfront. Comments from the other senior radoncs on the floor and someone right there. Yes, sir. Please. Who's that? Oh, Umesh. What are you doing in head and neck? I thought you're a gynec guy.
So thanks to your encouragement, I used to do head and neck,
Yeah.
as you remember, and I've started doing
When you
head and
found gynec more lucrative, you can
Yes.
go on. Anyway,
Yes,
go ahead.
But after you left, I have got again interest in head and
Okay,
neck. now in
please
my
tell
life.
us, Umesh.
Thank you. So I think point is, more important is surgeon is the most important prognostic and predictive factor for locally advanced oral cancers. If you are not able to operate an R0 resection, I think the next most important point is whether this patient is palliative or radical. And if patient is palliative, then you should go on various modalities like chemo or short course radiotherapy. If you think that there is still a chance for a radical treatment, then we err on giving neoadjuvant chemo, assess after 3 cycles, and then see
Radio.
See the biology and take a call on whether you can still go and do a surgery for R0 resection or go for chemo radiation.
Yes, sir.
The neoadjuvant chemo, in some cases, gives in 1 or 2 cycles very good response. But by the time they are taken up for surgery, it rebounces so much that it becomes inoperable again, sir. So this thing also we have to keep in mind.
Point well taken. If it's going to bounce so quickly back, it's better not to. So I tell the patient, they say excellent response, operate me Monday morning. I tell them, no, I'll wait for a week, 10 days. If it comes back, it's biologically aggressive. I won't operate. So your point is well taken. If it comes back, I will go the RT route. Yes, sir.
Even if there is a good response, the patient may run away from surgery also.
Will not have surgery.
Yes, the patient will say, I don't know.
Again, an excellent point. So let's quickly, we've got 1 minute. So I'll try to make some conclusive points and then we'll have some comments. So we'll give our patients neoadjuvant if it's inoperable. If they respond very well and come into the realm of surgery, we will operate these patients. And there's enough data from our country and now from others as well to show the benefit of this approach. If they don't respond, we have 2 options. As Umesh said, if they're going for palliation, they continue chemo, but please remember, more durable palliation in any patient is radiotherapy if you can give these patients rather than continue chemotherapy for life. If these patients respond to radiotherapy, please give them radiotherapy. But don't push your patients immediately to radiotherapy because that little window of opportunity that we as surgeons have to operate gets closed. So neoadjuvant will give you very, very good response rate, alleviate symptoms, bring some of them into surgery. Otherwise, they go the radiotherapy or just chemotherapy. Would you all agree? Anybody wants to make any points? Anything from the floor and we'll conclude.
Basically, as a cosmetic surgeon too, restoring form and function would be my primary goal.
Well
so
taken,
that is the whole point. The last would be, survival. If survival is a question, then I can't operate, can't pull it back from T4B to T4A. It's not operable up supranotch, something like that. Then probably RT is something else.
Well taken, agreed.
If surgery is too morbid or too mutilating, then we should opt for chemoradiation, I think.
Point well taken. Again, I agree with that. Any concluding from the floor or we'll get off because again, the interest of time, it's a... Yes, sir.
Just want to make one point that with the neoadjuvant chemotherapy and patient gets operated and comes for post-op radiation or chemoradiation, there are 1 or 2 aspects we have to, we feel we should be discussing. One is the enhanced toxicity. They are getting now 3 modalities of treatment with a lot of toxicity, both surgery, radiation induced. One is this. And the second is defining the post-op radiation fields, because there are so many radiation oncologists. So the target volume is either the pre-chemotherapy target volume, or it should be post-operative target volume, and sometimes the target volume is so ill-defined because the pre-operative details are not available, and sometimes the pre-chemotherapy details are not available. So that is a flip side of this kind. If it is done in a single hospital, I think it's better.
Better. A point very well taken, and we struggle with the same. Your target volume, we struggle, or we call it margins. It is a very, very important point. Well taken. Thanks again. I'm sorry we don't have time, 20 minutes. Thank you, panelists, for some great comments. Yes, sir.
So modern chemotherapy, concurrent chemoradiotherapy is not detrimental for most of the surgeons, because most of the surgeons who are doing large volume surgeries post CTRT are well unlike previous there are not much of reactions, and most of the surgeries following concurrent CTRT are very successful, sir.
Point well taken, but it's successful in other sites. In oral cavity, which has infratemporal fossa disease, or even if it has disease going up to the zygoma, I can operate, but I will not know my margins. The infratemporal fossa will bleed, please trust me. In larynx, hypopharynx, oropharynx, I'll operate post CTRT. There my margins are very, very well defined. Even tongue I would be able to operate because it's a compartmental organ. I know I can do a total glossectomy, come from the hyoid up, just leave the epiglottis. But trust me, all your good surgeons, if they operate on post-CTRT buccal cancers, it is difficult. And I have 3 surgeons who agreed with me. You'll have to believe us surgeons this time at least. Anyway, thank you. Okay, thanks everybody. Thank you.
Thank you, sir, for wonderful discussion. For next talk. Thank you, sir, for wonderful discussion. For next talk. Thank you, sir, for wonderful discussion. For next talk. Thank you, sir, for wonderful discussion. For next talk. Sir, for wonderful discussion. For next talk.
University in Vienna, in Austria, and give you my disclosures. So as you can see, I'm collaborating with almost all companies involved in immunotherapy, head and neck cancer. So I really try to give you a balanced view of the topic, doing my best. I'm also an investigator of the Keynote-48 study. So I think the treatment goals in head and neck cancer is definitely, as my previous, as your previous speaker mentioned, prolongation of overall survival. There's no doubt about that. But I think in the palliative setting, the treatment goal of symptom control is equally important. So it's a bit of a balancing act how to reach both goals in this setting. And on the one hand, yes, we want to prolong overall survival, but as you can see here, and this was mentioned previously as well, long-term survival in head and neck cancer is definitely an issue. So at the bottom of the slide, you can see here the higher the stage, and if a patient suffers from recurrence state, of course, many people die from head and neck cancer, and long-term survival might not be achieved. On the other hand, we know that response definitely is associated with quality of life. On the left-hand side, you can see that that's not much of the surprise, but you can see in blue that responders have a better quality of life compared to patients who are not responding, here depicted in red, the lower the better. But on the right-hand side, you can also see that in head and neck cancer, quality of life is associated with overall survival. Here, the higher the better, so a higher quality of life in blue, and patients are doing better with respect to overall survival. So how do we achieve this? And as I mentioned previously, of course, immunotherapy is an option. We know that the immune microenvironment in head and neck cancer, in particular also in oral cavity carcinoma, is a quite immunosuppressive one. You can see here all types of cells infiltrating the tumor tissue. Lots of those cells are immunosuppressive, suppressing the immune system. And I think it's also important to consider that there might be a bit of a difference between the Western population and the Eastern population with respect to the immune microenvironment, but also on the molecular level. There are different types of molecular alterations. PIK3CA mutations might be higher in an Eastern population, and the risk factors are different. So smokeless tobacco, I've learned, is the most prominent risk factor here for oral cavity carcinoma. In a Western population, we have different types of risk factors. Just think of the HPV disease. And this was not necessarily depicted in our Keynote-48 trial. So 18% of the patient populations were Asians. And the trial was not designed to address this question. This is the very recent update. It's the 5-year update from the ESMO we presented a couple of years ago, and this has quite recently also submitted for publication. So hopefully we have the full paper quite soon, depending on the reviewers. But yes, there's no doubt we have a couple of patients exerting long-term survival in immunotherapy. And as this was mentioned before as well, there are a couple of patients here on the left-hand side for pembrolizumab monotherapy where the curves are crossing. So we have early progressors. We have to be quite careful about that, and patient selection is definitely crucial. The response rates are quite comparable with extreme compared to Pembro Platinum 5FU. Yes, the higher the CPS score, the better the response, that's for sure. but also looking at the progressors, there seems to be the fraction progressing on immunotherapy or after immunotherapy seems to be higher compared to the extreme regimen, even in CPS more than 20 patients. And what's also a question, and I think we have to be very careful to draw a conclusion from this subgroup analysis, because this was a post-hoc exploratory subgroup analysis, so might not be fair to draw a very firm conclusion out of that. But as depicted here, in oral cavity carcinoma, the survival of advantage of immunotherapy seems not that clear, and for pembrolizumab, it seems that even extreme is better on the left-hand side. So a very exploratory analysis. Be careful about that, but it really indicates it might not be that the advantage for oral cavity carcinoma, in particular in local recurrent patients, is not that clear. This was presented at this year's ESMO Asia, ESMO IO meeting. Oh, sorry, no. This was presented at the ESMO Asia meeting 2019, a couple of years ago. Again, a subgroup analysis of the KEYNOTE-48 study. What about Asian patients, which only made up, or 18% of the KEYNOTE-48 population? In the upper part of this slide, you can see here blue are the non-Asians, these pink patients are the Asian subgroup, and as you can see, patients receiving pembrolizumab mono still do better. This was not seen in the non-Asian subgroup. It seems to be the other way around. If you look at pembro plus chemo patients, still CPS is a biomarker, obviously, both in the Asian and in the non-Asian subgroup. But again, exploratory analysis, small sample size, have to be careful about that to draw firm conclusions, but those are the data. And what I also want to mention and to address regarding long-term survival, because, and this is not only valid for head and neck cancer, but I think this is a very important topic we hardly cover, and it shouldn't prevent us from giving immunotherapy, but be careful. There might be chronic immune-related adverse events, and there definitely are. So just think about endocrinopathies, so thyroid disorders. It's a persistent disorder, so the patients will not recover from that. And there are also data that patients who were exposed to immunotherapy have a very increased risk of cardiovascular events here depicted in red, compared to patients who have not been exposed to immunotherapy, here depicted in blue. So I think not only valid for head and neck cancer, but quite in general, also given the fact that immunotherapy is given in the neoadjuvant and in the adjuvant setting, I think we should also explore a bit more about this. Another alternative, and this is what we also use in Austria or in the German-speaking countries, the TIPEX regimen. It's definitely an excellent option in head and neck cancer as well. There is not much of a survival advantage if you compare to extreme, but we have a very good response rate in a mainly European population, above 50%, which is quite nice, and we also observe quite early responses. We could also confirm that in a very small sample size, but in an Austrian population, this was quite comparable. We did it in this publication biweekly because it's a very, very easy to use regimen. Avoid weekly cetuximab, giving biweekly platinum and taxane plus cetuximab. But yes, the sequencing question is definitely in question, and in fact, neither KEYNOTE-48 nor TIPEX or Extreme haven't been a sequencing trial, so this hasn't been incorporated in the statistical design, and it's a very good question, and not that many data regarding the sequencing. In the upper part of this study, there's a Taiwanese retrospective analysis. They looked at the the sequencing cetuximab followed by IO versus IO followed by cetuximab-based regimen. So it's not cetuximab mono, obviously, it's a cetuximab-based regimen. And you can see here the outcomes are quite comparable. But the response rate on the right-hand side, the first place is much higher if you go for cetuximab IO with about 70% response rate. This is quite amazing. It might be really also the fact that it's an Asian population and not a Western. So I've never observed 70% response rate in the first-line setting. On the other hand, this was presented at the ESMO IO, when you look at the sequencing question, and again on the KEYNOTE-48 study, but again, exploratory post-hoc subgroup analysis, be careful. On the left-hand side, pembro mono, not that much of a difference of giving pembro followed by cetuximab-based regimens. It's in the CPS more than one population, so this is depicted here, and in the right-hand side it's pembro plus chemo, where you can think there's a signal that pembro followed by cetuximab might be more effective compared the other way around. So I think the question mark here is still there and still open. I've also learned that you're doing quite well if you use local India data. If you start with a cetuximab-based platinum taxane regimen followed by nivolumab, then you achieve response rates about 20 months, which is great, but of course it's retrospective. It's not retrospective, but it's a small sample size. We have to be careful about that. Oral metronomic chemotherapy, which is used, seems to be not that good. What we, and this is also a very small trial, is with a small sample size, but what I did and we did in Austria was a trial combining docetaxel pembrolizumab after first-line extreme failure, and we achieved quite comparable overall survival with 21 months, response rates which are about more than 20%, which is higher than we would expect with pembro monotherapy. We also did some kind of next generation sequencing, but there was not really, we didn't really find a biomarker. Again, it's a very small trial, but it's a signal. Just want to present a bit of a case and give you some consideration. A 67-year-old female patient, oral cavity carcinoma with a couple of recurrences and salvage surgery, and an intermediate PD-L1 CPS score. So what to do about that, and what's the perfect decision making? And of course, we have a couple of factors which drive our decision-making, which is definitely PD-L1 status, CPS. Is it a bulky tumor? Is it rapidly growing? What's the performance status? What's the symptoms? Do we need response up front or not? And what's, of course, the patient preference? And of course, in patients which need rapid response, we prefer a chemo doublet plus cetuximab or pembrolizumab. In this case, I went for cetuximab first line, Tipex. Patient had also some atrial fibrillation. So in Austria, pembrolizumab is approved with 5FU combination therapy. I really wanted to avoid 5FU in this setting. Very nice response, complete response, and the patient is doing fine. But what happens if you want to go the other way around? Yeah? If you give immunotherapy up front, then resistance is an issue. We have the crossing of the curve. Yeah? But even if a patient does respond, secondary resistance, acquired resistance, is an issue. And here again, and I definitely think that also if you give immunotherapy, or would give immunotherapy up front, a salvage therapy after immunotherapy failure should be cetuximab based. On the right-hand side, you can observe that cetuximab does a lot on the immune system, modulating the immune system. Chemotherapy modulates the immune system. We saw retrospective data which are quite encouraging that a taxane cetuximab regimen after immunotherapy failure is doing fine. And this is also my personal experience. Again, a 70-year-old patient lots of head and neck cancer in his medical history, oral cavity carcinoma again as a second primary. And even this patient, you might not see the tumor here that well, and there's a very high CPS score, 100, and I thought, okay, this is a low symptom burden, I don't need a quick response, let's go for pembrolizumab mono, have PD-L1 100, this works. And I did this for 1 month, so 1 cycle, and you can see on the right-hand side a very massive progressive disease just after 1 cycle. And I think it's really quite important not to stay on immunotherapy that long and really consider switching to a salvage surgery. And I think salvage systemic therapy in the second-line setting. And I think this is a case of hyperprogression. I believe that hyperprogression exists. There is a lot of debate around it. Is it the natural cause of disease? Is it, has it some molecular basis or not? I believe it has a molecular basis. We can discuss this afterwards, but for the sake of time, I cannot address this here. And immunotherapy resistance, there are a couple of definitions. What does it mean is definitely an issue. So I switched here in this case quite early to TPEX to salvage the patient just after 1 cycle. And we've seen again a quite major response, patient doing fine after 4 cycles. And we are now addressing this in an investigator-initiated Merck-supported study where we recruited 50 patients after first-line pembrolizumab failure. And we are now, the study, we have now recruited more than 50 patients. And we're now analyzing the data, hopefully publishing, presenting it this year. But what I can say is that we observe response rates far beyond 60–70%. And this is really quite encouraging, in my opinion, that salvage therapy with taxane plus cetuximab works. You've seen the NCCN guidelines before. What I also want to address briefly is the right part of the NCCN guidelines, which they address cetuximab, nivolumab, cetuximab, pembrolizumab might be an option. And why not combining the best of the 2 worlds? We know that the mechanism of action of immunotherapy, we know the mechanism of action of cetuximab, and it might be an ideal combination partner, of course. Financial toxicity is something which is an important thing to address. So this is really a quite expensive combination. But response rates are above 40%, or around 40%. We also saw similar data with cetuximab plus nivolumab. That's why they're in the guidelines. Unfortunately, they don't think they will do a phase 3 study, but activity is definitely here. And I observed that as well in a 57-year-old male patient. A couple of recurrences, now has a base of the tongue recurrence with a quite low PD-L1 scoring and relevant comorbidities. So I really thought, and sorry for this not perfect images, but you take my word for it, that there is the tumor. It's a rapidly curing tumor, and definitely thought this patient is not suitable for doublet chemotherapy, which would be needed to control this tumor. So what to do? And I think, okay, let's go for off-label pembrolizumab cetuximab combination. And the patient had a very, very excellent response on this combination. It really worked fine, a near complete response. But never forget, if you combine 2 types of immunotherapy, you even might get immune-related adverse events. And this patient had a very severe GI toxicity. In that case, diarrhea, pneumatosis, there's lots of air in the very, very, very severe colitis. So we had to start with corticosteroids, we had to stop therapy. It was a grade 3/4 adverse event. He had 10 times per day the stool, so it was really an issue, and we stopped it completely. But the patient recovered, and he was in my office 2 weeks ago, and is still, without any therapy, has still near complete response. So It's a pity that this regimen is not explored further, I think. Of course, this is anecdotal. I don't do this on a regular basis, but yeah. But definitely in the last couple, 20 seconds, perhaps I need a minute or so, there are different types and novel types of options such as BCA 101 in combination with pembrolizumab. We saw that at the ASH committee in combination of a TGF-beta antibody with an EGFR-directed approach. And on the right-hand side, there was a very, very encouraging response rate, in particular in HPV-negative patients, including oral cavity carcinoma, with around 70% response rate, which is amazing, but again, very small sample size. They talked with the sponsor of the study, and they are now planning a phase 3 study. And this is my final slide. Definitely head and neck cancer and oral cavity carcinoma exerts an immunosuppressive microenvironment. There are important differences between Western and Asian populations, and I think both cetuximab chemotherapy and or immunotherapy chemotherapy should be used to optimize survival, response rate, and quality of life. So I don't think it's either or. I think both should be used, but still novel approaches are needed. These are impressions from Vienna. Thank you.
Thank you very much for that provocative talk. So we can have few questions, and there is a little change in the program. You want to announce? So we can ask one or two questions if somebody has. Mike, please. Mike.
Thank you for all the presentations. My name is Dr. Deborah Omedo. I'm a pediatric hematologist oncologist from Kenya. We do see a lot of nasopharyngeal carcinoma in children, much more commonly than we see in the literature, especially in the Western literature. I just wanted to ask you and all the other panelists, what's your experience with nasopharyngeal carcinoma in children, and how are you handling it?
So this is quite a difficult question for me, because nasopharyngeal carcinoma is quite an orphan disease in Europe. So I'm not that, I have just a few patients, might be different, which are in Europe are quite often HPV negative as well. So I think I have to give the question back to a pediatric oncologist or someone who has more experience on this topic.
So if the patient is not responding with immunotherapy, can we give biologicals and chemotherapy subsequently?
Yes, I would really think that we should switch quite early on. So I wouldn't wait for 8 or 12 weeks period doing if you have clinical symptoms, the patient is doing worse, has a higher symptom burden, he tells you, okay, my pain is increasing. I wouldn't wait for 3 months and waiting for some miracle pseudoprogression, which we hardly observe in head and neck cancer. I would really, and as you said, we are losing patients between first and second line. I think we are losing patients perhaps also that we are staying too long on the therapy. I think switch early to a salvage regimen is quite important.
Can I answer the question that lady asked? I think in India also we don't see nasopharynx in the childhood. It is more of adults and mostly the adult disease. Has anybody pediatric oncologist here? We haven't seen much in India. Sorry, we can't add to your experience. And what do you think? They behave differently from adults? Yeah.
Yeah, I think I have a two-pronged question. One, in the keynote 048, there would have been some adverse events that would have been seen with immunotherapy. And there is a hypothesis that people who do get adverse events on immunotherapy tend to be the long-term responders or survivors. Did that happen in keynote 048? And two, how long was pembrolizumab monotherapy or pembrolizumab maintenance given? Was up to 35, or there were people who were still going on after that also?
So in general, let's start with the second question because it's a quite quick answer. I try to follow the protocol. It's 45 cycles, but of course, for patient preference, and if you don't have any financial considerations, I also go for longer. The first question is much more complicated. Yes, there are data, but there might be the so-called there might be the immortal time bias in there. So obviously, patients who are living longer, they have more time to experience immune-related adverse events, because if a patient doesn't respond to immunotherapy, he's going to die, and he doesn't have the chance to experience immune-related. So this might be a heavily biased thought, and we should do trials or some landmark analysis. I think this question is open. Yes, there are publications there, but I would be quite careful because there is this immortal time bias in this consideration, and perhaps we're just addressing something else.
Can I ask one question? What is the difference between hyperprogression and pseudoprogression? How you differentiate?
Okay, so in pseudoprogressing patients, it just seems like the tumor is growing because there are many cytotoxic immune cells infiltrating the tumor. So you do an imaging, the tumor looks bigger, and if you're waiting another 6 to 8 weeks, you observe shrinkage. So it's an immune phenomenon. For hyperprogression, this is a true progression where the tumor is rapidly growing, and the question is, does immunotherapy even promote that? And what's the molecular basis on that? There are considerations that T cell, follicular T cell expansion is responsible for that. Those are immunosuppressive. So that with immunotherapy, you might not only activate cytotoxic T cells, but also immunosuppressive T cells, promoting progressive disease and shifting the microenvironment to even more immunosuppressive.
This is the last question because we are in a hurry for the next session.
Yeah. Nasopharyngeal cancers in pediatric population or adolescents behaves more like a lymphoma, sir. And they require prolonged chemotherapies only, sir. Yeah. They're hardly, I mean, this is because we have Neelofer Hospital just besides MNJ, which is the very big pediatric hospital, sir. Okay. So we have a lot of such cases. They behave more or less like a lymphoma, so they have more chemo responsive tumors.
Okay. I think this session comes to an end. Thank you very much. And an announcement from the House.
Thank you so much, Dr. Anand, and thank you so much, Dr. Thorsten. It was, I could not completely attend it, so I would not be able to say, but I think you had engaged the audience so much, the questions weren't coming to an end. That speaks so loud. You could see the arrangements going. We've done a slight change. Good morning to all of you. We've done a slight change. Then we are shifting the newer radiation modalities to the session after the healthcare leaders session. So there is a session on healthcare leaders session in partnership with CNBC. We'll be starting that and looking forward again to a very brain enticing session, discussion amongst the leaders of the healthcare. We will have Dr. Ashutosh Raghuvanshi, who is the MD and CEO of Fortis Healthcare, Dr. Om Manchanda, Managing Director, Lal Path Labs, Mr. Dilip Jose, MD and CEO, Manipal Health Enterprises, Dr. B.S. Ajay Kumar, Executive Chairman, HCG Limited, and Dr. Vineet Datta, Executive Director, Datar Cancer Genetics. So looking forward to that session. They will be here any moment. And this will get featured on CNBC. And yeah, just getting ready for it. Thank you all. Thank you all. May I please request Dr. Ritu Garg to take us through this heartwarming session, brain enticing, and I can think of a lot of things that it will do to us. Please, Dr. Ritu.
Welcome to all of you, and thank you so much for joining us for this very special session that we have today. For last 2 days, we have had very enriching sessions with the best experts in the country to deliberate on scientific sessions, advances, recent developments that are going to transform the cancer care in the world. But somebody has to make it happen. And the business leaders, I think they play a critical role in providing an ecosystem to foster innovation, provide collaboration, and actually set the direction for the healthcare organizations and to a larger context, set the direction for the country. And we are very privileged to have a very august and very eminent set of healthcare leaders today. With further ado, I would like to welcome Mr. Dilip Jose, Managing Director and CEO of Manipal Health Enterprises Limited, an integrated healthcare service system with 33 facilities and over 9,500 beds. Dr. Om Manchanda, Managing Director of Lal Path Labs. He's worked across multiple companies and successfully transformed Lal Path's lab. Dr. Ajay Kumar, medical oncologist, entrepreneur, thought leader, and executive chairman at CG Group. Dr. Ashutosh Raghuvanshi, Managing Director and CEO, Fortis Healthcare. Dr. Vineet Datta, who brings together an experience of 20 years in patient care and is the executive director at Datar Cancer Genetics. And to moderate it all, we have a very special guest with us, an award-winning journalist and editor with CNBC, Ekta Batra. Thank you.
Hi. Good afternoon, everybody. Thank you very much for joining into this conference. Well, we are going to be discussing a topic which is extremely relevant to India as well as the globe, and in this prestigious conference and very relevant conference, which is sponsored by Fortis. So before we start, I just want to put some statistics out. 1 in 9 people are likely to develop cancer in his or her lifetime in India. India ranks 3rd after China and the US in terms of new cancer cases. Only 30% of cancer patients survive 5 years after diagnosis in India, and the household out-of-pocket expenditure of healthcare, though it's improved to 48%, it's still lower, it's much higher than the global average of 18% as of 2019. So this is where India stands in terms of healthcare expenditure. We also have some other statistics. India has the second highest rate of oral cancer cases worldwide. 1 in 28 women in India are likely to develop breast cancer in their lifetime. Cervical cancer is the 3rd most common cancer in India with an incident rate of 18%. These are just a couple of statistics to put into perspective the cancer burden that the country has. So without further ado, I'm going to bring in our panelists to discuss this problem and the way forward and where exactly does India stand. Thank you very much for joining in, gentlemen. Dr. Raghuvanshi, let's open up the panel with you. Why exactly do you think India has such a high cancer burden?
Thanks, Ekta. I think in India we are exposed to several environmental factors which probably contribute to this. Air pollution, pesticides, use of antibiotics indiscriminately, etc. Plus, on top of that, there's a lot of prevalence of viruses in the environment, and a lot of scientific papers suggest that inflammation could be one of the precursors of cancers. So I think that's how, because of the environment, it happens. And that is why I think it is very important to understand that the prevention is not only about tackling the disease directly, but also looking at the hygienic factors around. And that is why the public health engineering budget also, in my view, should be considered as a healthcare budget.
Okay, fair enough. Dr. Ajay Kumar, you know, you're an oncologist, you do practice actively. Can you tell us why exactly does India have such a high cancer burden? Yes, we have progressed a lot in terms of treatment, and we'll get to that in just a bit. But we do have some of the highest cases. Our burden is rising. We are lower as compared to other countries. So give us a sense in terms of what the structural systemic issues India faces when it comes to cancer.
Yeah, I think regarding the cancer burden, as we know, unfortunately, we are seeing higher, but compared to the Europe or US, the statistics we have, I'll come to that in a minute, is still not there where we are. We are still lower. You know, like 1 in maybe 9 people getting cancer compared to 1 in 5, 7 in US and Europe. But having said that, one of the things we lack in India compared to the more advanced countries is a national cancer registry, which I think it's very, very important, crucial. And I think this is where we have to bridge the gap between the rural and urban India also. Understanding the real incidence of cancer and what are the types of cancer and what stages they come will help us a lot to really take it to a next level of more prevention, understanding prevention, then going on to, in terms of what should be the early stage cancer treatment, where our outcomes will be very good. But what is happening now is, for example, you take rural India. We really don't have an idea what is the incidence of breast cancer. It is quite possible the breast cancer in rural India is far lower than urban India. Whereas cervix cancer may be more, but it is dropping quite significantly. So how we allocate our resources also becomes very important. For example, what is the point in having mammography units in rural India if its incidence is low? So whether we should do more of that in urban India, and because breast cancer is a lifestyle disease, any cancer is. And women in urban area, because of their lifestyle, eating habits, we are going to see more. 1 in 4 in future may be breast cancer, 1 in 5. So how do we take precautionary measures now? How do we teach the population so this won't happen? So we learn from the West, the mistakes they have done. Similarly, why we should focus on certain rural areas, more focus on maybe vaccination and bringing down the incidence of, pretty much cervix has been eliminated in the West. Pretty much. Why can't we do that here? And oropharyngeal cancer. So we are at crossroads in India. And one of the things we always talk about is India as a whole, but I believe we have to segment India into affluent India and not affluent. And affluent India itself is as big as United States. How do we address that? How do we address the non-affluent and bridge the gap? So this is the challenge, and this is where private, public have come together to play a role. And unfortunately, that has not happened to the extent we want.
Dr. Dattar, what about you? Why do you think India is where it is when it comes to its cancer burden, the statistics that we spoke about when it comes to cervical cancer as well as head and neck cancer?
See, the problem that we face is on multiple fronts. One is that we're lacking early detection across cancers where there is significant amount of evidence to suggest that that can have an impact in terms of early diagnosis, better outcomes, positive impact on cost. And when you look at across global metrics, whether you look at breast cancer or cervical cancer or lung cancer or prostate or colon, where there is sufficient evidence to suggest that screening needs to take place, we're not there. So one challenge you have within the ecosystem is that we are detecting cases far too late. Hence, the problem with our system is navigating rather than curative, but is to minimize spread or further expansion of disease. That's one element of the problem. The other problem that you have is more fundamental, which is the fact that you really need to rethink for a country like India, the dynamics that have worked overseas may not work here. And for that, the
primary element of the change I'm seeing across at least the oncology community now is that we are starting to gather our own data. The genomic space which I come from, data was established years ago to suggest that how Indian patients behave, for example, in the lung cancer space in genomics is very different to the West. Why would we then follow their guidelines rather than build in our own guidelines basis the data that we have as part of that ecosystem? The second problem that we have is with regards to access. So access, this rural versus urban divide is one element of that process, but that's largely again been driven by education. It's only been in the last 10 years we've started to see positive influences, for example, of things like, for example, basic things like sanitation. We're talking extremely high level things at the minute, but you've got to fix the basics. You've got to have housing, you've got to have clean water. Those are things which will impact infant mortality. They will impact women's health. They will impact the outcome in terms of some of those diseases, including cancer within that space. And I think lastly, more importantly, we've also got to look at within the ecosystem of education. Please understand, screening and early detection is always a behavior change. Never happens overnight. This needs culmination of decades of sustained effort to make those things happen. So when you have things which are preventable within the space as a country, if I cannot prevent the preventable, for example, an HPV vaccine for cervical cancer in women, where uptake for screening is less than 10%, it's a serious problem. And I think we were discussing this just before the panel started. When you look at healthcare, and healthcare budgets are, well, they're way above my IQ, but you really need to have a CXO at the level of the health ministry to look at oncology as a separate domain. You're a young country today. You are a young country today. Please understand the dynamics of economics in the West, where we have trained, a majority of us have trained, those systems are falling apart. Patients are living longer. There's a higher cost element to that treatment that needs to be provided. Somebody's got to pay for it. And if it's a public healthcare system, it's draining your resources. And in 20, 30 years, we will not be that younger country. If we are thinking only till 2029, it's a different story. But for those of us who want to lay down the foundation for this country in terms of improving healthcare dynamics, oncology is the new cardiology in town. You have to invest into oncology, and that has to be driven through prevention and early detection. Treatment is another dynamic which I'm sure we'll discuss today, but it has to be the focus of looking at a sustained strategy which does not move from one budget to the other, but over a 2-decade plan. What do I want to achieve as a country in 2035? Where do I want to be in oncology in 2045? You define those metrics and then you put action plans in place which are sustainable, which are cross-government. Doesn't matter which government comes in. But you have to build in those programs, and it has to be built in through the foundational element of that process. It may sound utopia today, but if we don't do it today, in 20 years, we're in a shitload of trouble.
Okay, well, I'm sure we're going to have a lot of questions towards the end of the panel, and I'm going to open it up to the public. But Mr. Manchanda, you know, you've been conducting tests across the city, and this is something that we spoke about the India rural and urban divide. Based on the data that you've probably seen through clinical testing, what is the difference that you see which stands out in terms of what is taking place in urban India vis-a-vis rural?
Yeah, thank you. As I'm preparing for this panel discussion, I've done a lot of data analysis as well. So maybe I'll share something which is based on our internal data, may not be representative for the country. I actually couldn't find much divide between rural and urban because most of these samples that we get are collected from hospital setup. And many times we don't know where that patient is coming from because the sample is being sent to us from a hospital.
Or maybe even if the trend that you've seen in the past 10 years.
Yeah, so few data points I'll probably share that the number of samples that we get, about 15 to 16% cases are positive for cancers. 16%. So if I get 100 samples, nearly about 15, 16 are positive cases. Interesting thing that I found was that the gender split, male and female, is nearly equal. But what is actually a very sort of startling or worrying factor that I found was that more than 50% cases are below the age of 55. Now, you can attribute to this whether it's getting early diagnosis or the incidence going up. I really can't make that out. Another thing that I noticed that females are nearly cases which are positive between 36 and 55 years of age, 60% are females. Now, I think the question that you asked to earlier panelists is what is causing, and the most fastest sort of growing cancer that I find in our system is head and neck. And it's very clear that lifestyle factor, this whole tobacco is biggest reason for that. And pollution, the environment itself is causing. So in my view, I think we are discussing about treatment and diagnosis. I think we need to discuss more about what is causing it. And attacking that is very, very important. So to me, I think head and neck is number one cancer that I see, at least in our data. On urban-rural divide, I think one can safely assume that rural cases are coming in advanced stage, urban are getting more diagnosed early, mainly because of facilities that are available. So as of now, I probably don't have firm data to share in terms of what is the divide between urban and rural, because most of them are actually getting picked up in urban setting.
Anything specific that you've noticed in the past 10 years in terms of a decadal change?
Yeah, I think that's an interesting question. I think this whole COVID has caused a bit of unevenness in the data flow. I'm not seeing in terms of very high rise of cases being sent on diagnosis. But one trend that I'm seeing now is that it's not just histopathology, because a lot of these advanced testing like IHC or NGS, typing of cancer has become very common test in terms of finding out what is the line of treatment doctors need to follow. I think those tests are actually on the rise.
Okay. Mr. Dilip, you have hospitals all over the country. If you could give us a sense in terms of, say, the trend that you've noticed in the past 10 years, and whether you have any kind of sufficient data to assess this divide that we're talking about when it comes to urban and rural, because while we talk about affluent, and I'll come to, the out-of-pocket expenditure, the rural part of India also suffers from a cost burden. Yeah. So is that one of the reasons why you see them coming in late? The trends that you've noticed urban-rural as well as maybe in the past decade or?
Thank you, Ekta, and pleasure to be here. Thank you, Dr. Raghuvanshi, for asking me to join you at the summit. Good afternoon, everybody. I'm probably one of the rare non-doctors in this room. I think Ekta and I, maybe one or two others. And I must say, from the time we started the pre-panel discussion till now, it's all been depressing statistics. It sort of feels good to be alive at this point with this kind of statistics. That we are all glad that we are alive in this room. That's a sad way it is getting portrayed. But having said that, in the Manipal system, I have my doctor colleagues, several of them in this conference. What we find is that about 10% of all the patients that we see, we admit and treat, are for some form of cancer. And it is increasing, the trends are increasing, and like the learned colleague said, part of it would be on account of this increase in capabilities of diagnosis, whether in rural area or urban area. The increase in capabilities of diagnosis is sending more patients to seek treatment. The second one would be, at least in the early stages, there is an increase in insurance cover and increase in affordability that is allowing people to sort of access treatment. These two are important trends. But what we notice is that maybe 1/3 of these patients that we are treating are from out of geography, so to speak, people who are not in the normal catchment of our hospitals. We got 33 hospitals across the country, and most of them do have oncology facilities. And what we see is that 1/3 of our cancer patients are from outside of the geography. So, Ekta, to your point about the cost, what it means is a lot of patients are traveling over distance, long distance to access treatment. And in that case, the cost of treatment is not only the hospitalization cost, it is the family who accompanies them, their logistics cost of staying outside. So pretty soon it becomes completely unaffordable. The one sad part about insurance is that while there is a growth in insurance and increase in number of people with insurance, from a cancer treatment perspective, the coverage is often inadequate. The doctors in this room know that even at the cheapest of kind of setting, it would cost 4 or 5 lakh rupees. And Dr. Ajay Kumar was talking about earlier, breast cancer treatment in India today costs about 6 to 8 lakh rupees. And an average healthcare insurance cover for a middle income family is 4 or 5 lakhs per year. So you run out of that, the coverage pretty soon, and then you can't stop the treatment midway. One unfortunate pattern that we see is that, people discontinuing treatment, discontinuing chemotherapy. Maybe if they are prescribed 10 cycles, maybe after 4 or 5 cycles, they said, we can't do. And it is a horrendous situation for me as a manager, and even more heartbreaking for doctors who are treating them. So this is one trend, Ekta, that we are noticing.
So that is actually a very important trend. Dr. Raghuvanshi, I'm going to get you on board for this. Out-of-pocket expenditure, 48%. And even if you talk about, outpatient expenditure, cancer is a majority component. Inpatient expenditure, cancer is a majority component. Insurance coverage, while it's rising, it's still rising. It's not covering, majority of the population at this point in time. So a lot of people actually get into poverty when they actually come for cancer treatment. And the best cancer treatment, whatever that might be, is only mainly available in private settings. From that perspective, what do you think need to be active steps that need to be taken in order to probably solve this issue?
Yeah, as Dilip was pointing out, I think the inadequate coverage of insurance is the major problem. Because the total cost of the treatment cycle, it is not an episodic treatment, but it is a treatment which goes over a period of time. So that is the major problem. And I think there are multiple things which need to be done. There are direct measures which need to be taken. One is to see whether there could be some critical care coverages, which some of the insurance companies have already started offering. So that is one sort of safety guard which people can have. But that again increases the cost in terms of premium, but at least it prevents a catastrophic situation for the family. So that is one thing which should be encouraged in my view. Other than that, I think early diagnosis is the key, because the cost of treatment as well as the outcome matters a lot at what stage you start the treatment and how early you start it. So I think there should be a lot of focus on that part. So these are the two main measures, I think, which can be taken.
Dr. Ajay Kumar, come in on this, because you probably have a lot of people who you see also retracting from treatment, or their treatment goes on for years and they have maintenance costs also which come through. And many of the times it is the head of the family who has cancer and is not able to provide for the family, so the burden just increases. So in that vicious cycle, what do you recommend to a patient? Is there public infrastructure which is sufficient enough to probably help in terms of balancing that out?
Yeah, it is, essentially in India, unlike in US, where I never worried about the cost. The patient comes, we do what is the right treatment, because most of the insurance covers. And one of the most important thing, like in US, unlike what Dilip mentioned about a limit, there are no limits. See, I am myself a Medicare recipient. I can go to any hospital in US and get free treatment. There's no limits. But unfortunately in India, we don't have that kind of a limitless universal healthcare, which we have all been fighting for. But at an individual patient level, the dilemma as doctors we face is essentially we know what is the right treatment to give. Suppose there is a 25-year-old patient who has limitations, scheme or insurance, but I know the treatment she requires for a breast cancer, which could be long-term control, involves using expensive medicine. How can I deny this? Morally, ethically, I cannot deny. Knowing. You cannot say you can't afford, I won't do. So it really comes down to what is the awareness the public sector has about it, why they don't approve certain drugs, it is a constant battle for doctors. Now, doctors are also financial managers now, because we have to tailor make what can this, in my tumor board clinic, when the recurrence happens, I ask, why did the recurrence happen? Oh, the patient couldn't afford this treatment. So it is very disheartening for us when we know what is the right technology to use, what is the right drug to use, but we are denied. So I think this is where we are muddling along in our country. But having said that, it is possible to establish systems, in answer to your question, to make sure they are not denied. So we have to do extraordinary measures like crowdfunding, foundation help. So we make sure, at least in our system, nobody is denied. And that was our Harvard case study saying, how is it possible you don't deny? For example, let us say a kid needs a cyber knife treatment in the course of treatment, which costs about 5 lakhs. And you can say at 11 o'clock in the night you come and take free treatment. Why not? Because CyberKnife doesn't require any out of pocket from us. So we have to create an architecture which supports this for people who come into the system are not denied. That is the best we can do. Can we go and say whole nation has to change to meet this demand? Is a daunting task. But that is where government has to step in and say, hey, I understand, but there are governments in India who have done it. Like you take, for example, state of Orissa. Phenomenal development in terms of reimbursement. Phenomenal. They have been a leader. Pretty much what the private insurance they pay for their scheme patients. So their patients are now getting, in my view, the best of care. We are trying to make it a model and present it to others to see, can we use this model? When Orissa can do, why not? So we are moving in the right direction to bridge that gap. Maintenance therapy, long term. But one thing I want to say as an oncologist for 48 years really, we cannot say no to a patient. Doesn't matter, private, public, whatever. We have to come up for that patient a formula so that the patient gets the right treatment, not deny. And this is the constant battle for doctors, hospitals, everyone. But we have to say, okay, it will compromise maybe 0.1% of my margin. That's okay, let me treat. And I take, personally, I take a lot of pleasure because I have empowered as a doctor. May not be, everybody is not empowered. Suppose if somebody comes in and says, this patient wants some given discount. When I say discount or free treatment, I feel so good that I am empowered to do that. And my request is that let all doctors should be empowered in the system, private, public, to do that. I think that is bridging the gap and say, hey man, I don't mind taking a cut in my profit. Let us do it for this patient. I think that is the fundamental norm we have to establish.
But does a private equity owning the hospital change that?
No, I think we have private equity. We are a listed company. I say, get lost. What are you going to do? Because doctors are the backbone. If the doctors stand firm and say, I'm going to do this discount, what are you going to do as a group? They can't do anything. I don't know any of the, because we have to believe in it and do. I am sure the administrators, managers also are concerned about it. They will come halfway and make sure it is done. Because I think in my view, again I'm going on a limb here, if I can, it is not correct to make a profit of 30%, 35% margin. No healthcare should. We should set a limit. Am I okay with 20%, 22%? Set the limit and do it. And if a private equity doesn't want to come, public are not interested, it's their problem. So we have to work on this. Some people say healthcare is your right in India. Some people say it is a must. Everybody should be met. We all talk. But are we practicing it? We have to. And who are our things who come in our way? Maybe the investors. We have to convince. In my view, I think majority of the investors, once you talk about it, will be convinced. We should not worry that much about the stock price, worry about what is the right for the patient. If you worry about it, stock price will automatically come. I think medical excellence, it will come.
Mr. Dilip, you're not listed, but but you do have a private equity which has taken over Manipal hospitals. So has anything changed for you all?
I knew that question is going to come to me soon after. I am telling you honestly, I knew the question is coming to me and I was thinking what I will say.
I want that architecture of providing, compensatory.
No. So Absolutely. I think, all of us, I think there are many CEOs on this panel, and I think one thing that we all struggle with in healthcare is that, how do we say no to a deserving patient, for sure. Not only because what we should understand is no patient comes to the CEO. I don't think, Dr. Ajay Kumar is a practicing doctor, but other than that, a CEO does not really come across a patient most of the time. It is a front-end hospital directors who like to take these decisions. I think one, of course, Ekta, we like to understand that it is important to ensure that a deserving patient we make every attempt to see that a patient is taken care. But there would be a limit, unfortunately. I'm saying, oncology is one example. In a multi-speciality environment that, we come across so many deserving cases. Imagine a case of a polytrauma victim coming after a road traffic accident to the ER. Maybe the head of the family, head injury, and needs an immediate surgery. No insurance, no other support. What do we do? I'm saying every attempt is to see that we provide help. But unfortunate fact is that, in all honesty, let me say that every element of the cancer care is expensive. That, technology, the medication that is involved, and the people that are involved. I think, every element of cost of delivery of cancer is expensive. So there is a limit to which we may be able to constrain, we may be able to reduce that. I completely agree that we may not require a 30% margin. But then for sustenance, we may require a 15 or 18% margin, which is fair enough. I think that has to be an understanding that hospital sector, the environment sort of provides for it in the sense that there is price control, there are margin controls which are in play, which would ensure that over profiting is not done. But eventually, to the defense of everybody who's an investor, I must say, India's healthcare sector has grown in the last 2 or 3 decades on the back of private equity investments which have come. It is not because of government investment, it is a private equity investment which has created technology, created beds, and reasonable returns are to be expected. What is reasonable, one can debate. But all I want to say, in the hospital, we struggle with this decision of who to say no to, and it is, we are in a cancer summit, but if you are in a cardiac summit, we will have the same challenge. Somebody comes with a primary, comes with an MI, would require a primary angioplasty, could save his life. Do we do a primary angioplasty? So I'm just saying, cancer is a topic today, but in healthcare in general, we struggle with that query every day. We don't have an answer. It has to be that doctor said, a collective wisdom that, look, we need to have a limit on what we want to do.
All right, so that's on the financial aspect, but I'm going to come to the early prevention bit. And Dr. Datar, I'm going to get your thoughts in on this, because there's been a lot of focus in terms of how early prevention is the cornerstone of oncology. What is the progress that we've made when it comes to testing as well as early prevention? Something which probably doesn't even deter somebody from getting tested for preventive oncology.
So let me start off by saying, thankfully, Ajay and Dilip will not be able to trip me on the fact that I'm neither listed nor I do have external funding. So I fund my own activity, which is great. So I decide every Friday or Saturday not looking at Excel sheets, which is a true benefit as a clinician. It comes back to behavior. And I was talking to some of my Fortis colleagues yesterday that behavior starts with me. The change that we want to bring into early detection as a precursor is prevention, and in that space, it's at an individual level and it's at a systemic level, which is at a public health space level. At an individual level, how many of us start at 7 in the morning and end maybe at 11, 12, 1 in the morning? This is not sustainable as individuals, as doctors, as healthcare leaders. If I don't take care of myself, I can't take care of my company. And when we look at the way our behaviors have been modified over the last 4 or 5 decades, do you want to take a break? Do you want to take a chocolate? No, I probably want to walk out with my dog or play with my son as a physical activity in that space. Somebody brought up this point about processed foods in terms of what are we eating. The foods that we're getting into the system are not just toxins of the air that we're breathing. This aid of food coming into our kitchens now, which is pre-made, pre-processed in plastic containers, which we are reheating in a microwave. We just do not understand the damage that we are doing to ourselves as part of that ecosystem as an individual. So it has to start with me. Has to start with me, myself, my kitchen, my home, my workplace. That's the way I look at the individual subset of that place. Then you look at a systemic level, what are the major challenges that we have? We have good data to suggest that putting together a systemic plan of screening for breast cancer, for cervical cancer, to a large extent for prostate, for colon, and for lung, there is good data, but you will have to prioritize which are your major pain points today. You can't do it all. And you have to be extremely pragmatic because you work within the structure of a country with limited resources and fundings, and we understand, we know what our GDP support metrics are towards the healthcare system, but it has to be put into prevention and early detection within that space. As long as you make sufficient amount of investments into educating, empowering various different populations across the diaspora of urban versus rural, I think this is really where that value is going to come in. And please understand that we are not even there yet today with regards to the standardization for the screening where there is data. The horrifying fact is that 60% of cancers and 70% of deaths come from cancers for which there is no screening at a global level. Forget us. So screening will create one element of support, but it has to be largely driven at a significant element by prevention. So we discussed a lot of things like tobacco. You have to walk the talk if you're looking at tobacco within the system, which is a significant insult, for example, for head and neck cancer, as one example in that space. When you look at various different dimensions, we spoke about earlier in the morning about mammograms, rural versus urban. What is the data? It again comes back to what are your gaps? If you do not understand gaps, you cannot fix them. So you need to understand across the country on a broad spectrum, which are the areas where you want to align goalposts to say, okay, I want to look at breast cancer reduction in this. I want to look at cervical cancer. I need to look at an HP vaccination program. I want to look at the fact that my uptake of pap smears is abysmal. How do I bring it up through education? How do I bring it up through women's empowerment? We are making changes with regards to sanitation, the Swachh Bharat, the toilets. That next element needs to be linked into this space. So this brings in what I do for myself and what I do at a country level across the second dimension. And I think the third and most important with regards to that process is also looking at providing access. It's important that we provide access across the ecosystem, especially for those where there's disparity in terms of that access of care. And that's going to be very, very important as we build into the technology. So we may talk about the fact that there are limitations even in our current screening programs. The mammogram itself comes with limitations. Yes, it'll miss some few cancers. It may create an issue of some false positives, but those are limitations of what we understand in the system. I always tell my work colleagues, when you're dealing with oncology, you are dealing with an imperfect ecosystem. You are not going to make it perfect tomorrow, but let's make it less imperfect. Let's take a step in the right direction to make sure we're not repeating the mistakes which others have made either in our country or in other countries. Let's look at, with our limited resources, what do we want to prioritize in that space? And screening has to be a significant element of it because, as everybody has said and everybody agrees, significant impact in terms of looking at downstaging disease. We want to capture those 3 and 4s at 1 and 2s.
So correct. Mr. Manchanda, what about y'all? What are y'all doing when it comes to early detection cancer screening?
So I think each enterprise has a role to play, and we believe that our role is not only to diagnose accurately, but also to help the ecosystem to diagnose early. I think a lot of efforts are actually going in that direction. I personally believe that for cancer, I think the biggest thing that we need to do, not only as an organization, but collectively, is just awareness, awareness, awareness. I think many of us have to play that role of educating patients or population in general. And also, I think the medical ecosystem, especially down the pop strata, also not fully aware about many of these things. So our role actually comes in when the test is prescribed. So we want to make sure that how early the test can be prescribed by a clinician.
but clinician can only prescribe test if the patient actually goes to the patient, to the clinician. So I think it's awareness starting with the patient itself and then goes to clinician. And then as far as our own system is concerned, I think as I was mentioning to you this morning that we have a network of nearly about 277 labs, network of 5,000 collection centers and pickup points of nearly 10,000 or even more. So far, a lot of our testing was very centralized. Now I see that we have opened a lot of hub labs through remote pathology, digital pathology. So I visualize as an organization a pathology grid where the excess of testing is virtually going down the pop strata. Nearly about 35–40% of our business actually comes from smaller towns. So I believe one of the roles that we can play to early diagnosis to improve access of testing and at the same time put a layer of creating awareness in the ecosystem about early diagnosis.
I think it's also important to point out now the success of India when it comes to oncology. While we've spoken about the negatives and the burden, Dr. Raghuvanshi, you know, we were just talking about before the session started about how many Indians who could afford it are now even probably not even going abroad for treatment anymore because of the accessibility that they have, the affluent has when it comes to cancer treatment. What is the progress that India has made when it comes to cancer treatment? Where are we when it comes to cutting edge technology versus, say, our peers in the US and Europe?
So a lot of changes happen in India, and the trend of people going abroad is becoming is practically gone away, and people are staying on in India. And the reason for that is that the accessibility has improved, and all the cutting edge technologies are available within India. Whether it is on the radiation oncology side or it is on the specific gene therapies, or now CAR T-cell is also coming in a big way. A little bit of problem on the pricing of some of these technologies is there. It's still relatively high, but the segment of patients which is affluent and was going abroad can easily afford that. And even with the high price of import, it still is much more economical than going to United States or Europe for these treatments. So that, I think, is changing and quite rapidly. And another thing which has been happening is that accessibility, even in the smaller towns and rural areas, is improving. Today, the modalities of radiation are practically available across the country in large numbers. Maybe we are still deficient in terms of the gross numbers, but that is increasing. And the latest technologies at the same time are also available, like proton is available in the country today, and MR Linacs are available. So on the radiation side also, the latest technology is here.
Mr. Dilip, you know, I just want to point out, I just want to try and understand one thing when it comes to India's oncology treatment. The waiting periods are much lesser as compared to what we see amongst our peers globally. You know, when it comes to the UK NHS, or when it comes to the US, when you're, you know, covered under insurance. Why is it that India is far more efficient in terms of a turnaround, despite the fact that we have such a larger, so much larger population as compared to a couple of the countries we're comparing ourselves with?
Yeah, so Ekta, that's a great question. My own surmise of that is taking on from what Dr. Raghuvanshi talked about, the access and affordability, that we look at the corporate hospital networks that we represent here. The patients who typically come to us are the ones who are either insurance covered or have the wherewithal to find the funding for their treatment. So what we should understand is every case that is detected or diagnosed does not automatically come to a hospital for treatment. So I think if X number is diagnosed, maybe 20 or 25% is first coming for treatment, and that is something that we are able to handle with the turnaround time. But I don't think we are diagnosing every case. I don't think every diagnosed case is seeking treatment. And if that were to happen, our turnaround time could get impacted. The second thing would be that maybe India is a little bit unlike an NHS system or some of the highly insurance-backed system where there is a gateway and a filtering process. India does not have that. For example, in India, if somebody today wants to see a neurologist directly, you could go and get an appointment. But in a foreign system, you have to go through a gate. I think those would be the differences. I also want to sort of add one point, if I may, to what Dr. Raghuvanshi was saying. One thing that we should keep in mind is India is a curatively oriented healthcare system. That it is a tertiary care and a curatively oriented healthcare system. What it means is people fall sick and then they come to hospital to get taken care. I think the way forward, I think the government recognizes it, everybody in the healthcare sector recognizes it, that we would need to be a preventive oriented or a wellness oriented society. I think that's the shift which has to happen if we are to deal with cancer, not only cancer, any other serious ailment, if it is a cardiovascular problem or any other stuff, that renal diseases which are really going up. I think the transition that the country has to make would be from a curatively focused kind of a network or a system to a little bit more preventive and wellness oriented system.
Okay, Mr. Manchanda, any thoughts in terms of how the private sector, such as even diagnostics, could collaborate with the government in order to probably expedite oncology care, expedite a focus towards wellness vis-a-vis curative?
Yeah, maybe I'll probably pick up this question after I have some views on what he mentioned. And the question that you asked about turnaround.
Tell us about the statistics in terms of a blood test or a biopsy report vis-a-vis our global peers as well.
Yeah, on an average, actually, we are 8 times cheaper than the test if you get conducted outside. And a lot of my friends who come from outside, they get their health checkups in India actually because it's much cheaper. So it's not only better turnaround times, but we are actually much cheaper. While we are perceived as an expensive healthcare ecosystem, but if you compare with Western world, we are way below than that. So I think the challenge which I am seeing is much more humongous, because on one side we have a population of 1.4 billion, but the number of people who are seeking demand for healthcare is very less right now. And if I draw a parallel with air traffic, I think as the affordability improves, as the per capita income goes up, I am actually sensing a huge pressure on healthcare ecosystem, because the number of people seeking healthcare is going to blow up exponentially in few years from now. And as the awareness is picking up, as we are going to tier 2, tier 3 towns, I think the demand for healthcare is, you can't even imagine what is actually waiting to happen, what is coming in front of us. The next question is, how do we cater to this demand is a very big question. Fortunately, diagnostic is not a heavy business. We don't require that sort of a capital investment as hospital ecosystem. I think the biggest challenge is on resources, both financials as well as on manpower or human resources, trained manpower. The question that you asked is what a role government can play or a private sector can play. I think there is a huge the entire network of government system, as I understand, there's a huge flow of OPDs in district hospitals. I think they are the places, feeder points, where if you do a public-private partnership and pick up cases very early, I presume this whole area of early diagnosis can actually be taken to the next level. So in my view, a public-private partnership in some of these district hospitals could be a good way to go about this.
Okay. Dr. Datar, artificial intelligence, that's seeping into medicine much more. Do you see it coming into oncology, into testing, into preventive oncology at all? And if so, how?
I think wherever there is data, you will find much more coming through very rapidly in terms of intelligently trying to decipher both gaps and benefits. Increasingly, we're seeing it in our space, which is in genomics, where more and more you are now looking at data subpoints. Because as data evolves, you're also learning new things coming through that ecosystem. When you're looking at various different subsets already in Ohm's field, where digital pathology has already come in such a big way, you're already looking at various different intelligent metrics to define those. You can use them extremely smartly in the country. You can have a clearly defined hub and spoke model where you do not need to set up a facility in every nook and corner of the country. You can clearly look at creating smart technology interfaces between a hub and a spoke, where the spoke can benefit, and we've done this before, we've seen it work reasonably well across the ecosystem. I think the social strata and a divide as a healthcare ecosystem, pre-COVID and post-COVID is very different. I think pre-COVID, regardless of whoever you and I spoke to, the patient always came back and said, no, I don't want to do a video chat, I want to sit across the table. And for some of those dynamics, you do not need it. Of course, you need it for a number of different phases where there's a physical examination to be done, other things to be done, you need to have the patient there. But what COVID, I think from a social standpoint of interface from the patient psyche has said, now it's possible. It's doable. And I think you have to leverage technology across different ailments and again, identify where will technology benefit. Clearly, AI will have serious challenges as well to bring into the ecosystem. I don't think we're there yet at a government level to look at a huge spectrum, but clearly there are spaces in which that is easily possible and doable. I think a lot of corporates are already looking at a lot of this data mining today, where they can look at it, and this is an enabler beyond oncology for sure. You are looking at it across the spectrum of healthcare sciences, where you can smartly use data mining, data drive across the system, and it is not a future to say that the interface and the future of healthcare is today clearly an interface between the clinician, the diagnostic space, whoever owns that space, the patient and the caregiver, and the fourth is the data person involved in this process. Because in all of those different elements, you will be able to identify gaps, plug those gaps, and also foresee in terms of future trends where can you use smart technology, and this will have an impact not only in terms of outcomes but also in terms of cost of delivery, which is going to be so essential for us as a country.
Okay, well, Dilip.
For a change, I wanted to volunteer a comment on AI that, I had an occasion to participate in another panel with CNBC maybe 10 days ago on AI specifically, and I just wanted to share a view that I hold very dear. One is that about 30% of all data in the world today is getting created by healthcare activities, that hospital data and healthcare related data. And in India, I think every year about 380 crore OPD consultation take place, 380 crore OPD consultation, enormous number. So the data is very large, and AI has the potential, like Dr. Datta said, to really work on it. But I strongly believe that AI in healthcare requires guardrails. Unlike AI used in many other areas, I think in healthcare we are dealing with vulnerable people. Unlike consumers in the other sector, the mindset is different. When they come to a hospital, they are vulnerable people. And let's take an example of, we could have predictive diagnosis based on the data of a patient, longitudinal data of the patient, which hospitals have for the last 10 years, including that of his family members and all that. You might be able to, using AI, to give a predictive diagnosis. Look, you have a probability of developing this, not only cancer, something else in the future. I think as a hospital, we have to be careful in drawing a line that predictive diagnosis is not pushing him or her to do more tests, consume more healthcare. So that is where we have to draw a line between healthcare as a business and AI's role in that. I think that's the only point I wanted to make. It's a great tool, but we have to be careful with it in healthcare, and we would need guardrails on how we are going to use it.
Okay, so maybe a little cautious when it comes to AI. Dr. Ajay Kumar, let's wrap up the conversation by circling back to one of the points which were made. One about the lifestyle factors when it comes to the oncology risk in India. The fact that we have a lot of data which is Caucasian related and not India related, and hence what we need to take away as a population, as an Indian population, in terms of, say, the risk factors and the reason why we're seeing cases rise in the younger population. So if we could just sort of end the conversation with a couple of your thoughts on this.
Yeah, I think it's an important thing to understand today. Cancer is really an enigma. What we thought was cancer before is ever changing. By some standards, every 72 days cancer treatment is changing. It's a dynamic process because we are beginning to unravel the mystery of cancer. You know, the heterogeneity of cancer, and today we know obesity or inflammation is one of the most important cause of cancer. When you look at it, it falls in the line of lifestyle diseases. When early days we never understood what could be the relationship between cancer, diabetes, Alzheimer's, or cardiac disease. But there is enough evidence now in our own practice every day. There is such an interrelationship between these diseases. And what is the role of genomics, as we have heard? We are just beginning to tap the surface. That is why if some people ask, are you an expert in cancer? I say definitely not. It cannot be. One person cannot be an expert in oncology today. You need teams. So when we look at it forward, why is it young people are getting cancer? What is it? Is it genomics? Is it environment? Combination of the both? Very clearly, it is combination of all this. For example, elephants don't get cancer. Why is it elephants don't get cancer? So there is a double P53 mutation could be protective mechanism. How are we losing our protective mechanism? And once we lose, how long does it take to get cancer? And like we discussed previously, what is the body defense mechanism and why is it, not all smokers don't get cancer? Only few get. And there is a reason behind it. What is the protection? How body is able to handle it? In some people it cannot. Why? And also cancer is such an enigma. For example, I always give this example, prostate cancer, which sits in the pelvic region, spreads majority of the time to bones. Why does it not go that much to liver or brain, lungs? We still don't know. What is the microenvironment? Whereas cervix, which in women sits anatomically same, very rarely goes to bone. Goes to lymph nodes and other organs. So we are just scratching the surface of understanding cancer. So we talk a lot about it, we say prevention, but global countries have tried prevention. Breast cancer incidence might have come down, but other cancers, colorectal has increased. So it is not that easy an answer. Nobody can say, let us go for prevention, eradicate cancer. Cancer, I don't think can be like, can we say we are going to eradicate diabetes? It's going to be difficult. So that is why, what we need to really settle down for, we may not be able to cure. This is the dilemma of oncologists also. In the past, oncologists have done a great disservice to oncology. Diabetologists never said, I'm giving you palliative care. But oncologists were very good in saying, I'm giving you palliative care. So when a patient comes to you and you say, you're a stage 4, palliative care, says, my God, forget it, man. I'll rather go to the burial ground. See, that attitude will be there. But if you say, I'm going to manage your disease. So we need to change our terminology, right terminology at the right time. And why should we use stage 4? Why not say your cancer is spreads to liver, lung? Why stage 4? Stage 4 means I'm already halfway through to Yamalok. So we should be very, very clear in our language, how we use, how others have done it, because cancer is now a chronic disease. If properly treated, even in advanced case, lung cancer, for example, breast cancer, it was unthinkable people can live for 6-8 years with advanced disease. So it is an ever-changing, so we need to change terminology that will give that positive approach. See, positivity is important, approach to the patients. Man, if I am like breast cancer, great, why not diabetes, why not? So that positive approach we have to reinforce. It has to be done by the media. How can media say corruption is a cancer of the society? What did the patient with cancer think? Please understand, So we have to be very clear in what lingo we use. So I think my experience, India has gone a long way in the last 2 decades. We have really leapfrogged. Sometimes, hindsight we will realize, but we have enormous progress in cancer care. We have to be positive. If a patient comes today and is living for 10 years, that's a great win over cancer. Chronicity. So we should appreciate and learn from it. And as we understand Indian genomics, which is different from Caucasians, how are we different? What is it? As we analyze the data, streaming data every day, we are good in data. We are intelligent. We run Microsoft, Google, IBM, all the companies we run. We are damn good, intelligent, damn good doctors. You go to any center in the world, we are Indian doctors, right? You first go. So we are damn good. Let us use it in our country. Research, academics, bring together, like this conclave. I'm very happy you're having. So we can all come together, understand the data, work as a group rather than individual institution. We can certainly win the war on cancer and make it a chronic disease.
All right, well, on that extremely positive note, and it's important to point out that cancer is preventable and the narrative, changing the narrative is extremely important. On that note, we'll get a couple of questions in from the audience. So go ahead, if you could get a mic there.
Actually, more comments than questions. I think, God is very unfair to men. He loves women a lot. And you look at it in the field of oncology, women had cervical cancer as a problem earlier. And she would have post-coital bleeding. And she would blame her husband for it. And then that disappeared. Then we have endometrial cancer that become important. And that was manifest as intermenstrual bleeding. And, well, that was something that was important and showed up. Again, breast cancer is something external and it showed up. And women had, for example, blood in their sputum when they coughed, and it again showed up. Whereas men, that prostate that is hidden there, that behaves very much like benign prostatic hypertrophy, which most men undergo as they age. There's a very little subtle difference between the cancer of the prostate and benign prostatic hypertrophy. Also, if you see colorectal cancers, I mean, these are two conditions which I, for example, as a family physician, I'm not happy really, I have to go and do a rectal examination and see whether this person has got a prostate problem or doing this. I may postpone it a bit. He has the same problem sometime back and say, okay, let him take the treatment for 1 week and see if he continues to bleed, then maybe I'll check him again. So what happens is, what we are seeing is that women have cancers which are external and therefore much easier to detect. I'm not saying not as a generalization, but because the important cancers are external, whereas in men, many of these cancers are internal. And like another example that you can take is, for example, you ask anyone in the crowd here, I'll say about 75% will say they've had some bleeding when passing motion sometime or the other. And almost everyone says that I've got hemorrhoids and things like that. And this can, as everybody knows, could be a symptom of colorectal cancer. And this is what we're missing all the time. And that's why this conclave is important for us to understand, beyond the proctoscope, which is just 6 inches long, that there is cancer beyond that. Having said this, I said, in India, we have a large incidence of tuberculosis. And a lot of our patients are bringing out blood. And that could be, for example, a symptom of, lung cancer, which we would miss because we have a high incidence of tuberculosis and patients who've been treated for tuberculosis, who have relapses, who have multi-drug resistant tuberculosis and XDR tuberculosis, etc. The other area that one of the doctors has spoken about was about insurance. And he said, the blanket insurance that is there in the West is not here. But we've also seen the West, doctor, there, for example, when you have a car and you take car insurance, if your car is buying a red-colored car, your insurance goes up. Because people with red-colored cars are known to be supposed to be a little sporty type and, they drive a little and they're more likely to have accidents. The same way that if you have a system where our patients can be, have a system where, but if they have good lab test reports, they look good, those reports look good, physically they have the right parameters. And if they have, everything, the labs look good, the people are less likely to cancer, they don't have, other things, then it's likely that, we can reduce these incidence rates. Thank you very much.
Sure, thank you. If we could just have 1 or 2 questions from the audience.
So that's just keep it short.
Sir, your panel discussion has been very, very useful to all the practicing doctors. I just want to ask 1 or 2 small things. See, the number of cancer patients in India is much more than the population of many small countries, say European countries. At the same time, we have the largest number of doctors in the world. what exactly is causing so many cancer patients? Is it the increased diagnostic facility or increased in the incidence? What is the role of the pollution? And another point I want to make is, in a country like US, if somebody wants to see an oncologist or an oncosurgeon, he has to wait for about 1 or 2 months. Whereas in India, the patient can see the doctor the same day or the very next day. But at the same time, the prognosis of Indian cancer patients has been very bad compared with the rest of the world. Where do you think is the loophole and what is the solution?
I think, first of all, the prognosis in India is worse compared to West is wrong. When you collect the data, like we have done 4,000 breast cancer patients, the triple negative, compared it to my alma mater, MD Anderson. In fact, statistically, it's not significant, but on numbers, we look better. See, we are doing better outcomes for the stage, but we are not publishing it. That is why we think we are not good compared to global, but we are actually there. Our outcome, head and neck cancer, breast cancer, stage, will definitely be equal or better than the West. In terms of us having more cancer, I think we are actually identifying cancer today in India. As I said, there is no Indian National Cancer Registry. Once we have a registry, county by county, district by district, it will help to analyze the disparity in cancer between different parts of India. Because India is a large country with different ethnicity. What is the cancer rate in Assam or Manipur compared to Bangalore? What is it compared to Gujarat? We have to really do a good demographic study, understand the oncology of India and why people are coming in different stages of what, and economics, the poverty or below poverty line people, what are this, what are the issues, why they are coming late. So all of this is as I said, is a task we are just undertaken. Why is it, we see Northeast as more head and neck cancer? Is it a perception or reality? We don't know the real answer yet. But all I can say is, as an oncologist practiced in US for 28 years and in India now, I see a tremendous progress. With technology, we can leapfrog to reach the global standard, and some of us are already there in big cities. I have no doubt about it.
Okay.
Thank you, Dr. Ajay Kumar. I think you've just answered the question that I was going to ask you next. This is primarily to do with data integration and how we can where we are currently, and how do we leverage that data in an actionable outcome manner to be able to even, as much as say, allocate our resources effectively that we have at this point of time. So if you could maybe shine a light a little bit on how you would see this pan out if you had to draw this plan up, in terms of even allocating our current resources so that we catch up with the shortfalls that we have, whether it be with upskilling, whether it be with just about getting the right things at the right places in the country.
Sure.
I think we are, like you said very well, what we were lacking is data. And when we do good work, how does anybody recognize? And other thing is with challenges. Because we are supposed to come from an emerging country, how will the advanced country take our data? Because we our own selves, we publish paper where Lancet says, the data is too good, it's coming from a third world. I have an email saying that. So it is because the West is now, they control everything, New England Journal, Lancet and all. For us to break through, it is not easy. We have to break through, but we have to establish our own journals, credible impact journals, and we have to come together to teach. Because I am convinced, doctor, patient coming through major institution in India are certainly getting even the turnaround time, outcome and all, far better than the West. Because I have friends in the West, I have patients, families and all, I know. I am convinced, but how to put it on data and prove is the task. That is where we should move forward. And resources are really not that much in India. It is technology is there, and putting the technology together, and whether it is EMR system, everything centrally collecting the data, we are doing that. We see 120,000 new cancer patients a year. How do we collect all the data, which head and neck and all that outcomes? I think it is a task which is, I think, a great journey for us to show to the world how we are doing extremely well, and we can challenge the world in terms of cancer outcome.
So I just want to extend this, what Dr. Ajay Kumar mentioned, I'm very hopeful that in next 10 years, this entire thing will change in India. The reason being mainly two, I believe. One is the commitment from the government side. You have this whole digital mission that's coming in, the entire repository of data in one place. Of course, in early stage, but that's one initiative. But second most important initiative, I believe, is that entire healthcare ecosystem in India is moving from individual practice to institution practice. And we are sitting here because Fortis as an institution, as a platform. As many of these platforms evolve in next 5-10 years, and with AI and ML, I personally believe in next 10 years from now, we would only be talking about Indian data.
So just the last question.
Just the last question now.
So she has another one. Okay,
Hello.
Just be brief. That's
How do you incorporate actually AI into person-centered or a patient-centered care? Because AI is all about data, and we have a collective data that machine learning and AI can actually pick up, which is there. But are we losing something on patient-centered care, which actually the doctor will deliver? I want the industry leaders to answer, and it's a wonderful podium here.
Dilip, if you could answer.
Yeah, I will attempt an answer there. One, of course, is we have to realize AI is always going to be a decision support system and not a decision making system. That, despite all the headlines which says AI is going to replace doctors and hopefully not managers, but with that that kind of comment. I'm saying hopefully that so I don't think AI, we should ever think of AI as something which will substitute the human judgment. I think in the Manipal system, for example, right now we use an AI layer to run our radiology images through that. Before it gets to a radiologist, it could highlight maybe 15 areas or 3 or 4 areas per image in terms of anomalies, just to highlight for the doctor to keep an eye on. And so therefore AI could be a decision support system. I don't think it is going to replace. But the other factors in oncology, for example, Dr. Ajay Kumar was talking about personalized medicine or personalized treatment algorithms which could work for individuals. I think there AI could help the doctor, for these parameters of a particular patient, these are certain outcomes that other parts of the country had. It could throw out maybe a 15 or 16, whatever number of the treatment protocols that other doctors have followed had good outcomes, and have this particular oncologist decide if it is worthwhile in this case or not. So the bottom line is decision support, not decision making.
Okay, all right. Just the last 2 questions, really quick and brief, please.
So, if cancer is made as a notifiable disease, it will solve a lot of the problems. And secondly, we have, like say for example, Arogysri, lot of other health schemes. In that already data is there, but nobody is coming out with the publications of those data available, sir. So for that we need motivated statisticians to be involved in preparing the data. Say for example, if you see in Arogysri schemes, we have a lot of data being treated for so many years, but we don't have proper statisticians who are preparing the statistics in how our patients are getting benefited out of the treatments.
Okay, all right. That point is taken, and maybe we'll just end with the
With
lady.
the last question, yes.
Yeah, this
Please
is
go
a
ahead.
very important one for me, because I don't think I could get a forum like this to voice a very important issue that cancer patients and their families go through. I'm sure my fellow colleagues would endorse to what I'm saying. The emotional trauma that families go through is enormous. Suicide risk in cancer is 5 times more than the general and the psychiatric population. But seldom little is done for mental health vis-a-vis cancer patients. And I thought it wise, because you'll all be engaging with policymakers as healthcare delivery leaders as well as media, that if you can voice this concern with policymakers to make sure that the insurance covers this particular aspect. Because mental health is not covered, and it's an out-of-pocket expenditure for patients and their families, and very often they kind of drop out of the psycho-oncology service primarily because of this important issue. Thank you.
Okay, well, that point is extremely important. It's not only the patient, but it's also the family that goes through it. And that is something that we had spoken about before the panel began, the impact of mental health and psych oncology, which is probably another aspect of it. But on that note, we need to wrap up. We're going to take the rest of the questions offline. Thank you very much, gentlemen, for joining into this panel. It's been a pleasure. Thanks very much.
Thank you to all the panelists and the dignitaries who have assembled today. If there is one takeaway, we will say that while the incidence of cancer is increasing, definitely our work and our technology, accessibility and affordability has to bridge that gap. And biggest takeaway will be that all of us as leaders in our respective ecosystems should work towards bridging that gap. So once again, thank you, and the stalwarts of the industry are with us in this journey, so we don't have to worry much. On that note, I'll request Dr. Ashutosh Raghuvanshi and Dr. Niti Raizada to kindly felicitate all the guests. They're taking a photo. No, he's in the middle. Request Dr. Raghuvanshi to kindly felicitate Dr. Ajay Kumar, Executive Chairman, HCG Group. Big round of applause, please. Request for felicitation of Dr. Vineet Datta, Executive Director, Dattar Genetics. Dr. Raghuvanshi and Dr. Niti Raizada. Dr. Om Manchanda, Managing Director, Lal Path Labs. Mr. Dilip Jose, Managing Director and CEO, Manipal Group. Ma'am, please go. Thank you, Dr. Raghuvanshi. Thank you, everyone. And we'd like to felicitate Ms. Ekta Batra, CNBC TV 18 India Editor, Health and Life Sciences Vertical. On that note, we come to the end of the Healthcare Leaders Summit. Thank you once again to all of you. We now are going to the award ceremony of the posters competition. We'll speak with Dr. Niti once on that. Sir,
The head and neck session is continued after this, please. We'll just quickly give the prizes for oral and poster presentation. After that, we'll continue the head and neck session. Raghuvanshi sir, can we have you on the stage? Mr. Anand sir, can we have you on the stage?
we'll just read it?
नहीं बोलना सबका नाम बोलो सबको बोलो पहले तो प्राइसेस और ये पहले ही बोल रहे हैं उसके बाद वो बोल
पहले प्राइजेस कर देते हैं, then we want to
वर्थ भी बोलो और and we do instead of giving a small congress for this thing we have decided to change it to cash.
I request all the dignitaries to kindly be seated. We have to issue the prizes.
Akshay sir, can we have you on stage, please? Rahul, can we have you on stage, please? For podium and poster awards, cash awards, Ashutosh sir. Dr. Anand sir, please. Rahul sir.
Good afternoon, everyone. Myself, Dr. Sanjay Rangagoda, radiation oncologist, Fortis Hospital, Bengaluru. There was some special prizes that we have announced for the abstract submission. Honestly speaking, there were like quite a lot of abstracts which have come, and it has given our judges quite a task to really sort out the best. And we had announced a sponsorship for conferences as the top 3 prizes. But it has been changed, and we are handing over the cash prize instead, so that it can be used as they seem fit. So without further ado, I'll announce the prizes. Okay. Yeah. So the first prize, worth of 1.4 lakh rupees, goes to Dr. Hemant S. Galige. I request Dr. Hemant S. Galige to kindly come onto the stage and really receive his prize. I request Dr. Ashutosh Raghuvanshi sir to kindly issue the prize and honor our winner. And the second prize goes to Dr. Sumanta Das. I request Dr. Anand sir to please hand over the gift to our winner. The prize worth 70,000 rupees. And the third prize, worth 50,000 rupees, goes to Dr. Rizwana Hassan. I request Dr. Okay, since she is not here, her representative will kindly take the I request Dr. Anand sir to hand it over to the winner, or the representative rather. So as I mentioned, there were like quite a lot of abstracts, and it was a very difficult task for our judges. So we have 2 more consolation prizes, which have done e-poster presentations. So I call upon Dr. Neha Yadav.
Actually, what we had done is we had only 3 prizes, but we added 2 prizes for e-posters, and both of them are 20,000 worth because we had tie in the first position. So we have 2 first position. First is Dr. Neha Yadav, and second is Dr. Bhuvneshwar Garg. Can we have both of them on the stage, please?
So both of them have been awarded with a cash prize of 20,000 rupees. Is Dr. Neha Yadav is here? I would request Dr. Neha Yadav to come onto the stage.
So there were few names we like to announce where the panel judges found their papers were excellent, but not that everybody gets the prize. So I want to mention few names. Dr. Tarini Sonauni, she had an excellent abstract. Dr. Sujit Arugam and Dr. Mirna Nicole, Dr. Swati Shukla, Dr. Malini Mohan, Dr. Venkatesh Naidu, and there were few abstracts from Satya Veera Malla, then Dr. Keshav Ajit, Dr. Muthulingesh, and one psycho-oncology which judges have appreciated is from Mr. Sajan. Thank you.
All of them will get a certificate of special appreciation from the Congress. Thanks so much, sir. Thanks.
I think we now have to continue with our session, which was kind of a little bit postponed to the previous session. And this session is also very, very important in continuation with the topic of this conference, the precision oncology. So we in radiation oncology have been doing precision oncology for years. We have been targeting tumors with high accuracy wherever possible, and we have been innovating and newer equipment, and so this has been going on, and a lot of work is still going on. And to discuss all that, we have two important talks in this session. So one is on MR-Linac, and the other one is on proton therapy. Both are newer technologies which have really made difference, and we want to know which are the patients who should be offered these newer modalities. So to talk about this, it's my privilege to invite Dr. Sweet Ping from Australia. Can we have the slide, introductory slide? So she is working on MR-Linac for close to 3 years now, and it is my privilege that we have invited her over here, and she will talk about her experience with the MR-Linac, which is a newer modality. It is going to be a second equipment in India, so it's that much important. And her topic is MR-Linac, a game changer, the precision clinical application in tumor radiotherapy. Case scenarios she will discuss, some motion and radiation cases. Dr. Sweet Ping, yes.
Thanks very much for the introduction and the invitation to speak today and share our early experience with using the Unity MR-Linac. So today I'll be going through a little bit of the history in radiation therapy and how we come to Unity MR-Linac, and then share some case where we found that it has been an eye-opener for us in terms of understanding disease and treatment response. These are my disclosures. When I first started doing this talk, I had to Google and making sure that I say the right thing and is culturally appropriate. But the majority of things that seems to show up on Google between Australia and India seems to be this. So I'm sure we have a common understanding of what we're interested in. So going back in history, the advancements in radiation therapy really is tied very closely with advancements in imaging. One of the major advancements over the last couple of decades really is the introduction of CT-based planning, whereby we move away from 2D planning to 3D, IMRT, and now really VMAT. And then of course, there's now ongoing investigations and also use of IMPT or proton therapy, and also stereotactic radiotherapy, whether it's Linac-based, CyberKnife, or Gamma Knife-based as well. So advances in imaging has really allowed us to see the tumor much better and able to contour the tumor with higher precision. So a combination of CT, MRI, PET scan has allowed us to contour with more certainty than ever before, and therefore be able to deliver with high precision. However, our treatment workflow over the many years, despite the advancement in technology, hasn't changed. So a patient has a biopsy and staging, referred to a radiation oncologist, have another imaging that would be for radiation planning, and then in the case of a head and neck cancer patient, it will be 7 weeks of treatment, and then restaging perhaps at 3 months. And from there, it's approximately 5 to 6 months away, and really in that time, we have very little knowledge about what goes on to the tumor and how patient is responding. And over the last decade, people have attempted to use CT-based investigation to quantify for tumor response. And in this slide, it shows that by week 3, there's an approximate 70% reduction in tumor size in head and neck cancer. But I'd just like you to keep this image in mind because I'll come back to it in a little bit. Not only that tumor responds over time, but we know that normal structures also change in size and shape. This study was actually done 10 years ago, which shows that the parotid and submandibular gland changes in size, but nothing has moved much since then. Again, another image showing that treatment response happened, and that even though we treat with something we designed at the very start, it may not be sufficient for our time now. So where to from here? Adaptive radiotherapy is what we are moving towards. And this is what I put up earlier. It's a CT-based quantification of the tumor. But really, we need a lot of imagination to try and quantify the tumor in these images because it's done without contrast. The edges of the tumor is hard to see. And really, I think it was contoured with some imagination in mind. So that's where MR imaging comes in. We have improved capacity to visualize the tumor and soft tissue now, but also able to do some functional imaging without contrast. Therefore, patients do not have extra radiation, and it allows us to image patients daily using the MRI. The Unity now have a comprehensive library of all the sequences for each sites. They even have the BFFE, which we can look at real-time motion monitoring during delivery as well. And some of my colleagues may argue that these are just pretty pictures, but I would argue otherwise. The MR-guided radiotherapy is the first time that we now have real-time motion monitoring during BMON, and it's the first time that we now have disease information daily during radiotherapy. So how can we use this data for the future? In my simplistic mind, I divided them into 2 groups. For those with poor prognosis tumors and high toxicity treatments, such as those with GBM or head and neck cancer, can we use this technology to improve cure? Can we use it to reduce toxicities? For those with good prognosis tumors, breast cancer, prostate cancer, can we use this technology to treat with less fractions, make the treatment a little bit more cost-effective as well? So here's some cases to support what we see. So for brain cancer patients, typically on treatment, you get a cone beam CT. We can't see the tumor. And showing this to a surgeon, it's really mind-blowing for them because they wouldn't operate based on the cone beam CT. But now the Unity allows us to match accurately to the tumor, but also able to match accurately to the OARs as well. So we've treated a different mix of high-grade and low-grade tumors, and surprisingly, we do find that 1 in 2 patients have significant change enough during treatment whereby we require a replan or adaptive of their treatment plan moving forward rather than using their plan at simulation alone. So here's an example of a patient. The top row is the preoperative MRI. Bottom is the postoperative MRI where he had a good surgery. We planned the treatment, but day before treatment, we realized he had progression of disease, even though he was asymptomatic. We find that if we do not replan or adapt his treatment plan, we would have probably missed approximately 30% of the volume of area that we should be treating. So what this has now allowed us to do is to generate a new plan for him on the fly so that his treatment is not delayed any further. This patient ended up having actually a good treatment response during treatment, and he actually achieved a local control of 18 months, which is pretty good. The second group of patients we look at on the Unity tends to those that we re-radiate. This is one of my patients who had GBM treated earlier, but he had a recurrence, and reviewing his dosimetry, it is a marginal recurrence. He had surgery, and again, very quickly, he recurred and progressed in the same area. We retreated him with bearing in mind that if he does progress through treatment, we would abandon treatment early rather than subjecting him to additional treatment toxicity, and he can have spending more time with his family. But in this case, he actually responded pretty well and had a local control of approximately 6 months thereafter. But not all patients respond. We do see progression during treatment. This is one of our patients who we keep having to replan or adapt the plan every week for him, and he did not achieve any control at all. So in this group of patients, we wonder if it's worth that we have ceased treatment early, have a discussion with our other oncology colleagues, whether we can change the treatment plan for the patient. The Sunnybrook group has also reported the changes in tumor size, cavity size of GBM patients. So this is not data that's unique to us. And moving on to head and neck cancer patients, we know that, and I think it was well discussed in earlier talks, it's a complex region affecting patient swallowing, saliva, speech. And really treating this area will affect patient quality of life regardless. It's only a matter of achieving balance. If we give too much dose, we'll give them late effects that will affect their quality of life. If we have too tight a margin and we miss, again, they would recur and affect their quality of life as well. With that in mind, I think we'll have to move forward from treating one dose and one plan for entire treatment for this group of patients. Now, that's all fine when we design treatment at the start at simulation and the match on cone beam CT is perfect, such as this patient at day 0. But we all know by mid-treatment, patient loses weight, tumor shrink, the normal organs changes shape and size, and the match is no longer perfect. And typically we would match to bone, but the question is, are we treating bone or are we treating the soft tissue here? This is one of our very first patients that we treat on the Unity, patient with a hypopharyngeal cancer that's actually involving the cartilage. However, he declined surgery. But really during radiotherapy, we find that he had a very good response to radiotherapy with his primary tumor pretty much unable to see it by the end of week 3. He went on to I think he's now 2 years out. Apart from having some grade 1 xerostomia, he has perfectly functional and eating well as well. Another group of patients we do like to put on Unity are those with very, very large tumor. This is a patient with T4 tonsil cancer invading into the oral tongue and severe trismus. And the plan for him was to see his treatment response, and as you can see here by fraction 15 or 3 weeks of treatment, the tumor size has shrunk down by more than half. So we adapt his treatment on the fly and deliver a smaller volume of high dose for the second half of his treatment. Again, this patient is now 1 year out. He's not tube dependent, he's functional. He does have dry mouth, but I think that's the least of his problems. So he had a complete response. So when it comes to head and neck cancer patients, we find that the volume change differ between the primary and the nodal disease. The primary pretty much would decrease by more than half in size by week 3, whereas the nodal disease tend to shrink in a more linear fashion. We have also looked at functional data in this group of patients, and what we find that the apparent diffusion coefficient change really happened within the first 2 weeks. And this is interesting early data for us because we think that the first 2 weeks potentially could tell us if a patient would respond to radiotherapy or not, whether we need to change treatment plan thereafter. Finally, I'll go through some cases on abdominal cancers and how Unity can be used to help these patients. This is a pancreas cancer patient, and although between fraction 1, 2, 3, 4, 5, it looks very similar. Just zooming in, on a good day where the stomach or duodenum is a little bit further away, we're able to use the Unity to try and optimize the treatment plan and ensure that we can give better coverage of the tumor while protecting the normal organs. On a day where the stomach is a little bit closer, as you can see there, the Unity would optimize to ensure that we still protect the normal organs, but on that day the dose distribution is slightly more compromised. The other way that changed what we do is the real-time monitoring during BMON. We've never been able to do this on the cone beam CT LINAC. And what this allows us actually is to design and ensure that we target the tumor throughout the whole treatment BMON, but also allow us to really measure down how much is the tumor motion and change that for each patient rather than having a blanket 5 millimeters or 7 millimeters. We've also treated liver metastases, central liver metastases. And again, during BMON, we can ensure that the areas, the motion is stable. One of the beauty of it is not all patients need to go on Unity, but sometimes patients surprise us. As we know on the cone beam, when we go down and we try to match to the liver, but we see a bowel loop that comes in the way. On a CT-based LINAC, we will have to take the patient off the bed, send them home, or give it a couple of hours, and secretly hope that the bowel move out of the way. But on Unity, we do not have to do that. All we have to do is contour the bowel. The machine would re-optimize it and ensure that we deliver the accurate dose to the tumor. Similarly, this is what's happened with cirrhotic patients as well, who has a lot of ascites. The amount of fluid is always hard to predict and guess. And really, we do not want to, when we're treating stereotactic treatment to the liver, particularly a not so healthy liver, we want to make sure we know what dose we're delivering. So what we do here is, rather than assuming that the air is fluid, we do recontour it, ensuring that the correct air is air and fluid is fluid, and deliver the right dose to the tumor. So really, I think CT-based LINAC is accurate and it's precise, but I think the Unity allows us to do it a little bit better for some patients, for a certain group of patients as well. So we can use a smaller margin, less toxicity for this group of patients. But the longer aim of Unity, I believe, is to try and achieve better cure and local control by delivering higher dose to tumor, because we can see better, potentially reducing toxicities by reducing margins and dose, and improving cost effectiveness as well. So thank you very much for your time, and happy to take any questions.
Dr. Peng. And so we have some time for a few questions about MR LINAC. I'm sure we would all realize that this is a different kind of working environment for radiation oncologists compared to the working environment we have right now. So any burning question from the audience? Yeah.
Thank you, Dr. Sweet, for the wonderful presentations. I have two questions for you. One is, what would
be the margin we use for the liver patients? So we went from contouring an IGTV that we would use for a CT-based LINAC to now contouring just the GTV, because that's what we would see on the MR. But we also assess the patient on the Unity to know that how much and quantify how much is the movement on each sup, inf, lateral, and then we included that as the PTV. So what we then now has really changed our mind when we contour is we no longer do an IGTV because we know we can see it on a daily basis. Yeah.
Sorry, the actual question was the GTV to CTV margin in conventional tongue cancers, which you showed.
Oh, tongue cancer.
The tongue or head and neck cancers.
We currently still use GTV to CTV of 5 mils, and now of course cutting back from all the anatomical areas. Yeah.
The 5 millimeter is what you use. Because the conventionally, in the CT-based planning, what we use, at least 1 centimeter we used. There will be a gradient we do create 1.5 centimeter. But in the MR-based, according to you, it's 5 millimeter is enough.
We've always done GTV to CTV as 5 mils, even on a CT-based LINAC. That has not changed what we do at the moment. But what has changed, and will probably change a little bit more in the future, is the PTV margin. So it doesn't change where the microscopic disease risk would be, but change and limit the uncertainty in terms of setup and matching. Yeah.
Thank you.
Do you have any additional margin of intermediate risk after the GTV? So most of the publications say 5 plus 5. So 5 is the high dose, and then there is an intermediate dose. So I think that is his question. What about that?
I think even that within a department, it's a little bit controversial. I think it varies depending on where you go, what people do. For us, we do just plus 5, and we don't do an intermediate. Okay. Particularly on the Unity, we try to keep it simple because we know that we can see where the dose go. So we can accept it a little bit better. And actually, in fact, on the Unity, even though we have a PTV, we are happy to accept as long as the dose is covering CTV, because we know PTV is just uncertainty. Yeah.
Yes.
You in, let's say, for example, liver lesions, drawing a GTV, because I know you don't have to do an ITV. It's a standard. Maybe treat with SBRT. I'm just wondering whether you can actually, after putting the GTV, put the patient into the MR Linac, and then create your CTV based on your MR, and then maybe a small PTV beyond that.
Yeah, so at the moment we do the simulation also on the Unity, so we know what we're seeing. So we create the GTV, and then we add on the motion as a PTV. Yeah, yeah. And certain people do it differently. Some people actually decide on a day before. Some people do it a bit earlier. Yeah.
So the answer for my second question, the protocol for the adaptive radiotherapy in the conventional head and neck cancers.
Yeah. So at the moment, we do adaptive radiotherapy or under a research protocol. There are international research protocols. So MD Anderson has one for early stage oropharynx cancer, where once you based on the shrinking tumor, and once you can't see the shrinking tumor, it'll be assigned the elective dose. We do have a collaboration with the Canadians where we're looking at T3, T4 cancers, where we have a adaptive plan at approximately week 3 to try and reduce the dose to the swallowing muscles. So our endpoint actually is swallowing. So I don't think the current treatment workflow on CT is inferior in terms of treating the cancer, but potentially for larger tumors, harder to treat tumors, Unity can potentially reduce toxicity in those patients. Yeah.
Can I add to his question is that you showed us your MR images weekly, and you have shown regression of the tumor. So what do you do if the gross tumor volume regresses? Will you shrink your GTV or not even GTV? So
when we adapt, we shrink the GTV.
Yeah.
And then actually online, it actually automatically knows your PTV and it auto-generates that for you.
So that is also an adaptive radiotherapy?
Yeah.
So I think...
it's still on a research protocol though.
Okay.
Yeah.
No, so this weekly regression of the tumor, so if the GTV has shrunk, you add a CTV and PTV. So as the treatment is moving, the volumes are reducing.
Yes.
So it's happening online, yeah.
We do not know how frequently we have to do. Probably they are still in the evolving the protocol for these things, I believe.
How frequent we have to?
How frequently you are shrinking the volumes?
There's no guidelines out there for the stereo cases. We do it per fraction if we need to. For head and neck cases, at the moment, we try and do it either weekly or every 2 weeks, depending on how quickly the tumor shrink. So usually within the first week, it's not very much. We don't see that having extra time on machine and resources is worth doing. But typically at week 3, week 5, we do try and do that. Yep.
Yes.
Hi. What is the margin that is usually allowed? I mean, how much of the margin do you practice? You have MR-Linac, very high precision. What is the margin of error that is allowed? Is it, I'm pretty sure it should be at the physician discretion, or is it run mostly by the machine? Or if it is at the physician discretion, what is the margin, GTV to PTV margin that you follow, now that you have such high precision imaging? I mean, high precision treatment, sorry.
So we just match to the tumor, aiming for 0 margin, yeah. And then the PTV is there, but we are very happy to accept a much lower coverage over the PTV. So we've now, instead of prioritizing a coverage of PTV, we prioritize coverage just on CTV. Yeah.
Because immediately adjacent to the GTV, some microscopic disease would always be possibilities there. I mean, can we afford to be so strict in that? I mean, what is the practice, I want to know?
Yeah, so I think that's the fear of reducing. We're always wanting to treat more, but not treat less. But I wouldn't say I've done, it's like a case series more likely. We haven't had anyone who had a marginal failure for head and neck. Yeah.
So the conventional wisdom of PTV of say 3 to 5 millimeter is gone, or what are we going to do about PTV? So that is his question.
If we can get rid of it. That would be the aim. And to be able to get rid of 3 to 5 mils of normal tissue, that's a lot of radiation we're saving from normal tissue. Yeah.
Okay, any other question? You have another one, okay.
So this is with regards to the use of MR-Linac for CA prostate cancers. Do you still follow this conventional treatment of treating the whole prostate when it comes to the stereotactic radiation therapy, or only you do treat the GTV-based treatment?
Unfortunately, I don't do prostate.
Okay.
But in general, our department, for those on the Unity, they don't treat the whole prostate. So they try and do the re-radiation prostate or just a focal boost. That's who they put on. Yeah.
Okay. Thank you.
So thank you very much, Dr. Sweet Ping, and thank you for answering so many of clinical scenarios and some of the confusions we have about MR-Linac. Yeah, thank you very much. So now we go on to the next high technology radiation technique, the proton therapy. And we have Dr. Edward with us from Mount Elizabeth Hospital, Singapore. And I had the privilege to work with him at the Middlesex Hospital London way back in 86, 87. And then accidentally I found him in Mount Elizabeth Hospital in Singapore. So they have put up the proton therapy unit, and he is going to discuss about his initial experience with proton therapy in Mount Elizabeth Hospital in Singapore. Dr. Edward, please.
Thank you, Dr. Anand. I thank you for your very gracious invitation, and also for the Fortis group for supporting our meetings. You know, Dr. Anand is as handsome as he was when I worked with him almost 40 years ago. 40 years in the Middlesex Hospital, so it's been a long time. I just want to talk to you about our IHH International Hospitals and Health and Hospitals project, Proton project, which we are now working in our 8th month. We are working well, and one of the things that we always highlight in our overall care is the global health trends. IHH is multinational, and we have to look at the global health trends as to how to design our systems to ensure that we can always meet the needs of the different locations where we are. And we must make sure the healthcare is value-based. It is based on the fact that there's so much data coming out, and there's so much need for combination treatment. There are more and more data points, and decisions are going to be more and more difficult to make in time to come with the amount of data, as you have listened to some of the head and neck lectures on chemotherapy. The number of drugs and number of combinations can be so confusing. So these are things which we are going to go into in the future, and to make sure precision medicine is the way to go, where every patient's case is taken as an individual and not as a statistic. And of course, quality of life is going to be very important. And in radiotherapy, we find that there'll be estimated a 4 times growth in the use of more focused treatments in the next 10 years. So just to recall, I think most of you are radiation oncologists. We are involved in more than 50% of all cancer cases. We have curative radiation, adjuvant radiotherapy. We have preoperative radiotherapy, palliative radiation, and prophylactic radiotherapy. In cranial prophylaxis in some cases. I'll just go through that quickly, and all the different tools that we have in our sphere of environment. And stereotactic radiotherapy is very big in our practice. And now we have our latest tool in Mount Elizabeth, our Novena Proton Center, which is our, the next generation of radiotherapy machines that we are trying to look into and see how we can add to enhancing the care of our patients. Now, as you all know, for those who have done physics, proton is a subatomic particle found within the nucleus of every atom. And it's a positive electrical charge, and it's equal and opposite to that of the electron. Now, in X-rays, we accelerate electrons, which to the speed of light, hitting a goal or tungsten target from which X-rays are generated, and then we shape and modulate them to customized beams. But the proton is much heavier, so we can only accelerate them to maybe 2/3 the speed of light. And in the old days, proton accelerators were huge, taking up a lot of real estate. But now with cyclotrons and magnets, we are able to reduce the size of these machines producing protons. And what we have is a cyclotron where we can actually, as it were, fling a proton round and round to accelerate it to the point where we need to use it to an accelerated speed which is sufficient for our use. And we have here in Singapore our accelerator. You can see it's not as big as you think it is. It's quite small. We don't have much space. Land is very, 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 very expensive in Singapore, so we cannot afford anything more than 1 gantry, because this is the sort of space that we have. That's the sort of platform where our proton therapy center is built into that hospital called Mount Elizabeth Novena. We also use a pencil beam scanning technology to modulate our proton beam in our planning system. So the proton beam is manipulated so as to accurately administer the dose to a very unique shape of the tumor. And we can increase the intensity and reduce the intensity of the protons according to the points of this volume that we want to treat. So this sort of like what we call IMPT, or intensity modulated proton therapy. There's also what we call passive scattering in some of the cases that we would use if we keep it simple, and where we have a proton pencil beam that goes through a scatterer, a second scatterer, to shape it. And of course, our more more often than not, we use an active scanning technique to make sure that if you can see the volume of the patient, little circles, which actually tell us the points we want to modulate our dose and how much proton dose that we need to give to these doses, to these spots. So why protons? And many of us are familiar with this graph, you know, where those who are in radiation oncology, where you have the photons, where you have how the photons will lose its energy towards as deeper it goes into tissue, and of course how electrons lose their energy even faster, so we can use it for superficial things. But for protons, we are able, depending on the energy of the protons, decide how deep it goes and where we want it to peak. We call it the Bragg peak, with a very sharp fall-off dose based on energy of the protons. I have one or two slides at the end to tell you that not everything is as rosy as you think it is. When you look at graphs like this, you say, wow, protons is fantastic. But I think there are challenges which we still face. But we do, as a rule of thumb, protons can be stopped at a target depth, and protons can be used to leverage by ensuring that we can try to avoid the contralateral sides of certain, you know, of the anatomy if possible. So for example, in brain tumors, you have a tumor, let's say on the left side of the brain, and we can just design fields using protons to keep the dose within that area. And of course, with conventional radiotherapy, a lot of the brain will be irradiated, although to a much lower dose outside of the tumor, but still irradiated. Sometimes we use a combination of protons and photons to ensure a better dose distribution. Okay, but why protons? You know, I think we're getting away, and we are getting fairly good results with our, you know, stereotactic techniques and such. But it's because of cancer survivors. It is a booming population. It is estimated that the number of cancer survivors in the United States from 1971 to 2026 have ballooned to close to over 20 million cancer survivors. And, you know, the estimated number of cancer survivors in the US by, you know, from time of diagnosis continues to rise. And, you know, as a result of which, more and more patients will have a long life in front of them after therapy. And it's for those especially receiving radiotherapy, we do know that there is a risk of what we call second malignancies, especially in childhood cancer. In fact, childhood cancers, we cure many of our children now, and they're young, and they have a whole life in front of them. And we know that, you know, for some types of cancers, secondary cancers cause more deaths than their primary cancer now, as a statistics in the United States, because of the improved cure rates. So I think this is something which we need to address, and that is why proton therapy now is becoming very important, especially in our pediatric care. Of course, just a slide to show how much proton beam is being used now in America, how it's exponentially increasing over the years, and how the number of facilities have increased. To date, in January 2024, it is estimated there are about 125 units of proton therapy machines, of which we have 3 in Singapore, growing, and it's growing, and there are 33 under construction and more than 30 in planning stages. So by the end of 2 years from now, we probably would see close to almost 200 proton therapy centers. And these machines are not cheap, I must say. They are very expensive, but I think there is a future for them. What is the proton advantage in radiotherapy? We like large tumors and we like deep tumors, just like the MR-Linac, we like the difficult tumors to treat. Okay, and just to give us an understanding that radiation therapy plays an essential role in cancer care. With better technology, we can safely treat cancers with higher doses of short durations. These are the trends. Impact of treatment being translated to better outcomes and longer survivals. And proton therapy, therefore, can potentially enhance outcomes with lower risk to normal tissue in some situations, lower risk to secondary malignancies, lower risk to long-term morbidity. For example, here we have a picture of a child who has a photon therapy on the left, or in that picture's on the right, where we use X-rays or craniospinal, and you can see the dose right within the abdomen. But with protons, we can virtually reduce the dose to the abdomen to 0. It's quite amazing. We've done quite a number of craniospinals in our center, and we are very pleased with the approach, although it is a challenge, and these treatments do take a long time, as long as about an hour sometimes, and we have issues concerning anesthesia and such. So they are difficult treatments to do, but the gains are worthwhile. For example, the other one, we are treating livers, and as you know, many of these patients with liver tumors, hepatocellular carcinoma is a common cancer in the Orient. And many of these patients have quite bad liver function. And so when we use our standard SBRT, a lot of normal liver is exposed as a result of which causing even further difficulties. We sometimes cannot pass a plan because the volumes and the toxicities will probably kill the patient before the tumor does. So we have to be cautious concerning that. But protons have changed the game, and we are now able to more safely treat a tumor without exposing a lot of the already damaged liver to further damage. So these are some of the things that our proton therapy machine have been, we have used that to leverage and helping many of our patients. And of course, in treating organ-confined prostate cancer, well, these pictures don't show a great difference, but between protons and photons, but there is a reduction, as it were, in the volume of normal tissue being treated, and I don't think you'll see much difference between photons and protons in prostate. I mean, I do a lot of prostates, and I still have difficulty charging so much money for a proton when I know my photons can do just as well. But on paper, you do see fairly good dose distributions. Especially when we are treating lymph nodes, you will find that plenty of the gut is not irradiated at all with protons. But these plans are difficult to do, and image guidance is very important because of the matching of fields. But that being said, protons has the potential of saving a lot of normal tissue from being exposed to any form of radiation. And this will be especially useful for, in cases like head and neck. For example, this is a pituitary that was treated, and you will see that in protons, they use in those days, the old technique where they used two lateral fields. We now use a lot more sophisticated proton fields. But even with that, you will find there is a difference between the amount of dose that is exposed, for example, from X-rays and protons. The X-rays look better to me at this point, but when you see the dose difference, you actually see a lot more dose to the normal brain in the posterior, and also eye in the area of the sinuses and the eyes when we use X-rays using a VMAT technology. Oops, wrong. And here we have a proton therapy, or what we call IMPT, a field for head and neck, and then compared to a standard IMRT or VMAT technology, you will find that there is a significant amount of difference in terms of dose distribution. The added radiation with IMRT, which is on the extreme left, or extreme right, I beg your pardon, shows that there's a lot more exposure to the cord, to the tissues in the back of the neck. Well, that being said, it is not a high dose, but it's still dose. So, the aim is to expose as little normal tissue to radiation as far as possible, and that is the challenge. And proton therapy seems to have stepped up well to ensure that we can try to avoid some of the very extra tissue if we can help it. So these are some of the other things, some of the other cases that we have done, with protons. And one of the things in Singapore is before a patient can receive proton therapy, he has to be reviewed by a proton tumor board, which will also involve non-radiation oncologists. And this tumor board will decide whether the patient will qualify. We have a very stringent guideline given by our Ministry of Health, and I must confess the guidelines tie our hands very often, and in patients where we think we can really do good for them, we cannot give it to them because there are certain constraints which these guidelines have. So we do have these challenges that face us, but one of the cases that we know that we can always do is a head and neck, and this is one of the cases where we can actually prove. And very often, before we even treat a patient on protons, we will do a VMAT plan to make sure that the plan is a lot more advantageous on protons. So this is something which we ensure that we do in our practice too. Of course, in Hodgkin's disease, you can see when we do pencil beam scanning in patient 1 and in patient 2. In both cases with protons, you find hardly any dose going to the cord, whereas when we treated them in the old days with 3D conformal techniques, a lot of that goes through the heart and through the spinal cord. So that being said, giving you all those lovely pictures about how good proton therapy, their plans are, there is toxicity. There is toxicity. You get systemic toxicity, like depending on where we are treating you, you do get dysphagia, some nausea. If we are treating the brain, you're going to get headaches, and tiredness. It's not as if it is without side effects. And I know that sometimes it's sold as that, but you do. Alopecia is a big problem. I know with my SRT, stereotactic techniques, we save patients from alopecia. But because of the way in which protons is delivered, especially in one direction or in just two simple directions, to avoid normal brain, we do expose more skin and therefore risk of alopecia. And we do tell patients that that alopecia may be a problem. Now, mucositis is not unusual, especially when we are treating a lot of our oropharyngeal tumors, because you find that there is although there's no dose going to the opposite side, the dose to the mucosa is just as high as photons, and you are going to get those side effects. It's not without side effects, and I think we should not tell patients, you have protons, you won't get side effects. You get side effects, right? The other one is proton therapy uncertainties. I think this is a slide that people don't like to put up, but I think one of the things that we always are challenged at this point of time, we use a international guideline, the radiobiological effect of X-rays versus proton is a 1.1, 10% more on protons. So all plans are based on a 1.1 RBE. The other thing which we are now looking into is linear energy transfer, and I think some of the treatment planning systems are trying to incorporate linear energy transfer into the planning, because this is a bit more difficult to quantify and measure. And it is this linear energy transfer that at the end of the Bragg peak, when we look at a graph, it's very nice and straight, but sometimes because of the momentum and the ionization momentum, there is a extension of linear energy transfers. And I was just attending a course recently, and they were showing us all the different kinds of imaging which they are using to pick up this linear energy transfer, and it can be quite hot. And especially if you're sitting very near the spinal cord, or you're treating a chordoma, you're near a spinal cord, there is potential that you can actually sometimes even overdose the cord. So we need to learn about this linear energy transfer. And of course, the third thing is about neutrons. Neutron contamination is even more difficult to quantify and measure, but it's something which we are always concerned about, especially even for the safety of our staff. So these are some of the proton therapies uncertainties. That being said, proton still has tremendous potential of ensuring that especially for our children, their survivability will not be marred by second malignancies, that we can reduce that risk. And there are many papers which actually show that there is a marked reduction, even up to 60% reduction of risk in terms of secondary malignancies. So just to give you some pictures of our proton center in Parkway. And I just show you that there's an IBA office, that is to say they have a 24/7 care of our machine, and some just pictures at night of our center. Thank you very much.
Thank you, Professor. If there are any questions for the, please.
Brain irradiation. How about the neurocognitive difficulties?
I've not given any slides to show how the results, but there's a very strong evidence to show that in terms of IQ, in terms of neurocognitive, psychomotor, social skills, all better in patients who had proton therapy to the brain as compared to standard radiotherapy with X-rays. That has been well borne out in Mayo, in MD Anderson, and these centers have actually showed that these are, and Loma Linda, which they have been doing for many, many years, and they have now evidence to show that. So we work on that evidence that children's psychomotor, social skills, everything does not actually improves with proton therapy as compared to standard compared to X-rays. Yeah.
Okay, that's interesting. So you do a baseline evaluation before you
yes, most kids will have that, and they are tracked subsequently. I mean, these trials were very exhaustively done, and in ours, most of our kids will have been under the care of our pediatrician, and their neurocognitive, apart from their, perhaps their motor skills, which were affected by the tumor, which improves, which is good, but they will also look at the long-term outcomes. Now, we have just started our proton therapy program, and it will take some time before we can see these outcomes. But we work on the basis of what people have done, and they've done it well, and and we follow these approaches.
How about with adults?
I beg your pardon?
With adults.
With adults, well, I mean, unfortunately, many of our patients with brain tumors, who malignant brain tumors, their life expectancies are not as that great. But without doubt, there's much less neurotoxicity, especially we are treating a very large brain tumor with protons, because we can expose much less normal brain to any dose at all. But that being said, many of our brain tumors can't qualify, unfortunately, to get into proton therapy, because in Singapore, one of the requirements is there is a potential for 5-year survival. So you have a GBM, we cannot put our hands on our hearts and say, yes, you can live 5 years. So, when we know we have a bad tumor, and we know that the average lifespan is 2 to 3 years. So sometimes we have to fight a little bit to say, oh, this tumor is probably, we can do it, and try to get him into our program. But otherwise, that being said, in adults, the main is the acute neurotoxicity, which we look out for.
Okay, one last thing.
Sure.
So you do the hippocampal sparing irradiation?
Yes, of course. That's when we do any large volume, if we can spare the hippocampus. For example, whole brain radiation, which I must confess I very rarely do now, because we do a lot of stereotactic work, and there's good evidence to show that even up to 20 brain secondaries, you can use stereotactic radiotherapy. But that being said, in cases where we actually have to treat whole brain, for example, in cranial prophylaxis, in leukemia, or in a certain in some circumstances, where we try to spare the hippocampus.
Thank you.
Yeah.
I have one question. Now you just shown the linear energy transfer. It is going to be quantified. So now when you see the trajectory of proton, LET is much even lesser than photon in the beginning. And when it reaches the bragg peak, it goes to more than 2 or even close to 3 also. So whether you think this late will help in confining a dose to the tumor, or it is helping in minimizing the dose to the normal tissues?
I think it is trying to incorporate the effect of this linear energy transfer beyond the field, beyond the bragg peak, into the planning systems, so that when we do generate a plan, we will have a more accurate picture as to ascertain whether or not, let's say, for example, if I am treating a tumor next to the spinal cord, and I want to ensure that the spinal cord doesn't get more than, say, 40 gray over a period of, say, 5 weeks or 6 weeks, I want to make sure it doesn't get 40 gray. But with photons, we know that we have certain way, because of X-rays, the nature of X-rays are going through, and we assume that, with a bragg peak, I can stop there, and then therefore the dose to the cord may be only like 10 gray, and I'm not too worried. But because of the linear energy transfer, which we are beyond that, we may have actually higher doses. and that higher doses may be detrimental if the dose is high, but if it's low, it's not too bad. But we are trying to, I mean, the vendors, the people who are developing planning systems are trying to see how they can incorporate these uncertainties into the planning. So what we now are doing occasionally, especially if we are treating a tumor where we have only one field, and that field ends near a significant OAR, what we do is we try to well, play a little safe by not giving any margin or being very tight. Yeah.
Actually, there is a range straggling at the end of break peak. So
Yeah.
do you think, are you giving extra margin to account for this when you are preparing the SOBP?
Sorry, I didn't catch that.
There is a range straggling in case of proton at the end of its range after break peak.
Yes.
So are you giving any extra margin while preparing the spread out bragg peak for covering the whole mass of the tumor, maybe GTB or so?
Well, you see, the planning systems are based on a Bragg peak measurements, and the Bragg peak measurements are such that at this depth, at this energy, the dose will be, X. But what I said that linear energy transfer is something which we have at this point of time working towards trying to quantify beyond that Bragg peak, and that's what I'm trying to address. Is your Bragg peak, is your margin clear? Do we have a nice straight margin, or do we have something going in beyond? I mean, these are some realities which we have to face, and some of the ways in which we mitigate these issues.
That was a wonderful talk, Doctor. I am working in the Proton Center in Chennai, and we have now nearly 5 years experience of working with protons. One of the things that we have done to address the issue of LET, of course, besides now looking at each plan, looking at the linear energy transfer of each plan, is also to try and ensure that we have at least two beams looking at every tumor.
That's right.
So you kind of spread out the end of range.
Yeah.
And when you spread out the end of range, that has an impact on the LET. And just an additional point I wanted to make to Dr. Brinda's question is that one additional advantage that is noted for pediatric patients is very often when the hypothalamic pituitary axis area is also being irradiated or is in the vicinity, is a reduction in the need of growth hormone supplement. And at times that is actually not just improving, it's impacting or making it more cost efficient to use proton in the pediatric age group. So I don't treat pediatric tumors, but like Doctor mentioned, that's a part of the protocol for treating all pediatric patients in our hospital too, that we would do a baseline neuropsychological cognitive assessment and subsequent ones too. I think our team might be ready to publish that at some point in time.
We actually, we're learning from Chennai actually. Dr.
Jalali.
Yes, I met him at the IBA meeting, and we were trying to think of ways in which we can collaborate in the long term. Yeah.
That's wonderful, sir. Thank you so much. I think we have to wrap up this session. We are already lagging behind schedule. Any more questions to the speaker? I think they're always available at the lunch. So I think we should start the next session. But before that, there is one small announcement. One of the abstract winner was not available back then. I think we'll just hand over the prize to her, and then we can go on to the integrative oncology session. So thank you so much, sir. I would call upon Dr. Neha Yadav to come and collect her prize, her abstract presentation. I would call sir to please come onto the stage and hand over the prize to the winner. Sir, please come, sir. Dr. Madhusudan sir is head of the department, Radiation Oncology in Fortis Hospital, Bengaluru. Congratulations. Thank you, sir. So with that, we are ready to start the sessions on integrative oncology. I would like to first invite upon the stage the session directors, Dr. Megha Pruthi, Dr. Parik sir, and Dr. Suman S. Karant ma'am. Hope they are there.
I'm waiting for Dr. Vritti to come. She's our boss for Oncosciences. So I'm hoping there'll be other perspectives because all I know is a little bit of psychology and nothing else. So so come. So I was listening to a lot of things since morning, and I was thinking how psychology has been treated in any case. So not just oncopsych, but psychology per se. We talk about prevalence, we talk about impact, we talk about statistics. Just imagine what statistics are for psychology. The only difference is that because we don't measure in terms of direct, we don't realize the indirect. That's what happens with psychology. You see pain, but you don't see the impact of the pain. And I mean, this could be endless. We had the session of by the leaders as well, and the thing that was coming to my mind when I was talking about this, that you actually put, if you look at the data that has recently come out, that if you make two buckets and you put the cost to the society and you put cancer, COPD, and I think diabetes or cardiac, one of them, I don't remember which one, and on the other side mental health, guess which one is heavier as a cost. But having said that, I think psycho-oncology requires a lot of effort at multiple levels is how I see it, and I think it starts also from the medical fraternity. Until oncosciences programs become more integrative by itself, everything else that happens becomes just, because it'll have to start from this side, it won't start the other side around. So what I'll do is I'll just, for just 2 minutes, give a whole spectrum as to how I see it, and feel free to then take it forward. We talk about prevention and awareness, psychology plays a role in it. Most aspects of prevention and awareness are about breaking the psychosocial barriers, the barriers of communication, the barriers of the narrative. And you need that consistent, empathetic, responsible, sensitive approach to be able to make people aware. If you want prevention, then prevention is a behavioral change. For a behavioral change, you will need to have the right kind of psychological messaging to happen consistently. You look at breaking of the diagnosis. it has its own psychological aspect. And you need how, when, who all as a part of that aspect. Then you look at the whole treatment and the impact of treatment, direct, indirect, and family. A lot of times we actually don't realize that families fall ill, individuals don't fall ill, irrespective of what illness spectrum we are talking about. And then the whole aspect of taking the treatment part. Then when you look at the component of survivor, so that has its own aspect. And then you look at breaking bad news, you look at grief, that needs to be addressed as well. And in all this, the families care that needs to happen. So something that we've started doing at Fortis is that gradually we are having psycho-oncological services in each of our hospitals where we have a strong presence of oncosciences. So for example, Fortis Gurgaon, Fortis Mulund, now our Banarkatra Road here, and we're taking it forward. The route we've taken is that, so we don't want to increase the burden of care. So it is the hospital that is ensuring that all patients, including daycare, radiation, are getting psychological support based on their requirement, but at least once, and then based on how it continues. I also feel that especially for non-mental health professionals here, I hope you realize that psycho-oncology is a specialist branch. And now we have more and more colleges who are training young people on this. And I think that's a very, very good development in our country when it comes to this subspeciality. And the other thing that we do is very focused on support groups. I've always believed support groups have a role to play. And we have been running now for about 4 to 5 years a support helpline for caregivers. We feel that that's one part which is largely neglected. So that's a bit what we are doing at Fortis, and I'll give it back to Vritti.
Thank you so much, Dr. Parikh. I think it set some tone on the mental health aspect, which is so very much required. I think, I'll just, while we are ending the conference, and I can see a lot of fatigue setting in outside the hall, but I can see a lot of right intentions inside the hall. At least we know that these are the people who are absolute. Just give me one moment, I'll come back to you. So just setting a little tone now what we have, and I'm just trying to set an expectation of how to best utilize our, this hour. Now what we had thought, considering integrative oncology, we know there's a lot of work happening, thankfully, to some people who are absolutely driven on the subject, be it be in mental health space, be it be in the palliative and the rehab space, the pain management space, be it be from the, from the space of nutrition for that matter. While there is work happening, but we thought that this would give us an opportunity of not just, reflecting on what is it that we've been doing in Fortis, and there are some achievements and some places where we are still trying to find the right methodology. And then, having some experts who also share the intent, and, we have, to get them all together and have a discussion and make it more like a discussion. Unfortunately, we wanted a boardroom setting, but we did not have a boardroom available, and we agreed to continue here. So so we are trying to set that kind of a thing, so that today when we leave this hall, we have at least if not more, at least 5 actionables. And if, people say if we can have 1 actionable is an achievement, but I'm saying if we can have 5 actionables across, we have Ms. Kausar Kidwai, is she in the hall? Sorry. Can you please come on the stage as well? So we have Kausar Kidwai. She is from the preventive oncology space, a very passionate preventive oncology mascot. She's with Carkinos. I'm sorry, we don't have the profile up there, but yeah. So Kausar, we will have, so from a preventive oncology space, and we have Dr. Sameer Parekh, and we have Dr. Brinda sitting here in the audience, And I think from a mental health space, if we can have few deliverables, and, we all collectively, and irrespective of within Fortis or outside Fortis, and, please, and I might not know everybody who's there, I would just know the people I know, but then please feel free to, this is more going to be an interactive session, is why I wanted to set the tone first before we started taking it as a, that is why just a 2 to 3 minute talks from each person. Dr. Megha has not been able to join, so she'll take on call. And then we wanted to have us, so we have Akriti from genetic space. Akriti would want to come on the team as well, so from the, so trying to cover all the spectrums. And unfortunately, we had Dr. Suman who had to leave. She had a flight. We had her here she's a medical oncologist, and she had to cover the nutrition aspect from a medical oncology. So now that, so concentrating it, dividing it into 2 parts, and genetics pitches in everywhere. So dividing it into 2 parts, since we've started mental health already, with Dr. Sameer Parekh already setting the tone from mental health, what is work that is happening in Fortis, and which is, there are things, all that he said, we've managed to do them, and I'm using the word managed to do them, because all that is happening not effortlessly. It's because it's not a normal course yet. So a lot of things we've set in tone, but still there is a lot of work to do. So for example, each patient now in his purview gets access to a psychologist. I think that has happened. That is coming as a routine. And I still know that a lot of our own network hospitals, we've not gotten there. So we also have, amongst the panelists that we had thought, we have only Dr. Vedant Kabra here. He's a surgical oncologist, and one person who shares, an intent, a very strong intent towards a holistic care. And we have Dr. Sushil Jain, again, very pro-patient, first patient's comfort and happiness. So I think, so on that, with that front, and Dr. Parekh, since we had somebody who was wanting to make a comment on what you had already shown light on. Yes. If you could also introduce yourself, it will help us know you.
I'm Dr. Naveen Machado. I'm a family physician from St. John's Medical College originally. I used to teach in St. John's, in St. Martha's Hospital in the Department of Family Medicine as clinical medicine there. I'm very passionate about family medicine and have an association with many hospitals, including Fortis and their oncology unit. Doctor, what I want to ask you is, every nurse or anybody who's working in a hospital is sensitive that, there are patients are sick, they're tired, they're in pain, they've been waiting, they've come from a long distance, etc., etc. And that is a general thing which I think most nurses and others are sensitive about it, but sometimes forget these things. But in patients who come to your hospital, who have obviously cancer diagnosis like a sword of Damocles hanging on their head, they've been told that this could be cancer. These patients, things are very, very different here. And I've seen it even in places which have daycare centers very close to us and keep requesting us for references. That these patients, firstly, our cancer patients are older. So they, their resilience and the importance for them for time, their rest, their, tea, everything becomes difficult for them. They travel a long distance to come down that miserable Bannerghatta road, which is up, dug from this end to the other end, and finally reach your hospital. And, they get into this thing. And they have anxieties as they come, with this thinking, oh, what's the doctor going to say? Is this really cancer? Is this the beginning of the end? Or what does it mean, And they must be having thousands of questions going through their head and worries, And sometimes we forget all this when we're treating patients because for them we're just another patient. And we forget that, they may be a father, a mother, or a brother, or a sister, or, a grandfather, or a grandmother, or a daughter or a son for somebody else. And I think we need to be sensitive about that. And, at your point, when these patients come in, I think you need to sensitize your staff to that every patient who comes in there should have that much, our staff has to respect that these patients are tired, they're worried, they've come a long distance, they're very worried about what that diagnosis is going to be, what are the procedures that they're going to undergo, I have gone through, like I mentioned on one of the sessions, I had follicular cancer of my thyroid about 6.5 years ago. And doctor, in the follow-up, for example, the PT scan, believe me, doctor, this is a personal experience which I can share with all of you here. That scanner, which was small in those days, hardly the size of the seat that we are sitting on, you went into a room which was as big as this. And you were in the center of that room, there was this table that was there. And you were like being crucified out there. You were put in that table there and you were strapped down. And there was not even a bell in your hand to call someone or see anyone. This was a gantry somewhere far away. You could see a glass and he was there. And then the scanning machine would come like this, just over your face. And you could hear all the whirring of sounds and things like that. And it was horrible, doctor. I used to dread that 6 months later when I had to go for my follow-up. And then I thought, what is the way of getting over this? And I decided the next time when I went, that I'm a person who loves adventure sport, travel, and things like that. And every year we go for some holiday, family holiday. And what I did was, as soon as I got to that place and I got strapped down, I was closed my eyes and I was thinking of something happy. My whole journey, that whole holiday that I went for, I just went through that in my mind's eye. The whole journey I went through in my mind's eye and said, wow, I was there. By the time I knew what's happening, it was over. And I could survive that particular process. And then, fortunately, as the years went by, the machines became bigger and, it was much faster. And what took 20, 30 minutes was over in 7, 8 minutes. So this is just sharing with people out here to set a tone as to what a cancer patient has to go through and follow-ups and everything, and it's just one aspect of it, and I'm sure you'll build on it. And it's just a fervent request that I think, doctors should fall compulsorily, really fall sick once a year. It's compulsory, they should fall sick once a year. They should get a few jabs once a year. They should be...
Sorry, I am so sorry. I do not want that prayer to go anywhere from here.
No, but only to feel the patient's pain. Only to feel the patient's pain.
I hear you, but I would not want that prayer to go anywhere from here. Sorry, just one more second. I'm Dr. Keith Lim, please do not go. I saw you, I realized, okay, perfect. So we have Dr. Keith Lim. He's the medical director from IHH Singapore Hospital of ours, and we thought it will be good to have him for his perspectives, because there would be certain things that they are doing right, and there would be certain things we are doing right, and we could have together, again, things what we could be doing together. And Dr. Parekh, and I can see.
Sorry, I didn't get the format of this discussion. The speakers are going to deliver their talk,
so what
and then the house opens up for
absolutely,
discussion. Right?
You're right.
Okay.
You're right. Yeah.
So I think one cannot take away the fact that empathy has to be there in every individual. I mean, not just in the profession of healthcare, empathy needs to be there. Fact is, empathy doesn't always be there, and to be present in 100% of the population is a utopian thought process. Yes, there is no question, doctors, nurses, colleagues, everyone, mental health professionals, all of us need to be reminded of our aspects here. But all said and done, we'll never have 100 on 100, and that's how life is going to be. If you ask me, 20, 25 years back, would we have thought that in an international summit for cancer, we would have been talking about psychology? I would have said that's never going to happen. 20 years back, I would have said that's not going to happen, honestly.
Recording in progress.
So, but yeah, that's my thought. So nothing can be taken away from the individual's experience. It is what it is. And whatever individuals should do, they should do, but we'll all feel each other every now and then, and that's also what it is.
Thank you, Dr. Parekh. Thank you, Dr. Parekh. We have Dr. Megha Pruthi, who's joined us online. She heads the pain and palliative for Fortis Gurgaon. Dr. Megha, we are setting the tone of the conference, and I know you are outside, but we don't want to, because we lost our time track completely because of the earlier things and the cascade of that. We would want, and I know you deal with pain and end-of-life care, and so specifically on end-of-life care, if you would want to talk about that and give us a perspective on the pain management perspective of all the cancer patients that you encounter in your clinic.
Thanks, Ruti. So I think, am I audible? Am I well audible there?
Yes, you are.
Very well. So I think, the whole idea behind this session on integrative oncology, and I'm very happy to be a part of it, albeit because of a lot of things, I could not be there. But so let me not just talk about pain and end-of-life care. I feel palliative medicine is a lot huge more. And when we talk of integrative oncology, it's about the team of experts that we are all talking to improve the overall routine care that is already being done by our oncologists, and I'm sure they're doing an absolutely wonderful job, evidence-based care that is being done. And there is, as Dr. Parekh was saying, we have come long way over last 10 years, 20 years in palliative medicine as well, from the time that there did not used to be any discussions around it in the research data, enough institutional and experiential data to say that the seamless integration of oncology, of psychology, of nutrition, of symptom management, of physiotherapy in the oncology services improves the overall survival, improves the quality of care, improves the adherence to the treatment and overall satisfaction of patients and their families, right? So I would just say that we have started our journey in Fortis like 9 months back. However, the journey, my personal journey, has ranged over the last 11 years, where we have done this integration with little steps like making a consensus statement on with our oncologists in my previous institute as to which patients would benefit from a specialist palliative care consult, right? So, and we did come up with a consensus statement by the oncologist for the oncologist. That's one step towards integration, right? And forming a complete department of integrative oncology when we say that. Even here, if we talk about our journey in Fortis, we have over last 9 months, I think, with great and huge support from our oncology department, from you, Vritti, yourself, you've been an important aspect of how our department is growing with mental health services and our physiotherapy services, our dietitian services. So all these things have been a huge part, and we are making probably good advances each day with another QI project, quality improvement project on goals of care discussion. So I think goals of care is one very important thing overall to improve the quality of care that we are delivering to our patients. And I'm sure all oncologists would concur with me on this, that whenever we discuss about what the patient wants, what values does the patient hold, and what are the social circumstances of the patients, I think that holds an immense value. And once we are able to discuss that openly with the patients and with their families, that kind of would pave the way for integration of entire team of all these experts, including psychology, physiotherapy, and make this entire integration very smooth and seamless. And that is what we have to do, When we say integrative oncology, we have to have a seamless integration. Patients should not feel that he's being abandoned by his, primary doctor who are medical or surgical or radiation oncologists. And there has to be a seamless integration. Patient is receiving all the care, symptom management, physical symptom management with the palliative medicine specialist, and psychological care with our mental health specialist, and nutritional care, physiotherapy support, everything being delivered seamlessly. The whole idea, as you and me were discussing before this session has taken its shape, was that we have to have experts who have been in these shoes and who have seen their or others' journeys, and we have to want their contributions as to how we can develop our systems so that our patients and our caregivers receive the best care that they deserve, right? So that's the whole idea about integration that I feel right from symptom management early on in the patient's journey to the care that they require, communication, honest communication that they require when there is change of or transition of care from cure to, to care, and even at the very, very important stage of their life, which is called end of life care. So that part, and all this delivered seamlessly with everybody who, who's required being involved. And that's the idea behind this entire session on integrative oncology with our oncologists. I would really like to have their inputs. How do we do this? How do we do this? Thank you.
Do we have Dr. Omlata Bhagat here in the hall? Yeah, Dr. Omlata. Sorry, I didn't know you in person, so I'm so sorry. Please come on the dais. So Dr. Omlata Bhagat is from Jodhpur. She takes care of the physical aspect of the onco care, and very important element of so all the physical, mental, emotional well-being, when we talk about it, all go hand in hand. Dr. Omlata, would you want to speak few words, and then probably I'll keep preventive oncology to the last section of it, Kausar, and then we delve into, and then genetics could play a role there.
I just want to give a disclaimer that I am not an oncologist and I'm not directly dealing with the onco patients. I'm a physiologist who is working in the area of autonomic responses to wellness care, and we do have the concepts where physiology is being forgotten somewhere in the realm of treating patient, though it is the fact that the goal of every treatment is to bring back the homeostasis, the primary object of physiology. So I just think that when we are treating a patient, let's add few things in their daily routine, which is very much physiology. Don't give them big goals, but along with the treatment, certain little things like exercise, how to breathe, or some physiological aspects, if we add to them, that will help them deal with the better the treatment, and the agony comes with the disease and other aspects.
Sure, a very important aspect, and I think that will form integral to all the discussion that we have. Dr. Brinda, you would want to speak something on, in addition to what Dr. Parikh said about mental health. Can we have the mic with Dr. Brinda, please?
Thank you for having me here. I agree with Dr. Parikh. Personally, for me, it's been a very, very long journey. This is my 31st year in psycho-oncology. And I know that of late, psycho-oncologists are kept very busy in an oncology conference because it has taken us 30 years to get this far and climb onto the stage to make oncologists listen to what we do. Primarily, a couple of things I think I need to put in perspective when we talk about mental health. I don't want anybody in the audience to believe that cancer patients are psychiatric. They are not. They're dealing with a very life-challenging, difficult situation, and therefore, psychologically, patients and their families go through enormous amount of psychological, emotional difficulties. So therefore, there is data now made available. For a long, long time, we were just resting on the international data to talk about the prevalence of psychological distress. So when I talk about distress, now psychiatric, psychological problems have been replaced by the word distress, primarily to neutralize and make sure that it is not stigmatized, because I think cancer is one stigma that universally most populations carried, and India was no exception to that. It's a double whammy to talk about going through mental health professionals when they're going through difficult times with cancer. So distress is the norm now, and now I think World Health, UICC, as well as the NCCN has made this very clear that emotional well-being of cancer patients now is considered the 6th vital sign. The 5 physical vital signs that we generally look, well, whenever we get into any clinic or, for a physical examination, like the blood pressure, heart rate, pulse, pain, and so on, the emotional well-being now is a 6th vital sign. So it's mandatory that all patients be screened for their emotional health before they even meet with the oncologist. In fact, there is something called the distress thermometer, which screens one for the emotional well-being, which takes barely about 7 to 10 minutes in the Western setting. In India, of course, it's half hour, because they have lots of issues to talk about. So then you triage your patients. There is a clinical pathway now formed. If there are financial difficulties, then they go through the social work services. If physical, then they go through the physician. And emotional, they come to us. Alongside what I want to kind of make it very clear, when we talk about mental health in oncology space, psycho-oncology is a highly specialized specialty, and it has its own place. I know that oftentimes I've had these issues in the past where the management as well as doctors would ask, why not a clinical psychologist? And oftentimes I would give them this example, the general surgeon versus an oncosurgeon, what is the difference? Why don't you get a general surgeon to operate on your cancer patients in a cancer hospital? You won't, because that's a highly specialized area. Likewise, in mental health, psycho-oncology is a specialized area now. It's also indeed very complex. When we talk about mental difficulties of patients, oftentimes we talk about depression, anxiety, and so on. Where it is stemming from is equally important. I think the rule of the thumb is first to kind of make sure that the organic factors are eliminated, because subclinical metastatic process in the brain oftentimes ape or mimic depression and anxiety that you and I would be thinking as purely psychological, while they're not. Number 2, the drug-induced difficulties that patients can have. We extensively use hormone therapies, and several of our chemo agents have the ability to breach the blood-brain barrier. They can also bring about several emotional difficulties. Third, the electrolyte imbalances that we so often encounter in an oncology setting, sodium, magnesium, potassium, all of them ape and mimic psychological difficulties. So we have to rule these things out before we subject them to any kind of cognitive behavior therapy or all the fancy psychological interventions. So what am I saying? I'm saying please do not trivialize mental health in an oncology space, because it's highly complex. Yet another thing, when we talk about support group, I think we should do that very cautiously. In an Indian setting, like there is quackery in everything, there's also quackery in mental health. While patients who have gone through the journey of cancer are very important to talk to newcomers who are embarking on this journey, it's very, very important to make sure, first of all, the volunteers or patients who really want to kind of serve a new person who is on this journey, their own mental health screening is very important. Because oftentimes, probably, when we are talking, even we as professionals, when we are listening to patients, oftentimes we also go through several trauma. We reflect on our own personal experiences and so on. So therefore, the rule of the thumb ought to be screen your volunteers, make it completely homogeneous group, because a breast patient sitting with a brain or a male sitting with a female in a support group does not make too much sense. It has to be coordinated and navigated through a mental health professional. Ideally, these are not to be done in a very lay, loose fashion. These are some of the things that I wanted to kind of emphasize on, because this is a science, and therefore this service has to be taken very seriously. Last thing that I agree with Dr. Parikh when he said that we have such a significant role from prevention onwards. I would say the scope of psycho-oncology is from womb to tomb and even beyond. because even after we have lost our patients, families continue to come to us. And in the space of genetics, we have a huge role to play. We have worried well to take care of, because now with all the genetic testing, quite a bit of trauma patients and their families go through. So I think we cannot be signed off so easily. And certainly in a conference next time onwards, make sure we are the first in the session, day one, because obviously mind comes first and all other things matter later. Thank you.
Thank you, Dr. Brinda. I think the whole, I think the overview that you gave was very insightful, and I think our physicians, our oncologists, and our surgeons say this day in, day out, and obviously that is why the need they have understood very well, while the oncologists at one era were doing everything, covering the whole spectrum by all themselves, now understand the need of psycho-oncology, and they are the ones who are insisting on having oncopsychologists within the department to support them, rather than, which was not the case earlier. And that is where, that is where the space in the conference, which is Fortis Cancer Summit, would not have been complete without integrative care, and that's how the, the place here. I can see Dr. Parekh is trying. Just give me one moment. I just would want to get others also involved, getting their perspectives. Dr. Keith Lim, so, if we could have, and I'm sure you will be able to give us a perspective outside the country, outside India, outside Fortis rather. You've heard Dr. Parekh and Dr. Brinda speak very nicely about, the detailed, and we can see the amount of work and hard work that is going in day in, day out, and, supporting the cancer patients and their caregivers. Would want to understand an overarching view from you. What is the kind of practice? Is it very, very similar to what we're doing here? Is it something more? Is it something less? Or, is there something that you have as a goal in mind that, this is what would make it complete there? Want to hear your perspective.
Thanks. And thanks to all of you for sticking around to the end of today. It's almost it's coming at 3 o'clock and people are still here. So obviously it looks like we're preaching to the choir. Those of us here feel very strongly about this. Just to introduce myself, my name is Dr. Keith Lim. I'm a radiation oncologist by training. I presently serve as the Group Medical Director for IHH Healthcare. So IHH Healthcare is the parent company. We own Fortis, amongst 84 other hospitals around the world. Our core goal is this motto, which is care for good. So that's what we believe, and we believe in that very strongly. The other thing we believe in is no bad profits. So even though we are a private company and we do have shareholders, never have our shareholders asked why are we doing certain things because of trying to get money. And in fact, that is one of the things they're always very worried about: unnecessary treatment, unregulated stem cells. Are we doing things that we shouldn't be doing? And that has pervaded through this company in its last 10 years of its existence. So first off, can I congratulate Fortis and those of you in Fortis for the advances you've actually made with integrative care and the psycho-oncology. Coming from Singapore, looking at Malaysia, these don't exist. So you guys are already one step ahead of everything. The other thing that struck me is that the fact that you guys understand that our patients, as Kabra and I both know, are persons. And that's something that we forget as oncologists, because we are not trained in actually very short training in breaking bad news. We don't want to really spend time talking and exploring the patients. It's a lot easier as an oncologist to say, okay, your cancer has come back, let's try line 4 of chemotherapy. Let's irradiate this. It's a lot harder to actually tell the patient that, look, perhaps you might want to take a break, enjoy your life, do things that you enjoy, make yourself comfortable, talk to your family. That's a lot harder conversation than to say, let's try this drug, that's a combination. And I think we, as a community in India, as we've heard so much about everything that's being done, need to start incorporating quality of life, psychological aspects into our clinical trials. Today, when we were at the liquid tumor biopsy, the lady from Canada, I think that was one of the first trials that I've heard in this entire conference for the last 2 days. So for those of you who weren't there, she created a trial called Value, in which she was trying to look at whether or not liquid biopsies, how they work. But what struck me very interesting was that she incorporated quality of life in that trial. And I don't think we've heard that very much. For those of you who are sitting in this head and neck room listening to the head and neck guys talking about the Pembro and all that, we know these are terrible drugs, they're terrible side effects, and they were trying to give it because it's a small improvement in control and all that. They didn't have quality of life. And so I applaud those people who are actually looking into that when the genetics, and those of you who hear how Fortis groups and the rest of the Indian groups who are doing this, you should start looking into that. We have taken a lot of data from abroad. We don't really know whether the Indian population, whether these EQ5D scales, EURTC scales are actually applicable to the Indian population, but as our leaders were saying just now, that is something we can take the lead. We have 1.4 billion people. It is not hard to start doing your own validated scales. So I would recommend that when we do this, we start looking into trials on quality of life as well when we start integrating into our clinical trials. The third thing, and I know I'm taking a little bit of time, is really along what you said and what Mega said over the internet. End-of-life care is very of concern to us. A lot of oncology patients spend a lot of the bulk of their cash and their money at end-of-life care. And as I said, it's very easy for us to keep prescribing chemotherapy, but every chemotherapy has a physical and financial cost. And as a group, we're very concerned about that. Because we do not want, as I said, no bad profits. We don't want to be known as a place where people just come to, and the moment you walk in the door, like if you go to a barber, you will get a haircut. Come to see an oncologist, you will get 6-line chemotherapy. So what you guys are doing by setting up your integrated oncology, having a strong palliative care unit, I think that's something already that you should be applauded for. A lot of other countries, we don't see people being referred to, in the private sector, to the palliative care teams. We don't see people being referred to physiotherapy, physiologists, psycho-oncologists. The oncologists keep it alone. But the fact that Fortis is doing this, and as a group, that is something that you can mandate and we will support along those lines. That patients who are reaching second-line chemotherapy should speak to a psycho-oncologist, a psychologist, palliative care, and for them to really decide if this is what they want to do, or is there something else that they want to do? Because we are not our patients. We don't know what their life goals are. They know what they want to do. Their family is their life goal. We need to actually explore that and understand that. And so again, congratulations to Fortis for actually having the maturity and the foresight to actually head down that road towards psycho-oncology, integrative genetics, and physiology as well. So again, congratulations, and I think that's the way to go.
Thank you very much, Dr. Keith. Thank you very much. You know, I think, so quality of life happens to be one of the clinical outcomes that, go very strongly associated with the treatment that is given, whether it be from medical oncology, surgical radiation, or oncology perspective. So I know we're trying to capture, the quality of life, and we're still trying to create the key performance indicators, the quality indicators for the outcome. We're still getting there for oncology because of the complexity that, the oncology has, and, one patient going across modalities, and we can't leave the caregivers behind. They are as integral part of the oncology treatment of the patient himself, so with all that, I would want to also take an input. We have, unfortunately, we do not have a medical oncologist. We have doctor, and a medical oncologist walks into the room though. So we have, we have a surgical oncologist with us, Dr. Vedant Kabra. Dr. Vedant would want to understand from you, and before we get into what should we be doing, what we are doing, how do we strengthen it, while we've heard an overarching views, want to hear from your perspective, if there were two things from your practice, that you think that, if by the end of this 1 hour, if we are able to nail those two things right, and again, one I have already picked up from what Dr. Keith said, and we've been, Megha and I have spoken, Dr. Parikh and I have spoken on the quality of life index of a patient, with being one of the parameters that we talk about clinical outcomes of the treatment that our patients are undergoing. What, from your perspective, you would want to talk about 1 to 2 things on those lines? Mike, can we have the mic, please, with Dr.
Yeah, sure. I have to leave in a few minutes. So I'm Maitri. I'm Dr. Maitri Shankar. I'm a nuclear medicine physician. I was practicing in the US. I now head the team at Aster CMI in Bangalore. So in nuclear medicine, we mainly do metabolic imaging, which kind of sees a little bit beyond what structure shows in CT or MR. About 4 years ago, I've gotten more interested in this space of lifestyle medicine, functional medicine, integrative oncology, and I got both certified in all three in the past few years. We are setting up integrative online kind of a platform with one of the NGOs I run. What has become more and more apparent these days is no matter what you call it, quality of life or lifestyle, which kind of is the cause. I see a lot of patients with this emotional anxiety coming and asking, why am I getting this cancer? And I think it kind of points us in the right direction of the lifestyle, which could be diet, could be plant-based, high sugar, gluten. There is so much research coming in, which is kind of leading to this vicious cycle of the Warburg's effect of cancer. There is the physical activity. There is so much data coming in for breast cancer patients where people who are exercising more, the rates of recurrence is low. There is sleep hygiene, again, very, very important. Sleep is an important pillar. There is stress management, again, #1 cause of cancer, what is coming up recently. Positive psychology, of course, the mental, emotional, and the spiritual space, and often much ignored the addictions or the substance abuse, which could be tobacco, alcohol, or even digital, and sometimes food itself is seen as an addiction. I think amongst this, a little bit beyond that, the functional aspects, which could be the gut microbiome, the toxins, the carcinogens coming in from the food industry, which there are so many new tests which have come up in the US, and we kind of send people there. The diabesity or the obesity and the inflammation itself, which could lead to this. So I think at some point when we are talking about integrative oncology, all these factors in all three phases, before cancer happened, during treatment, having a lot of nutritional support and a lot of emotional support can help patients recover better and respond better to the treatment, and most importantly, after, to prevent recurrence. I think the integrative scope which exists today, what I'm seeing in the platform here, has a much, much, much wider scope, and I think that would be the true essence of integrative, preventive oncology in its whole sense. Please do connect with me. We are working on some exciting projects, some pro bono and some this thing. So I'm Dr. Maitri Shankar. I'm at Aster. So I'm very keen and passionate about bringing in closure or some kind of a project on the integrative aspects of oncology.
Thank you, Dr. Maitri. Thank you very much.
So somewhere in progressing in healthcare, we have lost the culture of family physicians. And we have a guest here from St. John's who probably has been practicing that. And I very strongly believe those family physicians knew the family in and out, the equation within the family. And I think they were probably the initial and the best psycho-oncologists or psychologists for that particular family. The kind of equation which was there. Having said that, and he also mentioned about empathy, which sadly is deteriorating. That is something which is degrading in the society in general and definitely in healthcare workers as well. So I would go a step ahead and say that every healthcare worker, whether it is a nurse or a GDA or a doctor, needs to be a psychologist to their patients. We need to spend some more time. And I can tell you my colleagues in my department, my nurses would be tired of hearing me saying to my patients that what we do is half of your treatment. What you do is equally important, other half of the treatment. And what you do mean what you do, what your family does for you, what your caregivers are doing it for you. So that's a very important aspect of oncocare. We are talking of immunotherapy. Dr. Ankur is there, is a very strong proponent of it. And how does psycho-oncology help? Right. I think it improves your immune system. And we have now enough evidence that there are many other things which are going to improve immunity and give better outcomes, including a randomized trial which is happening currently in Tata Memorial Hospital, and the initial results are encouraging. On breast cancer patients who were randomized to yoga and meditation arm have had a better outcome in quality of life. It's already there. So these are few things that we must keep in mind. Apart from that, since we are talking of integrative oncology, we have to move away from radiation, surgical, medical, nuclear medicine, oncology. And there is again evidence to say that acupressure, acupuncture, they do help in decreasing the side effects of certain chemotherapeutic drugs or even other things. So these are my thoughts about integrative oncology. Dr. Brinda did mention about support groups, and you may not remember, but psycho-oncology became a very important part of oncology conferences first time probably in 2013 ICC when I was part of the organizing committee, and I was involved in the psycho-oncology program, and that is when I met you for the first time. And she also mentioned today about support group. I'm happy to say that we have a support group in Fortis, and we did have a program of across NCR Fortis groups, and we called patients from all the hospitals at one place, and we do try to hold them regularly. We have plans to hold them regularly. Thank you.
So Dr. Kabra, one thing that you would want the forum to keep in mind while creating a next step list, and integrating it into the patient care, what will be that one thing that you would suggest that you think from surgical, patient undergoing surgery and obviously the surgeries might not be the end of his treatment, from cancer. What is that one thing that you would want be the part of the patient care pathway?
It's not one thing, Dr. Vritti. What I would say is talk a little more to your patients. If you can talk, please do that. If your team can talk, let them do that. So there are small interventions that I'm trying to incorporate in my practice. Very small thing. I have told my nurses who take the patients in for surgery, I have told them, please ask the patient what kind of music they would like to listen to while they are in theater before being induced. That makes a difference. We also have evidence that music therapy works. So these are small interventions. I think we need to spend a little more time with our patients, understanding their needs. That is one point that I would say. Thank you.
Sure. Thank you.
Add to what Dr. Vedant just mentioned about the neuroimmunology. There's this hot area of science called psychoneuroimmunology. In fact, I think the first set of data came from our own study. This was way back some 12 years ago when Dr. Abdul Kalam was head of chief of DRDO before he became the president. So it was funded by him. It was very interesting. We looked at breast cancer as a model, and we ran a whole array of neuroimmune functions along with the psychological profile. And lo and behold, what we found was that patients who were emotionally down, who were using maladaptive coping methods, in them we found the natural killer cells, which is known to be the fighter cell, was low, along with the cortisol levels being very high and so on. And then in patients who were more emotionally more buoyant and more using adaptive coping methods, in them the immune system was more buoyant with the natural killer cells being very high. I think this is one step behind what Tata is doing now. They're using the intervention model to see how in patients who are low, how the immune functions would kind of, become more buoyant with the psychological as well as alternative therapy interventions such as yoga, meditation, and so on. So I think the mind-body nexus was always known, and we are reinventing the wheel all over again, because I think the grandmother's wisdom now is getting dissected in the lab. And to add to what we just heard is also the fact that I think what has happened in healthcare now is that from service we have moved to industry. So therefore we are oftentimes busy treating reports and we've forgotten the person. And in this person, the family member is always, now the care provider is known as the silent patient. They go through enormous amount of emotional difficulties. And in the realm of psycho-oncology, we just don't stop with primary care providers such as family. The service is now extended to professional healthcare providers. The burnout amongst oncologists is very well known. Suicide rate amongst medical oncologists is very high. This is bad news for you. So it's very, very high. So that's the current data. Originally, it was from the anesthesia team, they felt that the nurses and the anesthetists were going through, the suicide risk was high, but now current data shows it is medical oncologists. So what am I trying to say? I think mental health is important across the spectrum of cancer care. Nobody is spared because we all experience tremendous amount of burnout because we're taking in so much. It's a very toxic environment to be in, emotionally extremely toxic. So therefore, I think all hospitals and management should be very sensitive to this fact, number one. Number two, there is no revenue in this. I think we must make peace with that. This is a value add. There will be no return on investment. Your return on investment is intangible. If your patient compliance improves, if the dropout rates are less, your patients are tolerating treatment very well, then automatically it's going to impact outcomes. I'll sign off by saying this one little thing because there are a lot of young minds around who are going to be challenged very soon when they start working on their own and independently in various hospitals. Come March, this is a question I was asked years ago. What is the return on investment for a 10 by 10 room given? Psycho-oncology, what is the revenue generation? There wasn't much. So every time I reasoned, the finance team never understood. So finally, one smart thing I did, and I believe it's very smart, is that I went on to look at the records of how many patients had refused treatment. And post our intervention, when they were referred to us, how many people went back into the system for therapy. So I started looking at their bills, went to the accounts department, got their bills. Then the finance team asked me why I was doing this. I said, well, I have a presentation, therefore. They said, no. And I come up to something like 75 lakhs. They said, no, that's not the way to look at it. When they come into the system, not only they finish therapy, every follow-up, every diagnostics, there is a cost. And it came something close to 4 crores. So I presented this data and I said, this is what we bring back into the system. And that was the last. I don't think I'm ever called for any finance meeting. Why am I bringing this? I think it's very important for healthcare delivery system to look at these things as just a value add, which has tremendous amount of impact, not only in terms of patient outcome, but patient delight as well. And I completely agree with what you were saying just now. It is all about patient-related outcome now. No longer clinical trials are looking at what the physician is saying. Patient-related outcome doesn't stop just at quality of life. Just about everything about patient experience, right from physical symptoms to emotional, including financial toxicity. It gets factored. And that's the outcome that people are looking at. And mental health people are key players in this particular aspect. That's how even in clinical trials now, they want qualified psycho-oncologists. Thank you.
Thank you. I think, yes, our family physician friend is trying to say something.
So, building on what Dr. Brinda said, actually, almost if I remember right, I think you guys are more in the loop than I am. About 2 decades ago, the cover of the Time magazine carried an article. And the article is about the role of the immune system in health. And basically, if you look at our Indian medical system, which talks about, Vata Pitta, or you look at the Chinese system, which talk about yin and yang, and we talk about the sympathetic and parasympathetic nervous systems, these all tell us that there is something happening. There's a balance between these two systems, which really decides the well-being of a person. Why is a person very anxious? Obviously, sympathetic overdrive is there. Why is he very so dull and nothing? Because there's a parasympathetic overdrive. So having said that, what is happening is that parasympathetic, you have your ganglions there and sitting there, and your whole, something which controls your heart, your breathing, your circulation to your skin and your erector pili and whatever you have. Everything is controlled by these particular, your nerves, and also what they indirectly connected with your endocrine organs in the adrenals, and you're secreting more cortisol and everything that is there. And therefore, definitely it's going to affect your immunity, because it's somewhere these cells there are connected with everything else which is really part of your immune system, right? Which is, whether you're talking about lymphoid cells or wherever you are, it's all connected there, and it's going to cause this problem is going to occur there. Having said that, somebody mentioned about massage, for example, and how, acupressure and acupuncture. Now you see, I've always, people ask me, can I do acupressure, can I do acupuncture? And my answer is yes, always. Because the reason being is human touch is very, very, very important. And I said this to all of you who are working in oncology, my young friends who are here. See, just reach out to the patient, hold his hand, hold her hand, put your hand on the shoulder, hold that old lady's hand. You know, it makes a difference. It cures. It cures all the anger that is there, all the tension that is there, dissolves. And for nothing, you become a great doctor of an ordinary doctor.
I think, thank you very much. I would just want, I think, we can delve on the theory and the benefits. I think we don't have to establish it. We very well understand the benefits of what we are talking. I would not, and we could go endlessly, I know it. We are all passionate people about the subject. We can go till the evening on this topic and probably we are closing. I mean, my suggestion here and my, would be, let's just try to bring ourselves, towards the next steps. When I say next steps, so I am, again, the way I said, Dr. Parikh has already mentioned what's happening at Fortis. Dr. Brinda mentioned, and there were some very good takeaways from, I've just made notes of. Dr. Vedant Kabra just made a word, saying that, for example, understanding your patient need and making something like, giving him an option of music to his therapy room. I mean, let's just try to, and Dr. Keith said, integrating the outcomes, integrating the outcomes in the clinical, and doing outcomes, doing integrative oncology-based clinical trials, those kind of things. So, I mean, I'm just trying to get you all look towards what do we do? What is it that you've done or you've been thinking of doing that can further help us make this better, because again, we don't need now, at this stage at least, to this forum at least, we do not need to establish the need of it. It's established. And that is why we are all here.
Can I just say a little thing?
Yeah, sure, Megha.
Yeah, so just to set this conversation going, I feel we have to start, first thing is, as Dr. Kabra also said, screen. First important thing is screen your patients for psychological distress, and screen early and screen frequently for psychological distress, for physical symptoms, for nutrition needs, for spiritual needs, so emotional needs. So all these things have to be screened. I think that has to be the first step. How do we put that screening in our system, right? We may, start discussing on that. How are people doing it in different setups? How, at what point, and what's the point of contact with their patients when they screen for needs? If that makes sense, yeah.
Yeah, sure. Yes.
I just want, when the patient comes to us with the term cancer, itself gives them into psychological stress. So, and we don't talk in terms of normalcy and abnormalcy. Everything becomes abnormal for him. So let's make certain steps to make them understand, yes, it is a normal, everyone can have a disease, and it is just like any other disease. This can be taken care of. So the term our ancient wisdom use is the swasth, which is swayam mein sthit. So let's the person imbibe their own emotional intelligence and help them deal with their own aspects which they are dealing in their personal life, apart from what we are treating. As a doctors, we are more focused on doing. We want to finish the treatment, maybe chemotherapy, radiotherapy, or anything, but with that, there is certain normal life of that person which is getting affected to an extent. So we need to focus on that aspect as well. Simple thing like a functional capacity, if we know that the person is going for a surgery, if we prehabilitate that person for a functional capacity, that will definitely help him doing better after the surgery, and also make him or her self-confident in going into the surgery kind of setup. So that simple thing of being themselves is and helping them to do that, to reach that swasth on its own may help.
Thank you, Dr. Mumta. Dr. Parekh, you would want to contribute, so I'm just trying to get to the next steps, and we've spoken, again, if we have to get to the next steps and we have to start speaking to the patients, we all know it. We have to speak to the patients, we have to understand the need. But how do we get to the next steps here?
No, we get our basics right, start with the resources. I mean, all water boundary will be water boundary if you don't have resources. Right, an expert is an expert, period.
Absolutely.
Right. There is no other way to look at it. I started by saying that I completely endorse what you said. There is no question around this. This is a specialized area. The reason why at the start I said that we've started taking steps is because we have a mental health program in 27 hospitals, but a psycho-oncology program in 3 hospitals. Simple as that. I will not call it a psycho-oncology program until we have a psycho-oncologist. And that is the only way to look at this. And that's something we need to look at. If you honestly look at the referrals, so as to say, that will come to a mental health program from onco services or onco clinicians would be what? Delirium, right? Where you'll end up going and telling the doctor that kuch karna nahi hai. You wait for a couple of days or whatever it is, hyponatremia, metabolic, this, that, whatever. Occasionally it will be a irate family member who probably not get the psychoeducation required about the entire treatment process, so on and so forth. One thing that I liked what you said, I fundamentally believe that there are more quacks in the field of mental health than all fields put together. We win, hands down. And it pains me when I see, again, very similar thought process I have about support groups. I think we don't understand the concept of support group as a treatment intervention, and we a lot of times think it's some kind of a stand-up comedy show at best, or sometimes it's a musical and so on and so forth. It's therapeutic. I mean, there are defense mechanisms at play, right? So obviously from screening to what needs to happen has to happen, and a support group in absence of a mental health professional is at best a boardroom meeting gone completely wrong. That's what it is. And there's no point thinking about what are the steps. Step number 1 is get the resources, right? I'm glad you mentioned the numbers. Most people who look at numbers are right now not here, but I'm going to quote this one to them. But of course we will not be getting the so-called direct revenue. How is it even possible? I mean, at the end of the day, it's manual labor. I mean, you will see you'll do a consult for not less than 45-50 minutes. Sometimes it can go more than that also. It might be a family session which may last longer, and you are not just going to switch it off just because it's 40 minutes done. And if you have an 8-hour working day, which you don't, so if you have a 10 or 12-hour working day, what will you do? I mean, that's about it. And if you have X number of patients and Y number of sessions, if the math doesn't match, it doesn't matter. But there is quality of life, which is a differentiator. The fact is that, and that's why I feel that it just boils down to whether one wants to do something or whether we just have coffee table conversations which are boring. Because if you don't implement a thought process, at best it's a waste of time. So my thought, experts should be doing what experts are doing. We have now more and more experts coming out of our country in a specialized field. They need to be given the right space, and I think that's something which is very important. And then obviously you integrate. You integrate, it's going to be a learning process. If you ask me 5 years back, I did not know what a distress thermometer is. I didn't know. I've started psychiatry way back 97. I didn't know. A psycho-oncologist told me about distress thermometer. I said, wow, let's do it. And let's do it in all patients. And we realized that what were we missing out?
That's right.
That's the learning. Similarly for support groups, we need to understand, because you may have 20 people, one person got damaged because of the support group, nobody realized it. So all of this needs to be given an importance. Right. I think experts should be there. Leaders in healthcare and clinicians in healthcare need to be first people to embrace mental health in its all specialized and otherwise forms wherever they can. If they can't, then whatever is the alternative. Of course, we will never have enough psycho-oncologists for the next 100 years. Or we will never have next counseling psychologists for the next 100 years, and clinical psychologists or psychiatrists. It's not happening, it's 300% shortage. But then you look at the next level and so on and so forth. I think that's how it needs to be. And we will never have an ability to be able to see 100 on 100. But we'll need to figure a way to see the maximum that we can. There was a conversation around AI. I'm a very firm believer of it. At least in my...
Go ahead.
Oh, I'm so sorry. From the administrators to the clinicians, and they have to embrace it first and further guide us as to how do we, take around integration of palliative medicine, psychology, and everything taken together. Thank you.
Thank you very much, everyone. I believe everybody's been very patient hearing, and that's the essence. I believe the narrative needs to shift from illness to wellness, and that's what we are all discussing here. My name is Kausar Kidwai. I'm a non-medico, and I often wonder, what am I doing amongst oncologists, doctors, but I think this is food for my soul. I basically take the learnings from halls like these to the community. I'm more of a people's person. I build those bridges where lives can be impacted. I have worked extensively with partner governments across states, and one of the highest satisfying points in my life is when a very small number, which is around 2.5 lakh plus women, were screened for oral, breast and cervical cancer. And of the ones identified positive, we were able to offer treatment, leveraging new technologies, bringing down the cost of treatment, and effectively treat approximately 63% of these women, thereby saving a lot of financial burden on the systems. While we are actually talking about mental health and mental well-being, I would like to talk about how large or how big is this problem, and how Government of India is planning to take it up front. If we were to see, around 37% of India's population needs screening. And if you were to look at NFHS 5 results, only 1 to 2% population has ever received the screening. Government of India mandates oral, breast and cervical screening once every 5 years. So if I were to put this in numbers for you, approximately 51 crore people need the screening once every 5 years. And as Dr. Parekh rightly said, we do not have the means, and we are challenged by supply side immensely to be able to do this. We would need about 10,000 nurses screening day in and out to be able to screen around 8 lakh people per day, and we'll only be able to screen 50% of what is actually needed. So community-based screening programs, this is what is the mammoth target that is on us. Nearly 8 lakh people have to be screened to be able to accomplish the target. The 5-year patient burden in India is somewhere around 27.2 lakh patients. And of all that I present here, this is years of effort that we have been collating data, working very closely in the community to be able to drive impact. While we're talking about 27.2 lakh patients, the annual cost of treatment is somewhere around 32,000 crores plus. And that is what is the financial burden on our economic system. We do not have the bandwidth to screen, nor do we have the finances to treat. Do we need any further evidence to establish preventive oncology as a part of our systems? And that's what I'm going to talk about. Preventive oncology means the entire patient pathway alters. How do we do this? At all given points in time, we will have to differ from age stratified and move towards risk stratified screening. And this can be done with the help of artificial intelligence, technology tools, and as a company, Karkinos, I represent Karkinos, and we have designed an app, and we have put this app to test, and I would be very happy to share the results. This app basically works on socio-demographic, personal history, habits, lifestyle, family history, reproductive history, and clinical history. We are screening patients for 6 different types of cancers, oral breast cervical, prostate lung colorectal. If I were to put it in numbers, this is more than 40% of the cancers that men and women are actually combating with. The biggest problem is metastatic stage detection, and we want to protect individuals from getting cancer and catch cancer early. The study was actually conducted in a closed ecosystem where we could follow up with these patients, and these were the incarcerated women from the prisons in Bhopal and IVDP camp in Krishnagiri. This was part of Tamil Nadu. Approximately 3,200 women were screened, and everybody who was screened using the app was also put to a physical test. While we were using HPV DNA testing for cervical cancer, we used clinical breast examination by a trained physician and oral visual examination again by a trained physician. I would just like to walk you through the results of accuracy, sensitivity, and specificity values. I can deep dive into PPV and NPV, but just to talk about that the sensitivity of this particular app was around 38% for breast and oral, and slightly lower for cervical cancer because of obvious reasons. What needs to be done is it helps us stratify patients who have any kind of history of the disease, any kind of symptoms of the disease, and it predicts using artificial intelligence. What we actually need to include in this are germline mutations, some kind of diagnostics tests, and also sharpen these tools further so that we are able to risk stratify to the best of our ability and then take this conversation forward. I will pause here and try and answer questions if you have any. Dr. Kaur.
Pretty low even for oral and
Absolutely,
breast
sir.
cancer.
Absolutely. So, sir, the idea is more to include genetic testing as a part of the regular screening protocol. And as I said initially, that the narrative needs to shift from illness to wellness. Right now, we are exploring how wellness can become a component in Ayushman Bharat, because there is a cervical cancer component for pre-cancer dysplasia, wherein women are treated using ablative and excisional procedures designated at a specific amount. However, given introduction of new technologies like ablative services, the cost of treating has gone down by 1/4. So there is the window of allocation where approximately 2,000 to 2,500 rupees can be allocated to wellness in Ayushman Bharat. And if that happens, along with this test, along with this app, we can also feed in data for the evaluation results of, say, breast sonography, or HPV DNA testing, or say other kind of tests that are available, and then we can predict the average low or high.
So, agree there. But since this is for general population, I don't think we can include genetic testing in that. I don't think so.
We have done this.
Maybe breast screening, imaging by mammography or ultrasound, mostly mammography, HPV DNA or a pap smear or a liquid-based cytology, but not genetic screening for population. That's a big Pandora's box which will open after that.
So we were working very closely with the HIV cohort and screened more than around 2,500 women. The positivity that we observed was as high as 34%.
HIV is very different.
Yeah, I'm just talking about different cohorts.
HIV is very different, and I'm sure you were screening high-risk groups.
Definitely,
right.
sir. So right now, this is a community.
There are clear-cut definitions for high risk of HIV.
Absolutely.
Right? It's not there for cancer for general population.
A lot of work needs to be done so that we can sharpen these tools further, which will be a mix of...
Akriti, I'm sure, wants to comment on this.
Yes, please go ahead.
She's smiling.
Please go ahead.
So like he said that we cannot measure genetic testing with the wellness program for the general public, because like she said, it brings in a lot of distress, right?
Yes.
We're still having a lot of myths that we need to bust. And this is why genetic counselors actually add value to the entire integrative oncology and integrative healthcare, right?
Sure.
So I always tell my patients and in general clinicians also that we very casually say breast cancer patient get a BRCA done. But you don't know what goes behind that lady's mind. She must be thinking of her children. She must be thinking of her siblings. She must be thinking of all the ex-family members that she's concerned about, right? Maybe herself. Maybe she has some major milestones in her life to achieve, right? That is where psychology comes in play. And since I have been a part of Fortis, actually we've done this, that the psycho-oncologist and the onco-psychologist and the genetic counselors, we actually go on the rounds to see the actually daily practice of the daycare and the wards as to what the patient goes and what the actual patient needs, like Dr. Kabra mentioned, that we need to really understand what the patient needs. That is on the treatment side, but when we go on the prevention side also, whenever the patient comes in the clinic, we actually tell them that this is not the end of the road. This is where you actually begin. Because when you know that there is a high risk, or you may need screening or surveillance, you can actually detect something early. And we always press on the fact that early detection in cancer can actually save a lot of distress, can actually be very cost effective, and obviously less burning out for the caregivers also.
Yeah,
So
I totally hear you. I've been on both sides of the table.
Yeah.
Ma'am.
Simple screening. There are so many barriers to cancer screening itself. I don't think we have beaten it completely, because even in a normal hospital kind of setup, when we encourage families to come for regular screening or even a health checkup, they shy away. They don't want to go looking for trouble, as they say. So therefore, genetics right now for prevention is a far cry. And it's not even affordable. Let's face that straight and square. As it is when we talk to cancer patients and their families who are at a high risk, for any genetic testing, they're already depleted of enough funds for their therapy. So with the normal population to kind of, I don't think we have arrived there at all. Besides, even if you do find something, do you have solutions? Because any investigation, if it does not translate into meaningful intervention, I don't think we should even go down that road.
No, I think
I'll answer that, ma'am.
history-based
So
risk
I'll answer that
stratification.
I just wanted to say what Dr. Brinda has already said, and I'll give you an example. I have seen a prescription myself of a lady who had breast pain, went to a physician, no family history. The advice is get BRCA1 and 2 done. What is this? I don't know. So
No,
please,
no, I
please
just
don't get into
mean
genetic.
that. I'll just take 1 minute and explain. I don't mean to support this with any kind of genetic testing. No, please, I think I've been misunderstood. This app is only used to risk stratify in the community where both supply and demand side is met and all systems have been built effectively, which is why I mentioned that this was carried out in a closed cohort setting where people, there is minimal loss to follow up. I will just supplement this with an example, ma'am, please allow me a minute. The ASHAs and the ANMs, the field level workers, do community-based assessment on the ground. This is a Government of India initiative where we risk stratify and segregate population. This is exactly a technology tool to conduct a CBAC, including more potential cancers and assessing the risk for other diseases to be able to be conducted effectively on the ground, where one ASHA worker goes door to door and may just cover about 10 to 15 households. Through this, you can cover at least 8 patients per hour. That is how quickly you can risk assess, number one. Number two, when you risk stratify, you've identified a cohort with a particular disease. That is, and I'm not saying that cohort has a particular disease, that cohort is subjected or may be prone to getting a particular disease, which is when the first consultation on lifestyle, on nutrition, everything comes into consideration. And our ANMs, and we've done this in the state of Madhya Pradesh, where right up to primary health care, they were trained on screening using for oral, breast and cervical using VIA, which is visual inspection of acetic acid, and patients identified positive were then connected to the next level of care, and treatment or diagnostics was available right from the community health centers, CHCs. So this is just helping the ASHA worker conduct risk assessment or a community-based assessment quickly so that we can actually reach out to the population. And this is a double-edged sword. While it is risk stratifying, it is also making the other individual aware of the signs and symptoms associated with a particular disease. I'll pause here.
Yeah, I think to add.
Ma'am, this is free of cost. The app that I'm talking about.
Yeah. Testing.
You mean the clinical breast? This is all done by the staff nurses in the government sector.
Yeah. I think, yeah, I think.
Absolutely. 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 Sir, no, I think there was a communication error there. I have been on the table on both sides. I am not talking, I actually understand how difficult it is to experience or to be a caregiver. So I'm not at all saying that genetic testing should become the norm, new norm, no. No.
True.
So, Dr. Kabra, just a thought on this, and I'm with you on genetic testing because psychiatry is also, we are also getting a lot of this. To be honest, we are exploring some, but I've kind of split this in two parts. Part one is this whole predictive illness business, which is a very, very, very dicey thing. And here I speak in the psychiatry domain. I'm just coming out of the psycho-onco just to give you a perspective. The last thing I want is somebody getting a genetic report today saying that you have an X% chance of having schizophrenia. Matlab, this is the hell break loose. So I get it. So all the people that one has talked to in the last few months, so I've kind of, in my head, split this in two parts. This first report, nobody's interested, dare you do it. The second one, yes, I think we'll reach somewhere, like how, can you choose a medication because of the genetic environment of the individual and reduce the trial and error method, which is largely also a part of psychiatry intervention. I think that's something there. The only thought that comes to my mind is that we'll keep on evolving and we'll probably bring out both our best and worst, and all our best will bring out our worst, and that's how humankind just ends up doing what it does, like what we did to social media. But I think all of this will have its own place. It will only be at the right time is what is important. And once we come to the general population, we need to have a lot many ticks in the boxes. I think that's the only thing which is coming from from what they are also saying. A lot of ticks in the boxes need to happen now, whether it is what percentage success do we have, is it even worth doing it, more importantly, not just cost but even the psychosocial impact, and is it predictive in the true sense? So what part of predictive actually helps in intervention, something that, my teacher told what you were saying, that, prescribe a test only if it's going to change your treatment. If it's not going to change your treatment, what's the point of prescribing a test? So old school thought it was there, but not to say that tests have not happened and more tests are not happening and more will not happen. So certain aspects of science is beyond us, it will happen. But so yeah, I thought I'll just put in a word from both sides.
Yeah, absolutely. I think, when we speak about genetics, there's also epigenetics and nutrigenomics. So much research is coming, and even the Indian genome, they haven't really coded. So how much importance are we truly giving to the results of the SNPs, which you're seeing on the genetic profiling? That's one thought. And we know, right, like look at the BRCA gene. Not everybody has this gene, nor does everyone with the gene actually end up getting cancer. So there is something in the environment, or there is something which is, it's like the trigger, something is pulling the trigger, which is, genes are not your destiny. That's what they say these days. So I think we also need to emphasize on what is triggering lifestyle. You also mentioned that, the carcinogenic burden, maybe environmental toxins. There is something, let's look at NET, the neuroendocrine tumors, for example. About 25 years ago, I've been doing PET scans, both in here in India and in the US. We never saw, it was like less than 5% I think, the statistics. Now we are seeing so much, and there is some kind of a correlation. The neurocrine disruptors, the plastics, the bisphenols, there is so much carcinogenic burden coming in also maybe from the hormones coming in from the animal industry, the food industry. These are things, I think, which is kind of getting missed, where we are looking at why is cancer burden increasing and what can we do lifestyle-wise or prevention-wise to actually trigger these genes to go berserk, and that's my thought on this.
So in the month of August, I attended a 3-day workshop, a 3-day conference on this topic.
3-day conference. We can't finish it right now. But yes, very valid points, and we need to look at epigenetics also when we talk about preventive oncology. I think what Kausa was trying to arrive was, obviously risk stratification is very, very important at this point in time. We need to understand, and it's not going to be a one-time exercise for one individual, it's going to be a routine exercise for an individual, so that he could read his, one is from the family history, one is from his own, disease or, symptom pattern, what is he exposed to. So I think risk stratification will always play an important role, because that helps on mass as well as in a localized population from both the perspectives. How many of them can be exposed to genetics and genetic testing, and who takes the burden of the cost? I think at this point in time it is too much left for the individual choices to be made till we get some more regulatory norms around it, and to be able to, the way Dr. Parikh said, too many boxes have to be ticked before we say we have a norm to make. Internal milieu, very, very important. Prehab, rehab, so a couple of takeaways, and before I go to summarize it, yes, I would just the last comment of the question.
Madam, I have a lot of objections to what was said so far. Why should the lady, A&M go, lady health worker in the village go, and subject these women to what she's talking about, looking at their cervix, painting with acetic acid and saying, like you need a colposcopy, you're precancerous. Or go and subject a woman for a breast examination and tell her that, she needs to have this and that. Why don't we go to the men all over the village and ask her to insert a finger in and say, your prostate is big, you need to have a prostatic, whatever test you need to do, or you've got, colonic cancer. Why are women subject to this? How many men out here who prescribe mammograms? How many men who prescribe mammograms have had mammogram
have
themselves?
To go, I'm so sorry, I will have to pitch in here because we'll go absolutely off track. This is all based on incidents.
This is important, madam, because this is the summit we are making a consensus. And it's important not to put it under the carpet. It's important to talk about these things.
Nobody's putting it under the carpet, please.
Yeah. Let me answer that. See, this was a Government of India launched program for easily detectable and common cancers. Cervical cancer is a big problem. Breast cancer has become #1 cancer across the country. Cervical. Sir, just a minute. I'll tell you, sir. Just let me finish that. Oral cancer, they're examining men. Yes, the finger is being inserted in the mouth and not in the rectum, as you suggested. Prostate cancer is not yet a big problem. Colorectal cancer you can't detect just by finger examination. You need a scopy examination, which is lacking in our country. It should come. I agree with that. But this is only a pilot project started by Government of India, directed at 3 cancers, which are currently a bigger health problems according to them. Which is true. Oral cancer in men is the #1 cancer. So they are examining both females as well as males for oral cancer. Breast, 99% of breast cancers are in women. So women are being examined, right? They can't be examining men for finding that 1% cancer. So that's why they're not asking them to do mammograms or examining their breast. So no offense here for anybody. That's the reason. Lung cancer is important, but you can't you can't diagnose them by chest X-ray. CT scan is recommended only for high-risk people. And again, now we are seeing patients who have never smoked coming with lung cancer because of pollution. So that means whole of Delhi needs to be screened because they are all at high risk. Anybody living in Delhi today is smoking 20 cigarettes a day. But you can't do that. The government doesn't have resources, unfortunately. They're not able to screen for common cancers. So we can't expect it, very honestly.
Thank you, sir. And we'll let Vriti have the last one because it would be nice not to miss flights. Thank you.
Thank you. I think it was a nice, a very interactive session with the way it was supposed to be. And I think we can't, again, we are dealing with problems. We are trying to get to solutions. Now we can't create a problem to find a solution. So yes, not brushing under the carpet, but yes, we have to go with what needs attention now and focus on that. I think what needs attention now is having having preventive risk stratification, preventive testing, part of norm, which it is already in terms of screening tests happening in the hospitals. But the idea was, how do we make it more robust? Epigenetics is a very, very important aspect, and I think we have enough material now on social media. How do we make it part of life? Again, I think there's a lot to do in that space, and we can have a specific conference on that. Coming on to the integrative oncology part of it, as I think Akriti said, and from the genetic counselor standpoint to the nutritionist standpoint to the psycho-oncologist standpoint, being part of the integral patient care so that they are able to understand the pulse of the patient's need and being able to, because there will be no size that fits all, specifically in psychology and diet. These two things, specifically, there will be no size, and again, genetics, no one size will fit all. Customization will have to be the key here. Getting to understand our patients stands the most important thing. And when we say patients, I think we understand the caregiver, the secondary caregiver as well. And I also very well want to include one more point that Dr. Brinda said, and that is the volunteers. Now, these volunteers are, this is also could be a double-edged sword in itself. If the volunteers are not screened well, and if they are not capable enough, in terms of their, and I think more and more institutions are now getting to a curriculum that the volunteers should be undergoing to be able to volunteer for the kind of work. Because, medical oncologists going through depression towards suicide, what about the volunteers, And again, if they happen to guide wrong, we are all into trouble. That one patient, if we lose just because of a wrong guidance from an incapable or unskilled volunteer, we've had it all. So, and I would also just, so I had read recently something which was very nice. That was called I think it's done in the Cleveland Clinic. They called something called Fourth Angel Program. Now, Fourth Angel Program is, and they have a whole Fourth Angel mentorship program. There was this skating gold medalist who underwent cancer treatment. He was a young sportsman who was undergoing cancer treatment. He spoke about 3 angels in his lifetime, and he spoke about what the 4th angel he missed in his lifetime. So he spoke about, throughout his cancer care, he spoke about the first angel, which was his doctors, his primary doctors who were giving him care. The second angel he spoke was about the nurse, the paramedics, the psychologists, everybody around giving him support. Third angel, he said, was his friends and family. And fourth angel, which he missed, was somebody who had gone through it and could help him hold his hand and navigate it. So, we can't undermine the importance of those volunteers. If, as a takeaway from this conference, if we are able to build that mentorship program for those volunteers and ensure that every hospital that we all are part of, and we are having able volunteers, I think that would be one takeaway, apart from, in addition to the resources Dr. Parekh spoke about, Dr. Brinda spoke about, capable, skilled, this is science. Again, it's all science. So psychologists, resources in terms of palliative medicine experts, resources in terms of rehab to be able to cover that, and genetics, of course, so I think resources plus this, if you're able to put it all together, I think for me, these are, and again, in making it all integral part of the patient clinical outcomes. And, I think in our next conference, it will be my dream come true if 2 years later in this conference, which Fortis Cancer Summit, we are talking about patient clinical outcomes, which are reflecting the quality of care because of the integrative oncology support, plus all the technology that we are building in, all medical, surgical, radiation, oncology standpoint, all put together in front. I think that will be something that we should all together gun for in 2 years' time. We should start with clinical outcomes, and that will cover it all. Yeah, absolutely. Yeah. And I think we have Dr. Keith Lim's support, and I think, and it can't be just by sheer chance that Dr. Keith Lim is here. We should build it together, so. Thank you all.